Right. Good morning, everybody. I know that you have had a terrific dinner yesterday, and I'm very sorry I missed it. And that's perhaps why we are not starting more punctually. So this session this morning will be dedicated to immune vascular mechanisms in these post-viral syndromes, and we will have a mix of talks discussing neurovascular changes associated with these diseases, as well as some immune mediator or immune changes in this disease. And the first speaker is Michael van Elzacker from the Tufts University, and is a neuroscientist at the Massachusetts General Hospital and Harvard Medical School, and co-founder of the Polybio Research Foundation. He will talk about his lab's research program on neuroimaging of infection-associated diseases. Michael, if you're ready, thank you.
Okay, thanks everyone. And how do I get this to go here? I don't know if the slides are up or what's the scoop. Okay, so thanks everyone for being here in the morning, and thanks so much to the organizers for all the work that you've done to pull this together and inviting me, even though I don't speak Portuguese. I appreciate it. So I'm going to talk a little bit about cognitive function and neuroimaging for neuroinflammation in ME, CFS, and long COVID. So I'll sort of stretch across both conditions in this talk. So we wrote a review article a bunch of years ago that sort of got into the mechanisms and the methods of studying this topic. And so some of what I'll be talking about today is an effort to sort of make that happen. So I think everybody knows that when long COVID came up in sort of in the public, it took a lot of people by surprise, I think. But for a lot of people in this room, it unfortunately wasn't surprising. We sort of knew that there are consequences that can happen for some, subset of people who experience an infection where they don't fully recover. So Amy Proal and I wrote a review article at the time to try and prevent the, this is some big mystery, we don't have good leads type narrative from taking big hold. And I think it stood up pretty well. And, some of what I'll talk about today sort of gets at some of the questions that we were addressing. So this is just an overview of some of the stuff that we're doing in the lab. And basically everything except for the fibrin PET imaging we're doing on both pre-COVID, pre-2019 ME patients as well as long COVID patients. So we've done our best to sort of use the infrastructure and kind of funding bolus that came with long COVID to study people that were sick before 2019. A lot of the times it's relevant. I don't think it's the same thing. So I'll just start off by saying that. I think that there are shared mechanisms. Surely there must be, because there are shared symptoms. But I don't think it's precisely the same thing. And I think that is long COVID and pre-COVID ME. And I think that that's an important task for the field to figure out what things are similar and what things are different. And we ought to be doing sort of precision medicine in that way, I think. So I'll start off by talking a little bit about this paper here. That we put out a couple of months ago. And, this is a study of neuroinflammation in long COVID patients. Essentially we tried to, get this paper out a little bit quick. So we used pre-COVID controls that were already done in the same scanner with the same basic protocol. And what we did in this project was to study a form of neuroinflammation. So microglia are the resident macrophages of the central nervous system. So when you look at a brain, a significant number of the cells you're looking at are microglia or other forms of glia, which are neuroimmune cells. Glia means glue in Greek, sort of a pejorative where they thought, originally that they were just scaffolding for neurons, but it turns out that they're much more important than that. And they're innate immune cells. So when they come in contact with pathogen-associated molecular patterns, whether it's a full pathogen or an antigen, or when they come across neuroimmune mediators such as pro-inflammatory cytokines, they actually activate, they change form, and they sort of withdraw their arms, and they take on this sort of thicker form, and they release a bunch of mediators. That includes glutamate itself, which is, of course, the main neuroexcitatory neurotransmitter, as well as other pro-inflammatory cytokines, all kinds of things, prostaglandins, ATP, bradykinins that excite neurons. This, of course, can disrupt the normal sensitive signal-to-noise ratio of neuronal signaling. It's important in the short term, but at the long term, it can become problematic. And it also releases what's called the translocator protein, or TSPO. And this is what we're able to measure with PET neuroimaging. To be fair, immune cells, peripheral immune cells, also upregulate the TSPO protein. And so the signal that we see in the brain can and probably is sometime immune cells that are penetrating in from the periphery. So in this study, we were looking at 12 adults with long COVID, mostly non-hospitalized, mostly pre-Omicron, mostly pre-vaccine. And these are patients that qualified for a modified ICC criteria for the MEC. Have someone with long COVID and that's about it. That's possible to have, right? So we were looking at this sort of sickness syndromic manifestation, and we have additional controls going, but this is 43 controls from the scanner before COVID. So sort of a standard PET protocol using what's called the PBR28 radioligand. The translocator protein used to be called the peripheral benzodiazepine receptor, so PBR. So this is a radioligand that binds to that protein that we're interested in. And as it does, because it's radioactive with really rapid decay, it will release protons right there where it's detecting the neuroinflammation, and we can localize that. And this is just some statistics of the PET analysis. So this is sort of what our results look like. And this is a statistical map showing the regions of cerebellum normalized signal that were greater in the long COVID patients than in our 43 pre-COVID controls. We extracted a whole brain signal, and this is what the whole brain signal looked like. I put the two you probably can't see it, but I put the two hospitalized patients in open circles just to show that it wasn't the case that those were the two most extreme patients. So you see kind of a diversity of signal in the patients and in the controls, but a pretty solid split between the cases and controls. We wanted to see if this was driven by a particular area. So these are sort of the brain regions that were activated in our long COVID patients greater than controls. We kind of saw that the signal was somewhat associated with areas where there's a bit of a window in the blood-brain barrier. So for example, at the roof of the ventricles, right below the corpus callosum, there's a little bit of a window in the blood-brain barrier, or circumventricular organs. I wouldn't want to overstate it, but we sort of saw a signal that was consistent with that. So we extracted data from the different regions, and it didn't seem like one region was really driving the effect. So it did seem to be sort of all over those regions. This is the just as an example region, this is the subfornical organ. So it's one of the 7 circumventricular organs that naturally, normally in everyone, has a diminished blood-brain barrier. The circumventricular organs are really rich with ACE2 receptors. And so we thought maybe that was part of the story, and maybe that mattered. Here it is, it's number 3. And so we thought, okay, if we're getting signal here, then maybe it's the case that there's, you know, something in the blood that's at least contributing to this, because this is the place where the brain sort of communicates with the blood, or one of the places. And so we did a bunch of measurements of blood that we took immediately before the people got into the scanner. And we found that 6 different mediators correlated pretty well. You know, I think it was Massimo yesterday that was saying they only had a 0.7 correlation. Usually in biology, that's really good. And sort of surprising. So we, you know, we found a 0.7, moderate to strong correlations. For example, this one up here on the left is SL-selectin. So that's an adhesion molecule, meaning that it is expressed on the vasculature so that it pulls in immune cells that are rolling through the blood. They attach to the vasculature and get drawn in. So that's where that, you know, assertion that our signal may be penetrating neutrophils as well as the resident macrophages or other glia that are in the brain. And fibrinogen, of course, the Riccia pretorius's group, you know, works on this cascade, and we found that it correlated at a 0.8 with the whole brain neuroinflammation signal. So our next step that we did was to use COVID recovered controls. So these are all people that had COVID and report feeling fully recovered. And this is showing signal that's significant in the brainstem. So the signal location did sort of move downward, but it's still what we would call subcortical, sort of a little bit of a diminished blood-brain barrier. It's not the case that I can just look at a scan and go, there's the long COVID patient. There, you know, the neuroinflammation is there. There's a split where in our data as of now, the long COVID patients are largely at the mean of the controls or above, but you really can't just look at a scan and diagnose. And I think that's true in these diagnostic labels of long COVID and ME/CFS and the infection-associated chronic illness. There are, at the group statistic level, these biological factors emerge, but you know, it's really not just a biomarker that you can just look at and say there it is. So we also have, even before COVID, we tried to have this study sort of rolling and we got it shut down, but then back up again. So we have pre-2018 ME patients, which obviously onset was not COVID-19. And we found a signal as well in a region that we predicted ahead of time called the anterior mid-cingulate. So cingulate gyrus goes right above the corpus callosum there. It means belt in Greek. It wraps around the corpus callosum like a belt. And I'll come back to this brain region because I think it's important for the symptom of brain fog. Again, you can't really look at the scan. If you look over at the data, you can't really just look at the scan and say, there's the ME/CFS, you know, but it really is the case that it splits out at a group level. And we also found brainstem signal there. I think this is where the idea that maybe not the same thing is driving, but there are shared pathways that lead to shared symptoms is kind of how I think about it, right? So there are probably aspects that you can sort of attack across patient groups if you're going to manage symptoms. But if it's really being driven by antigen, or if that's a component, you have to address the antigens. That is a specific approach as opposed to a non-specific approach. This signal, by the way, is a little bit more similar to what Nakatomi found in 2014 with an earlier radioligand and what Rodmakers found. Rodmakers did not find in 2021. And, you know, they did a good job in their study, but they were using patients that had been sick for a really long time. It was all women and all sick from Q fever. So those may be some of the reasons that, you know, they did not replicate what other groups have found. So I want to talk a little bit about the symptom of brain fog and the idea that these are, overlapping symptoms across the different drivers. This is a really common non-specific symptom that, exists, in all kinds of things. Almost everything really has at least some aspect of brain fog in some patients. So the way that we approach this is to try and get at a really fundamental aspect of cognition, which is called top-down cognitive control. So the idea is that if you were looking for a friend in a crowd who was wearing a red shirt, you would be focused, you have a goal, and you're ignoring extraneous things on purpose, and you're focusing in on something on purpose. That's called stimulus-driven or top-down cognitive control. And it's a really fundamental aspect of cognition. So when I'm searching my mind for someone's name or phone number, it's largely the same circuitry. So there's my friend with the red shirt that I found. But if suddenly a red balloon floats up, I wasn't looking for that, but it's going to capture my attention whether I like it or not. That's called bottom-up attentional capture, and it's actually a different circuit. And it's an important part of cognitive control, is to maintain focus on what you're doing while you're ignoring things that are happening around that are not important to you. And I think that's a lot of what the patients kind of deal with, is a struggle. Lights and sounds and those sorts of things are really sort of distracting. There's a sensory component there too, but some of it is cognitive as well, I think. So when that happens, you sort of lose focus on the thing that you care about and end up having your attention grasped by the thing that you weren't actually focusing on. Well, it turns out that that's largely held in place, cognitive control, by that region that I mentioned earlier called the anterior midcingulate. And this is a meta-analysis, so pre-COVID meta-analysis, just studying the effects per se of inflammation on cognition. So this is a combination of 24 different studies, 400 plus patients who either had interferons injected or lipopolysaccharide, or even just had blood extracted and they measured inflammation. And up there at the top is that anterior midcingulate. It's part of the sickness circuitry. So it's an area that's affected by inflammation. It turns out that, and that's that anterior midcingulate. It turns out that you can study it really directly with a task. So this is a task that was developed by my PhD mentor, Lisa Shin. It's a really interesting brain region because it's both important for cognitive control and sensitive to inflammation. So the task that can address this region is called the multi-source interference task. And it reliably activates what's called the top-down attentional circuit that sort of holds control despite the fact that other things are happening in your periphery, whether it's periphery literally in your visual field or cognitively as well. So we used a dual PET MR scanner, even for the data that I've showed you already. They were in an MRI scanner that has a PET insert, which allows us to do multiple forms of neuroimaging at the same time. So we're able to do an fMRI task while we're collecting the PET neuroinflammation data. So the multi-source interference task, like other tasks in fMRI, we have a little MRI safe joystick basically that's down there in the lower right. And the way that it works is you place your fingers on it, 1, 2, 3. So if you kind of put your hand up with your palm facing me, 1, 2, 3, that's where the button box, the numbers on the button box are. And the way that the task works is you pick the numeral that is different than the other numerals. So for this one, you would pick 1, right? For this, you'd pick 2. For this, you'd pick 3. For this, you'd pick 3. Now that's hard, right? That's the interference condition because your finger position wants you to choose your number one finger, right? So you have to override that. You have to override what's called the prepotent response. And this is a real reductionist way of getting at that mechanism of cognitive control. It taps into that same circuit that we care about. So let me just give it to you if you want to put your hands up at about the pace that they get in the scanner. So that's 3. 2. You can see how much easier it is when it's like that. So, and what we do is we compare the non-interference to the interference, and everybody, healthy or not, will have more activation of this circuitry in the interference condition. And the question is whether patient groups need more real estate. They need more brain power to complete the task. And it turns out that yes, they do. So this is long COVID patients. Essentially, it's a pretty good split in the data where they're able to complete the task. It just takes more brain effort, essentially, to complete the task. And so what I've done next is to show you an overlay. So this is that MECFS group pre-2018. This is the anterior mid-cingulate of, in this case, I'm showing you 9 controls versus 7 patients. And that's that anterior mid-cingulate. And now I've overlaid, if you can see the blue, that's the task. That's where the patients, in this case, MECFS patients, needed more activity to do the task than the controls did. So we're going to put together the full story. This is sort of showing the concept that we're working to get at. So what we're doing here is showing you that it's really that same region that's affected by inflammation that's important for cognitive control that is affected. It really overlays really well. And that's that anterior mid-cingulate. So another thing that we found from another ongoing study, this is a study, a separate study that uses EEG as well as fMRI in patients, again, long COVID and then pre-2018 MECFS patients. Here, I've combined the patient groups, again, not because I think they have the exact same thing happening to them, but I think the symptom expressions are the same. And what we're seeing here is delayed phase index. So that area of anterior mid-cingulate ought to be kind of pulsing with activity at the same rate as a region further back called the superior parietal that holds cognitive control as people are holding a task. They ought to be sort of turning on at the same time. The brain waves ought to be aligned. And this is showing what's called the phase lag, which is sort of a common thing that can happen in problems with cognition. And you're seeing basically a delayed phase in the MECFS combined with long COVID patients. We'll split it out. This is like hot off the press type data that we're in the middle of. And interestingly, that lag anti-correlated with the MCIT task performance. So in other words, they did sort of worse on the task, moderate correlation, 0.45, but significant. So it's the task performance. Okay, so that's anterior mid-cingulate. I'm also interested in, oh, sorry, I forwarded, this is that correlation, the anti-correlation between the phase lag and the MCIT task performance. So we're also interested in the brainstem as a region we think is important in these conditions. So if you look at that meta-analysis of regions that are affected by inflammation kind of per se, brainstem is all the way over there on the left. And it kind of makes sense. This is where the vagus nerve enters the central nervous system. So vagus shares the same Latin root as vagabond because it wanders all over the body. It detects small amounts of inflammation. This is why you can be sick in the lower left lobe of your lung and have a full body response, despite the fact that cytokines are, basically kind of mid-sized proteins that don't easily cross the blood-brain barrier. So the vagus nerve acts as a diffuse sensory organ that detects inflammatory mediators and signals, hey, brain, the body is sick. So for example, if you inject a rat with something like lipopolysaccharide, broken up bacterial cell walls, the rat will act sick. It won't socialize, it won't run on a wheel unless you have cut the vagus nerve. And then the brain doesn't know that the body is sick. There are still some aspects of the sickness response that will get communicated, but some won't. And so, we're real interested in whether the brainstem can be sort of an on-ramp where, different forms of stimulation provocation, including physical compression with CCI patients, might be driving symptoms that overlap. Again, that drives the sickness response that makes people sort of feel really tired and worn out and in bed. And I guess let me just take just a real quick second here. Sorry, let me get here. The NTS here over on the right is the nucleus of the solitary tract, which is where the vagus nerve enters brainstem. The nucleus ambiguous just below is an outgoing nucleus that, for example, problems there would lead someone to be vulnerable to tachycardia. Ventrolateral medulla and dorsal motor vagus are outgoing autonomic control regions. So problems there would lead to problems with autonomic control. And then the DRT down below is the dorsal reticular nucleus, which receives from the periaqueductal gray, that's inflammatory pain. And so problems there, sensitization would lead to an increased sense of pain. And that circuit, by the way, is sexually differentiated, where it's more sensitive in women. So what we did was to extract data from the brainstem using magnetic resonance spectroscopy, which allows us to look at the chemical content of brain tissue. And we found that in both the long COVID and the pre-2018 ME/CFS patients, there was reduced N-acetyl aspartate, which is a marker of sort of metabolic health in brain tissue. Again, I can't just look and say there's the patient, but this is where sort of dysfunction happens. And let me just go kind of real quick through the next couple of slides. So this is hopefully an animation. Yeah. So what we did is to take live neutrophils. We didn't freeze this blood. The cells are still alive, and they're swimming into a little well to get at bacteria. And what we found was that the ME/CFS patients had a higher proportion of cells entering the wells than the controls. The long COVID is just a trend at this level, although it's probably underpowered. So evidence of immune activation. Again, that's the innate immune system, which means that there's a shared response despite potentially non-shared drivers. And then we gave our participants a wearable sleep device to wear the 2 nights before they came in for the scan. And as you might guess, found reduced sleep quality in the patients versus controls. This is a measure of fragmentation and periodicity. We also do pupillometry, where we, in a darkened room, sort of put this device up to someone's eyeball, measure the diameter of the pupil, and then flash a quick light to see the contraction. And in this case, the long COVID patients have a reduced initial diameter relative to both the ME/CFS and the long COVID groups. So this is one area where the long COVID and the ME/CFS are not the same. And also the end diameter after the constriction. This is an area where the ME patients are different than both groups, which is constriction velocity. The velocity here is sped up in the pre-2018 ME/CFS patients, a little bit like a concussion patient. And this is the max constriction velocity. So I just want to thank my lab, who does a great job. The patients are really generous in coming in. We're not even trying to get them better, but they all report having a good experience. And that has a lot to do with my team. So thank you very much. Do we have time for a question? Or okay, I think I do.
Right. So the next 2 presentations will be remote, and it is my great pleasure to introduce the next speaker, with Carmen Scheibebogen from the Charité in Berlin and the Institute of Medical Immunology at the same institution. And besides very prolific work in this area, she was in the forefront in building resources that are helpful for the entire community, namely a biobank and an infrastructure that may serve now clinical trials. So, Carmen, it is a great pleasure to listen to your talk.
Yes, thank you very much for the invitation. And I'm very sorry I cannot be with you today, as unfortunately there are 2 other conference presentations in Germany this week. So November is really the conference month. I hope you can see my slides now. And I'm going to talk about autoantibody treatments for an CFS and long COVID. I will try to leave some minutes at the end for discussions. So to my background, I'm a clinical immunologist. So we do both taking care of patients with ME/CFS, but all the other forms of post-COVID and do research. And so I'm going to talk about evidence for autoantibodies we and other groups have so far, and the therapeutic trials which are ongoing to target autoimmunity. This is actually from a review we published within the Euroimmun group in
Carmen,
Yeah?
may I suggest you press the slideshow button so that
okay.
we'll...
Yeah, so thanks.
Thank you.
Okay, yeah. And at that time, we had already evidence that immune dysregulation plays an important role, autonomous dysfunction, and also metabolic dysfunction. And fortunately, during the last years, we learned more details about these mechanisms. So we have good evidence now that autoantibodies do play a role in a subset, at least, of ME/CFS patients. I'm going to show some data on the G protein-coupled receptor antibodies and neuronal antibodies. We have good evidence for ongoing, at least low-level inflammation, heightened immune responses, and also neuroinflammation. As Saka just showed, we have evidence that there is association with EBV reactivation, also in COVID. We have evidence for autonomous dysfunctions, typical sympathetic overactivity with vascular dysregulation, orthostatic intolerance, and microvascular hypoperfusion. And we have evidence for mitochondrial dysfunction resulting in impaired energy metabolism. And we also have quite good evidence now how this is linked, and we think that hypoperfusion is probably a central problem in the end, which can well explain many of the key symptoms, brain fog, fatigue, and also the post-exertional malaise. So what we've learned during the last 5 years about long COVID is that it's really a complex clinical picture, and also regarding the pathomechanisms. And we have a subset of long COVID patients that fulfill the diagnostic criteria for ME/CFS using the Canadian consensus criteria. These are approximately 10 to 20% that was shown in our cohort trial. We published already 2022 and in many others now. And we have many symptom overlaps also with long COVID. So also many long COVID patients suffer from severe fatigue and exertion intolerance, not fulfilling these criteria. We have also quite an overlap with pathomechanisms. We know that immune dysregulation, inflammation, mitochondrial dysfunction plays an important role in long COVID as well. I'm going to show you now some data about what we know about autoantibodies. And actually there is also quite an overlap in autoantibodies described in long COVID and ME/CFS patients. And this is the case for the antibodies against the so-called G protein-coupled receptor antibodies. A subset has elevated ANA antibodies correlating also with fatigue. And then there are several neuronal antibodies found in both groups. And we've also learned that COVID can trigger classical autoantibodies in a smaller subset. What we've also learned that there is evidence for molecular mimicry with EBV in the ME/CFS patients. I'm going to show you in a minute. I'm going to show you some data about antibodies to neural antigens, to G protein-coupled receptor antibodies, And what we've learned is that levels of several of these autoantibodies correlate with symptom severity and alterations in the central nervous system. So the G-protein coupled receptor antibodies are a very interesting family of regulatory antibodies. We find them in healthy people too. And what we've learned in post-COVID and ME/CFS, that in a subset of patients, these antibodies are elevated, but more importantly, their levels correlate with symptom severity and also with ZNS alterations. And we at least know for the antibody to the beta-2 adrenergic receptor that the function is impaired in ME/CFS and post-COVID syndrome. These are the landmark studies from Japan showing that levels of beta-1 and beta-2 adrenergic receptor antibody correlate with changes in MRI studies. In the studies, these changes indicate a correlation with an altered pain response, and in the more recent studies, the changes indicate correlation of these antibodies with neuroinflammation. I also want to mention this study by the group from Ron Davis, in which they describe antibodies against myelin basic protein, which is the classical antigen in multiple sclerosis as well, and they found these antibodies in about half of the ME/CFS patients, and these antibodies, as shown here, have the special ability to digest the myelin basic protein and result in the demyelinization in multiple sclerosis. And there's some evidence that this in a milder form can also happen in ME/CFS. Now coming to our studies on the role of EBV as an antigenic target for autoantibodies in ME/CFS. And this is a study in Nuno Sepulveda had an important role. The first study we did is we looked against all proteins of EBV. We compared the antibody responses in patients against healthy control, and we found a signature that ME/CFS patients have more IgG responses to the EBNA6 protein. Then, with the help of Nuno, we performed further bioinformatic analysis and found a very interesting region within EBNA6, which has such a polyarginine repeat sequence. And in these, we found higher antibody responses in the post-infectious ME/CFS subsets. And in a consecutive study, we then looked for human proteins with sequence similarities, and there are actually quite a lot having this polyarginine sequence, because this has several functions, for example, binding to DNA. So we selected a list of proteins where we see this mimicry, and again analyzed antibody responses against these proteins. And to summarize what we found is we found elevated antibodies against several of these proteins, including the alpha adrenergic receptor, and here this is another interesting neuronal antigen in multiple sclerosis, to the SRRM3 and several others. And again, for several of these antibodies, we not only observed higher levels in the ME/CFS and post-COVID patients, but also correlations with symptom severity. So, of course, autoantibodies are no proof of causality. What provides us with evidence, or at least with more evidence, are IgG transfer models and, of course, autoantibody targeting and clinical trials. And fortunately, there were two IgG transfer studies performed last year, one in Akiko's group in Yale, and the other in the group from Jerome Van Dannen in Amsterdam. And those could show that if you take the IgG from post-COVID patient, transfer it into mice, then several of the symptoms we know from post-COVID are induced in mice, for example, heightened pain response as shown in this set of experiments, or that the muscle force, the grip strength is reduced, very similar to what we see in ME/CFS patients. And regarding clinical trials, there actually haven't been many clinical trials in ME/CFS during the last 2 decades, but there were these groundbreaking studies from the 2 Norwegians, Øystein Fluge and Olaf Meller. So they did a series of rituximab studies in ME/CFS. They could show efficacy and long-term clinical remission in a subset of patients. Unfortunately, then the multi-center phase 3 trial failed to reach endpoint. Numerous causes have been discussed, and now there is now there is a study from Wakiro Sato in Tokyo, who is trying again rituximab in a phase 2 trial, and he is trying really to select the right patient. So we are hoping that he can confirm now that rituximab has efficacy in a subset of ME/CFS patients. And there were several groups, including ours, doing treatments with higher doses of IgG, which can also be effective in autoantibody-mediated disease. So this is the study we did with sub-Q intermediate dose IgG, and we gave it for 12 months. We included only patients with mild IgG or IgG subclass deficiencies to be within the indication, and what we observed is that the IgG not only led to reduced infection susceptibility, but also that patients improved. So this is the Child Fatigue Questionnaire. This is the SF36 functional score, and what we found is that from month 3 on, when the patient got the full dose, there was a significant improvement of the Child Fatigue and also the SF36 physical function. In a subgroup of 5 patients, we had a really clinical meaningful improvement with more than 25 points. However, we also observed that some patients do not tolerate it well. We had 4 patients who had to early discontinue treatment due to headaches, skin reaction, or liver toxicity, or severe flu-like symptoms. Then there is a treatment by which you can reduce or diminish all antibodies with a device called Immunoadsorption. This is a treatment which is well established in Germany for all autoantibody-mediated diseases. Usually it's a bridging therapy, is in a situation where you have rapid disease progress, or in a pregnant patient you cannot treat with medications. We did already 2 small trials pre-pandemic and got some evidence that in a subset of patients, the removal of IgG results in rapid symptom improvement. And then we got funding in 2022 from the government to do clinical trials in ME/CFS and post-COVID syndrome, and combine it with research. So we initiated 5 trials, 2 on immunoadsorption, and then the high-dose methylprednisolone to target inflammation, and 2 trials to target hypoperfusion. And just to show you the data for the immunoadsorption trial, so we included 20 patients who fulfilled ME/CFS criteria following COVID with elevated beta-2 adrenergic receptor antibodies with a BEL from 30 to 60, and they got 5 immunoadsorptions with Terasorb, which results in rapid depletion of IgG, as you see here. So the green period are the 5 days where they got the immunoadsorption procedure. And again, as very similar to what we saw with IgG therapy, we saw improvement of SF36 physical function. Before therapy, they were a little bit above 25, so they were housebound, and thereafter, in 14 patients, we had an increase in average to 60, which really means that they are back in life, although they still have symptoms, and that is not surprising because we do not get rid of the autoantibody-producing B cells, so we only reduce autoantibodies. We saw similar improvements in pain and also in markers of neurocognition. We did testing similar as Alsaka just described, and we also saw improvements in hand grip strength. And very importantly, we also find a marker, and we found a subset of B cells which was elevated pre-treatment in the majority of the post-COVID patients compared to healthy controls. And then when we looked after therapy, we see that these B cells dropped. So it looks as if immunoadsorption has also some effect on the B cell compartment. And most importantly, we could distinguish non-responder to immunoadsorption from responders. So it looks as if we have a marker to predict who will respond to autoantibody depleting therapies. At the moment, this is a highly sophisticated technique using CyTOF, but we are trying now to analyze this subset with a regular flow cytometry panel. So this would make it suitable to test patients in clinical trials very rapidly. And so that is what we plan now to do clinical trials targeting autoantibodies and plasma cells and using monoclonal antibodies against CD19, which also depletes plasmablasts. And we also want to use newer, more effective CD20 antibodies, which is the target of the rituximab as well. And we also prepare a trial targeting CD38. And you may have seen this remarkable study from Øystein Fluge and Olaf Meller again. They performed already a small 10-patient study with CD38 antibodies. And I show you one figure out of their study. What they showed is an impressive clinical response in 6 of 10 patients that they treated. Here again, you see there's a 36 physical function, and you see a quite rapid improvement. And the patients, especially those who received 7 repetitive treatments, are back to normal. So 80 to 100 is the normal range of this measure in healthy people. And those not responding were those with the lowest NK cells. So this is probably one of the reasons patients not responding. The other, which is possible too, is that these are not autoantibody mediated at all. So this will also help if we are going to analyze the patients now with our B cell signature. And then, of course, this may open the door for many other therapies which are currently in development or are already licensed, which are much more specific, targeting certain pathways in B cell or T cell activations, and of course also have less toxicity. So to summarize, we do have evidence for a role of autoantibodies in long COVID and in ECFS. We do have evidence that autoantibody targeting therapies have efficacy in a subset. And it looks as if we have a specific B cell signature which can predict a response. We have also by proteomics identified several soluble markers in which are characteristic for autoimmunity. So we think autoantibody targeting therapy holds great promise as effective treatment for the autoimmune subset of long COVID and ECFS. And this is to thank my wonderful team and all the supporters. And I want to invite you also to participate at our next conference on an ECFS, which will be the 7th and 8th of May in Berlin, either on site or via live stream. So look, I'm happy to answer questions if there are any questions.
Thank you. Thank you very much, Carmen. I think that we have a joint session for questions, but I don't know if you will be online at that time and whether you prefer to have some questions now.
When will be the joint?
So the entire panel will have it is scheduled at 12 noon, so 1 p.m. Germany.
Also, sorry, 1 p.m. is too late for me.
Yes. So let's take a couple of questions. There is one over here, Miguel.
Okay, good morning. I'm Miguel Castelo Branco from the University of Coimbra. Thank you very much for your very nice talk. I have a couple of questions, very brief. First of all, I think it's very important that you talk about, first a comment. It's very important that you talk about subsets of patients, because it's clear to me that most trials fail because people tend to ignore in the design of the trials that they should target particular subsets. And that's why most of the trials fail to reach phase 3. This is just a comment, but now I come to questions. You talked a little bit about inflammation, like in the previous talk, and several of these autoantibodies make lesions to the endothelium. So my question to you is whether, I list the questions. So do you think that these endothelial disruptions can make these autoantibodies enter the central nervous system? In the previous talk, we heard a lot about brain fog. So that's the first question. Could be this a mechanism for entrance of antibodies in the brain? The second question relates to the therapies you have been discussing. It was very interesting, the one on the autoantibody against CD38, because in general, my feeling is that these treatments don't reach the long-lived cell niches. And so my question to you, which of these therapies do reach these niches, and how important it is to reach these niches? So I believe rituximab does not very effectively reach these niches.
So maybe I suggest to allow Claudia to answer these questions.
Yeah.
Carmen,
So
sorry, Carmen.
Answering your last question first is, we do not know yet which is the most effective autoantibody targeting therapy. The daratumumab antibody is quite effective. It has been developed for multiple myeloma and has been used actually in numerous other autoimmune diseases so far. There is another one from Sanofi, isatuximab. We are hopefully going to test in a trial too. And then, of course, there is CD19, which is very interesting too, because it's expressed on plasmablasts and on memory B cells, has less side effects on long-lived plasma cells. So I think we should test them all. And then if we find subsets where we have evidence for autoantibody-mediated disease, but these antibodies are not sufficiently effective, then we have several other opportunities. We do now have the B-specific antibodies targeting plasma cells and CD3 cells, which are more effective we know already in other autoimmune diseases. And then the final escalation would be CAR T cells, which are very, very effective to induce a deep depletion of plasma cells. But I don't think that we probably do not need these escalations. Regarding your questions, if these antibodies can go into the brain, theoretically, yes, if you have a disturbed blood-brain barrier, but there is no clear evidence yet. We did one study with Jonas Bergquist, and in this study we could at least not find these antibodies in the cerebrospinal fluid, which does not exclude that there are areas in the brain where they can bind. And the data from Japanese showing the correlations with findings in their MRI does not mean that these antibodies necessarily need to go into the brain. It can just mean that they bind in the periphery, for example, are related to pain responses, and that this results in changes in brain connectivities.
Thank you. Any more questions? Can I?
Okay.
No.
A very brief one. You talked about the B2 adrenergic autoantibody, but there are many other autoantibodies that can be elevated. So why the focus on these antibodies? So how strong is the evidence that this is the most pathogenic autoantibody?
So far, we only have correlation analysis. So we have correlations repeatedly found for fatigue, also for vascular symptoms. So patients frequently have symptoms of hypoperfusions in the extremities, for which we have a correlation with beta-2 adrenergic receptor antibodies. And then the Japanese studies I just showed. And then we analyzed in detail the function of the beta-2 adrenergic receptor antibodies. We know that they are functional. Healthy people too, they are agonistic, so they stimulate the receptor together with adrenaline, and in ME/CFS patient, the function of this antibody is impaired. So they cannot adequately stimulate beta-2 adrenergic receptor, and the beta-2 receptor is an important vasodilator in the microvasculature. So it would fit well to our concept that if this receptor is not properly working, you have a paradox vasoconstriction in your microvasculature upon exertion.
Thank you. No.
Hi, Carmen. It's Nuno here. Hello, how are you doing? I would always a very good overview of the autoimmunity hypothesis of ME/CFS. The only thing that I would like to ask you is that what's your perspective? What's the chronicity? How do you explain chronicity? Is it a lack of regulation of the immune system? Is it reactivation of the virus? Is it a bias on the B-cell repertoire or T-cell repertoire? What's your perspective on the, let's say, on the chronicity mechanisms?
Yeah, I think we most likely face circuits vitiiosus in the muscles and in the brain due to the hypoperfusion, because then the mitochondria get severely impaired and they produce oxygen radicals, and they trigger inflammation, of the small vessels. And that is what we also see in muscle biopsies. And I think that is probably situations a subset of patients cannot recover from. And that fits very well to the concept from Komarov too.
Thank you very much. Thank you, Carmen, for this remote participation. And we will move on to another remote participation now by Nancy Kleimer from Institute of Neuroimmune Medicine in the Nova Southeastern University, not the Nova Medical School. And this is because we have a university in Lisbon with the same name. And we will talk about comparative analysis of pre-pandemic ME/CFS and long COVID cohorts, phenotyping insights, and CIPA-VBART monoclonal antibody trial. Thank you.
Hi, thank you for having me. And can you see my slides okay? Everything's all right? So I'm assuming you can hear me and you can see my slides. Is that all right? All right, well, I think I can see it on the screen, maybe. Okay, anyway, hi, I'm Nancy Kleimer from Nova Southeastern University in Fort Lauderdale, Florida. And I've been doing a lot of ME/CFS research for many, many years, and more recently, long COVID. And thank you for having me. I'm actually in Australia right now. They're having a competing meeting, and I'm somewhere near Brisbane. So my world is upside down time-wise. Can you see that? I can't tell if you can see my slides. Yes, they're right. Now I see it changed. Great. Okay, so I'm assuming you can hear me and you can see, or you would interrupt me. So today I'm going to talk about a couple of things. They sort of morph together. But I will be talking about ME/CFS and long COVID, some of the things they share and some of the places where they are not sharing exactly the same thing. It starts with a trial that we're doing. This study, it's not a trial, I'm sorry, it's a study, COVID-19, Understanding the Post-Viral Phase, or COVID UP. This is a CDC-funded study with a cast of thousands, a lot of people working in this study. We've been at it for a number of years now. We're just in the final month or two, so we're excited that we reached our recruitment goal of 800 people with 600 long COVID and 200 recovered, of which we brought in 200 people, 150 ill and 50 recovered for phenotyping studies. So that's one study that we have underway. And the main thing here, as you know, is that there's so much similarity between ME/CFS and COVID that we wanted to explore, that area, because we're taking advantage of this other study that we completed right before the pandemic, MCAM, which is another CDC study that had 750 patients, another very large cohort. This was from, I think, 7 expert clinics. Where we really diverge in terms of who we're studying is the COVID UP study is regional, it's South Florida, and it's representative of the population, meaning that we recruited from healthcare systems, not clinics, including the healthcare systems that serve the underserved. So we have a socioeconomic distribution, racial distribution, ethnic distribution that's much more reflective of the place we live. And so we're very excited about this study. Unfortunately, I'm going to say that because the CDC has been in government shutdown for the last 6 or 7 weeks, I couldn't get permission to show the most recent data. So I'm going to do this just a very brief thing here and hope that you invite me back next year when I can have all the final data in hand. But that lets me concentrate on my other things as well. The second study that I will be talking about is this study. This is a monoclonal antibody study, a therapeutic intervention, double-blind placebo control of a monoclonal against spike protein. This is the AstraZeneca product that is used to prevent COVID. And it has gone through some iterations. This is their more recent variation that covers variants through about the middle of the Omicron change. So Omicron, like early 2024 backwards to the beginning. So we're excited about this study because we did a little open label case series, or I should say Dr. Shepke did, one of the co-investigators, with a case series with a different product. And he had some remarkable improvements in some of the patients who received the monoclonal, which led on to developing this study. So what do we need to know about what's the same and what's different, and what we can learn from both what we hope to be able to generalize from one to the next as we do these really important evidence-based studies, so that we can say that with certainty, what is the same and when can you generalize. Well, they share clinical phenotypes, as I showed you in that first slide, widely overlapping both in the way they present and the severity of the presentation, which I'm sure you've heard from others, and I won't belabor the point. The triggers are different, and this is important because I threw in a third illness here. Long COVID, clearly the trigger was SARS-2 infection. ME/CFS, more often than not post-viral, not always post-viral, but more often than not post-viral, but not necessarily a specific virus, Epstein-Barr, influenza, other types of upper respiratory tract infections, enteroviruses, and so on. Now, Gulf War illness I threw in because Gulf War illness is a toxic injury. These are the veterans that were sent to the Gulf 1990, 1991, and they had tremendous organophosphate exposures and other burn pit exposures, burning gas wells, oil well exposures. They had a tremendous toxic load. And their end result was a chronic neuroinflammatory state. So if you look at all these different illnesses as being triggered by different triggers, but having sort of a common persistent illness with common persistent mediators, they can be lumped, and we can learn from what we learn from one and hope to apply it to another. So the working model then here is that there are triggers, and these triggers can be viral or not, specific viruses or not. Chronic immune activation persists or goes on. That results in immune senescence and poor immune function. Viruses reactivate continuously push the on button and keep that immune activation going. And eventually there's immune senescence and more viral reactivation, a vicious cycle. Spin-off from that, from the speaker we just heard before, is Carmen's work, very important work on the autoimmune mediators, because autoimmunity is also a chronic immune activation, thumb on the go button kind of push that results in senescence and so on. And you could postulate that the autoimmunity happens early in the course of the illness, but you could also postulate that any illness that results from chronic immune activation initially could eventually start spinning off autoimmune mechanisms, particularly when Epstein-Barr virus is involved, since it's a polyclonal activator that's known to trigger autoimmunity. So all of these things that drive the immune system into a chronic immune activation state is a setup for viruses to reactivate. And then the viruses are also contributing to the mediators of the illness. This is one of those lovely summary slides that tries to make the point about what is the same across the board. And you can see that all three illnesses, because I included Gulf War illness on this, have evidence, whether it's looking through the cytokine window or the immune window or the proteome window of chronic immune activation. And in fact, this is one of the very first things noted in ME/CFS in our first paper, which was in 1989. It was actually the title of the paper, chronic immune activation. And same with Jay Levy, who published the same year in The Lancet. So that one of the very earliest immune findings in ME/CFS was chronic immune activation. And both those papers also emphasized the poor cytotoxic function and evidence of EBV reactivation in patients with ME/CFS. Since then, as we've gotten new markers and better ways of measuring, the senescence markers were measured, and there they were. The immune senescence was a part of the play here. And another cell that responds very poorly to chronic immune activation is the mast cell. And you will see patients often have an overlay of mast cell activation syndrome at a low level or a high level. And it becomes another cell that releases all kinds of chronic inflammatory mediators and helps drive the severity of the illness. Finally, I put the gut microbiome on here, not technically part of the immune system, but another thing that can drive immune dysfunction, particularly when there is mucosal integrity breakdown and antigen exposure systemically to a broad spectrum of antigens that would normally be hidden from the systemic immune system through barriers, through mucosal barriers. So that's sort of a breakdown about if I were to split it into innate versus adaptive immune system. The innate immune system is really important here, and that is this very clear evidence that natural killer cells aren't working correctly. In fact, when the Institute of Medicine did an entire review of the literature about 8 years ago, they said it was the one single marker of immune dysfunction that they would accept as evidence-based. Everything else they thought at that point, I think it's much better now, but that point, the lack of validating studies, so many intriguing papers without the follow-up high and number drove some of their conclusions that everything else was more intriguing than definitive. But NK cell they thought was definitive then and listed it as a biomarker of ME/CFS. So you can see NK cell dysfunction is a player, and many groups have published this now. We published it, like I say, in the early 90s, but many times since with different cohorts. But so have other groups. And in fact, Dr. Marshall Gradisnik, who's actually hosting the conference I'm attending right now in Australia, their group has done a lot of work looking at the TRP channel dysfunction in ME/CFS, and they have a very elegant system now to test ways to correct that. and presented at this conference an intriguing paper that low-dose naltrexone actually helps correct the channelopathy that you see, this calcium influx channel dysfunction of NK. It helps to restore NK cell function. I think that's fascinating because clinically we use a lot of low-dose naltrexone thinking we're working on neuroinflammation, but in fact it has a much broader effect. And then our group has published papers using flow cytometry to measure the content of the NK cell for granzymes and perforins as being reduced in all three conditions, Gulf War illness, ME/CFS, and long COVID. In terms of adaptive immune changes, you just heard an elegant talk. I hardly need to spend time on this slide because you just heard it all by the foremost authority, I think one of the leading experts in what's going on with autoimmunity in these conditions. And Carmen just did a splendid job of describing the T cell and B cell compartments. So I'm going to bring you down to the bottom of this slide, the key question. If chronic antigenic stimulation is driven by antigen, it can be autoantigen, or it can be non-self, it can be self, autoantigen, or non-self pathogen. So key question in this illness is what is driving the illness, or at least the chronic immune activation component of the illness? Is it reactivated infections, or is it autoantigens, or is it both? And I can tell you, since we measure this all the time, we frequently see both, frequently. But we nearly always see reactivated infections. So a part of the problem, as you know, is that with autoantigens, you have to know what you're looking for. You have to order the right test. And the work that Carmen's group has done looking at the alpha adrenergic and beta adrenergic receptor autoantibodies in these illnesses is really pivotal. But there are other autoantibodies, including CNS autoantibodies, that have been reported. And it's hard to do a total body survey. So I think at the end of the day, when you're a clinician, you have the data you can collect, and it can be, well, look, there's evidence of EBV, perhaps CMV, perhaps HHV6 reactivation, and maybe I have a low positive ANA, and now I'm going to go searching for autoantibodies as well, just to try to hone in what can I try to fix? How can I help this patient? But since this talk is going to speak mostly on viral reactivation, I'll focus on that. And this is some of the information we know about that. Well, much of the focus has been on herpes viruses because they are latent, they reactivate, they cause all kinds of havoc. And there are some treatments available. And so there's more than 1,500 pages in the ME/CFS literature on viral reactivation, or that shows evidence of viral reactivation in the literature. And it's more likely to happen and at higher levels when NK cells are dysfunctional, that's been shown, or cytotoxic T cell function is impaired, or both. So the degree of immune dysfunction drives or predicts the level of viral reactivation that you will see. In long COVID, though, we have another whole thing, and I'm going to spend a little time on this because it's the reason why we're doing that monoclonal antibody study. In long COVID, there appears to be a reservoir of viral antigen in people with long COVID that persists months and years after the primary infection. So you could argue that there's viral persistence. I don't think we have evidence to prove that. It could be a hypothesis. But we have absolute evidence that there's spike protein and nuclear antibodies, but particularly spike protein reservoirs hiding in organs and bone, and to some extent a little bit in plasma. So that's a hell of an antigenic drive. And it can be a really important reason why people keep their immune system so stirred up and so dysfunctional. But also in long COVID, if a person reactivates EBV during primary infection when there's acute COVID, that's a predictor for long COVID. So people who reactivate EBV, which is about 40% of people, that's a predictor of people who go on to be at risk for and eventually develop long COVID. Also, people with long COVID who have reactivated virus, the more virus they have, the sicker they are. It does predict the severity of illness. So again, we're stuck in this loop that I was describing: viral reactivation, inflammation, senescence, cellular exhaustion, poor cell function, more virus comes out, and on it goes, round and round in a big circle. So as I said, there's more than 1,500 papers in ME/CFS, because we've been doing this since the 90s, so there's been some time to do some papers. The focus has always been on herpes family viruses, primarily EBV and HHV6 being the most commonly seen, HHV6 being the most commonly seen. CMV also seen, though sometimes not in the blood compartment. Enteroviruses, particularly Coxsackie B virus, in the gut compartment, not circulating in the blood. So you actually need to look at the person who did all this work was John Chia, and he looked at people who went in for endoscopy for any reason. And he did 300 plus endoscopy reviews for viral reactivation in people with and without ME/CFS, and had a very high prevalence of Coxsackie B, but also EBV and CMV in those stained tissues. And he did some very elegant fulfill Cox postulates type of work to prove that the enterovirus was in that compartment. We sometimes see parvovirus, and that's actually treatable. So when you see it, it's kind of nice to find it because you can do something. And that is an important player. I think I sort of reviewed this, that EBV, we mainly are monitoring by antibody response to antigens that shouldn't be circulating, specifically early antigen, that's probably your best. But also we often see IgM antibody to capsid, which is, the outer wall. And IgM antibody is not something you're supposed to see after primary infection. So two of the big serologic indicators of EBV reactivation are high titers to early antigen and high titers to IgM titers. When the Stanford group did a Val site study, and they looked at who the responders were and who weren't responders, they said EBV early antigen titer of 1 to 160 or greater predicted a responder, and 1 to 80 and lower were less likely by a lot, like a 5% response rate versus a 60 or 70% response rate. So that was quite the line, or IgM positivity. So I thought that was a pretty good clue, and we thank Dr. Montoya for giving us that important information. Finding the PCR positive is trickier because it comes and goes. And the time when they found PCR positive in the plasma of MD patients is when they've done longitudinal studies and drawn it 3 or 4 times. And then particularly with HHV6, Dr. Connie Knox did a study with HHV6 with 4 blood draws, and she found it in a very high level. It was more than 80% by PCR at least once. So that was important. And the other thing that's not published, but Dan Peterson did this study, is he did spinal fluid, and he did around 130 spinal fluids of the sicker end of ME/CFS, and found 44 patients out of 130 or so PCR positive for HHV6, and then in the teens for EBV and in the single digits for CMV. So he was actually finding viral DNA in the spinal fluid in a significant portion of ME patients, and I think that's rather important. Another important study is Dr. Marshall's group at Ohio State. This is really important work because it kind of turns on your head what you thought about viruses. Do I need a whole replicative virus to mess someone up? And they're saying, no, you don't. If there's a latent virus like EBV or HHV6, and there's a lot of immune activation, there's enough viral code in those cells to be coding for viral peptides like DUPTase. And DUPTase itself has a lot of immunologic and endocrine effects. And so they're saying you don't need a whole replicative virus. You don't need Cox postulates here. You need viral enzymes that are unique to these viruses being expressed by the cells that are infected by these viruses. And they've done elegant work, very definitive work, that DUPTase is a player and part of the problem in these illnesses. So this, on the yellow on the bottom corner there, is this DUPTase slide from a paper that they wrote not too long ago that's looking at reactivation of EBV and HHV6 and all the effects the DUPTase enzyme can have on, in this case, just the immune cells. There's also a whole host of endocrine things DUPTase affects over and above the immune system itself. On the left, I'm showing you a picture from a different paper from Verma et al. That shows the role of co-infection. What happens when you have more than one virus? And during your acute COVID, if you have, the first slide there shows a virion binding to the ACE receptor with just COVID on board. And it says 3 spike proteins bind to ACE2 in that setting. The middle slide adds Epstein-Barr virus to the culture. Now 4 spike proteins bind to ACE2. You have a different level of binding and a different level of drawing that virus into activating cellular processes. Finally, that third one is when you're co-infected with EBV and HHV6, 2 co-infections plus COVID, and now you have 5 spike proteins binding to ACE2. So you can see that viruses, when they come together, help each other be even more equal. And that's what that slide is suggesting. So we have to think about co-infections and that we're not necessarily looking for the magic button, the single virus that's causing all of this problem. So here's some of the data that EBV reactivation predicts long COVID and has an impact. And here's now 1, 2, 3, 4, bunch of papers here, right? 5, 6 papers that look at Epstein-Barr virus in long COVID, and it's showing that it's reactivated, that it increases the severity of symptoms, that it's associated with very specific symptoms like brain fog, headaches, confusion, that 42% of long COVID patients are demonstrating EBV reactivation in this 2022 series. I've seen other series much higher, the one here 66%, and so on. So it's a player. What about HHV6? We talk lots about EBV, and we should. It's a bad bug, but HHV6 is there too. And as I said, I showed you the DUPTase data, but it's a frequent co-infection, and it's activated in long COVID in a significant subgroup. It's also associated with autoimmunity and oxidative stress and inflammation. And when you have EBV and HHV6 together, you're sicker. Enteroviruses, I mentioned Dr. Chia's work. I'm not going to spend a lot of time on it, but I wanted to make sure I didn't just talk about herpes family viruses. And we've been having discussions about retroviral fragments for a long time. You know, we have a lot of endogenous retrovirus in our DNA, and whether or not we should be completely ignoring that. You know, you could argue that, particularly with the work in ALS and other diseases, they're starting to make endogenous retroviruses more important in brain diseases, that we should be paying attention. The other thing about co-infection is we learned a lot in HIV about co-infection, because co-infections made HIV much worse. If someone had acute EBV or acute CMV at the time they got their acute HIV, they were dead in 5 years. It didn't take them any time to totally shred their immune system. So that was because during acute infection, when you have one of these other herpes viruses and you have a virus that is being produced, it actually upregulates the amount of virus, and then you end up with a much higher latent viral load and a much more potential to have chronic immune activation driving persistent infection as it goes along. So as we puzzle our way through this long COVID question of why are we seeing spike protein, 2 years, 3 years after the acute infection, it begs the question, is it a deposit of old spike protein? It all happened during acute infection? Or is this the weird, strange SARS-2 infection that should not be, that persists? Because SARS-2 is like 30% of your common cold viruses or coronaviruses, right? So they should come and go. They shouldn't hang out. But, you know, mutations happen and viruses change, and perhaps we don't really know what's going on that's driving all this spike protein to persist for years after an acute infection. But what we do know from HIV is that if you had co-infections, that wasn't good for you. And it created senescence, T-cell exhaustion, early aging, short telomeres, and so on. So how's that relevant to long COVID, ME, and to our Gulf War veterans? These common mechanisms across all these different illnesses, knowing that they correlate with severity, they correlate with the way the illness presents. It makes total sense that if your cytotoxicity is not working, you're going to reactivate viruses. And whether or not this persistent antigenic load is driving the inflammation, the early aging of the immune system, the senescence, and some of the metabolic derangements that we see, it just feels very similar to the HIV story. But it also says, as we're thinking about how we go about treating these things, to realize that we're not talking about one virus and one virus's replicative cycle. It won't make sense that you're going to completely control these things with a thymidine kinase inhibitor like acyclovir when you're looking at viruses that are behaving together, that there are multiple viruses, and may not even be in a replicative cycle at the time when you're treating it. And this is just a thing to make me remember to say it's more than just inflammation and immune activation. Herpes viruses directly affect mitochondria and disrupt mitochondrial function. So what are the therapeutic implications? Viral reactivation is not epiphenomenal. It's a driver. It contributes to the ongoing immune damage, and it's a logical target for intervention. But limitations. Most of our antivirals are only active when a virus is in its lytic phase of replication, and that's not what we're talking about here. These are not as predictable as all that. In transplant populations, EBV and CMV reactivation often occurs even when you put them on decent prophylactic, even big gun, high-dose valsite prophylactic medications. So it's not easy to suppress EBV or CMV, or for that matter, HHV6. The reservoir cells, if we just talk about EBV for a moment and we think of it as the B cell virus, but it's also in the salivary glands, it's in the parotid gland. So in the B cell depletion studies that were the Norwegian colleagues did, we thought, oh, this is great because not only are they taking out B cells and dealing with autoimmunity, maybe they're going to knock down the EBV reservoir, and that could only be a good thing. But there's this reinfection coming from the parotids that can rapidly re-inoculate the system. So that's not a perfect thing. We're hoping that these newer drugs, and there are many newer drugs better than the old thymidine kinase inhibitors and zidovavir and foscavir, and not as toxic as those stronger drugs that are either already out for CMV or in early stage development. There's also 5 EBV vaccines in some stage of development and one that's already listed in clinicaltrials.gov. So that's exciting. To have an EBV vaccine is a transformative thing for human health. And I'm excited to know it's there. I'm hoping we'll be able to access it for our patients for clinical trials. But simple short courses of antivirals is not likely to be particularly helpful. So the key point here is that antiviral strategies must address the latent reservoir and the exhausted immune system, and not just acute replication. That immune system needs to be engaged if we're going to be successful. So as I said, there was the Montoya study with alkyl cyclovir, which is a little pilot, but it looked promising. for the people with high titer early antigen. The long COVID trials that are trying to just suppress COVID, if it's replicative, and we don't know if it is. So far, the pathology trial, there's been 2 of them, and they've both failed. This trial, the Myalgic trial is underway, and there's various immunomodulator trials that are getting underway. There's some pretty exciting immunomodulator trials coming along. So what is the evidence for viral persistence in long COVID? Well, it started with a series of papers. These are really important papers. This is Michael Pelosi's papers. These are both his, that are looking at plasma-based antigen persistence in COVID, in post-COVID patients, and then tissue-based T-cell activation studies. And this is an important thing to consider. This is the plasma concentration of spike protein, how much spike protein is circulating, versus severity of illness. And you can see the more spike protein, the more severely ill they are.
I'm sorry to interrupt, Nancy. You have 2 or 3 minutes to finish. We are already over time.
Oh, I'm sorry. I'm glad you told me because I'm not watching. I got chatty. I want you guys to note this paper. It's a really important paper by Wrong et al. And this red stuff right here you see on that picture on the left is the cribriform plate next to the meninges. That's spike protein loaded up there. This is in an acute COVID person who died of COVID. And all these little red dots are various immune cells in the meninges responding to that spike protein. But there are other papers that have looked at long COVID in organ systems. I have that in just my next to the last slide here. And this little chart in the middle, which is finding tau and GFAP and NFL, all neurodegenerative markers in the spinal fluid of long COVID patients, which is a big concern. This is another one that's just looking at tissue. This is big numbers of people that went to surgery and they biopsied while they were in there. And this is the percent of those organ systems in people with long COVID that had measurable spike protein in skull, in liver, in GI tract, and so on. So this is my big ta-da, is our study, which is the monoclonal antibody to spike protein. The study's underway. It started 2 months ago. We're going to recruit 100 people. The person that asked about powering studies to be able to find the subgroup, this one was powered to find 25%. At the time when we designed this study, that was what we thought was the percent of people with spike protein in the plasma. But we didn't know how many had it in other tissues, so we went for everyone and not just people spike protein positive, but powered it so that if we saw a 25% response rate, we would see it. So it's 100 patients, 6 months, they get 1 dose, they're followed for 6 months, and then they can have a second dose, and the placebos can go open label and have a dose. So that's basically it. It covers the variants until about the middle of 2024. So we collect, that's the entry criteria, had to get 64 of them. And we're measuring everything under the sun. One of the most important things with this study is that we're creating an amazing biorepository and we're very collaborative. So keep in mind that any liquid that we could get our fingers on, plasma, saliva, urine, stool, we have a biorepository that we're gathering. And so this is my conclusion slide. In conclusion, there's a lot to learn from each of these illnesses that will teach us about the other illness, particularly as it relates to the immune system, viral reactivation, viral persistence. I do think we need to think about immune recalibration and trying to find ways to shake those senescent cells back alive, if it's mTOR or if it's the LDN studies, the channelopathy interventions that Dr. Marshall Gradden is doing here and in Australia. But we have to think about these things in a more comprehensive way. I think single drug, single hits aren't going to teach us what we need to know or help our patients enough. Thank you very much.
Thank you. As we are already over time, we have time for one question, assuming that Nancy will not be here for the panel discussion.
I can come back for the panel. It's okay.
We have one question there.
Thank you, Nancy. Amazing talk. It's Rowan from Precision Life. You spoke about the experience of HIV, and many of the co-infectious viruses are endemic in the population. Is there any reports in the literature that you know of whereby some individuals had a measure of resilience to that? So I'm thinking of going after some of the resilience mechanisms may find a way through this that would benefit many of the patients. I just wondered if you were aware of any
I kind of
clinical
know the flip
evidence.
side of that. I do remember that in the work that was being done in HIV, if your CD4 count was toast, if you had 10 cells left, right, you should die. But many people live for years and years, despite a CD4 count of terrible. And the thing that was working in them was their innate immune system. Their NK cell function was good. So the NK cell function has a lot of psychoneuroimmunology literature because it does respond to stress in a very negative way, and it responds to stress modification to some degree. So you'll see a lot of literature there. But I think that in this instance, the NK cell has poor perforance, poor granzymes, overactivated, driven into senescence. So I think we're going to have more luck with mTOR type strategies, inhibiting the mTOR pathway, like the longevity work that people do. And then this very important work the Australians doing on the actual channelopathy. I think that if they make progress, and it looks like they're making rapid progress, that they might give us some very novel therapies.
Thank you very much. Since Nancy can be in the panel starts in about 1 hour and 15 minutes from now. I know that there are a couple of questions from online, and we will keep those for the panel. We will break for 20 minutes now, and we reconvene at 11:05 for the new session. Thank you all for this session.
And we also had some agreements because I had to present my issues. We had a special presentation, so I was frustrated by that. But my colleague, Lydia, is continuing the study. She's doing her PhD in money. So the results will be available till the end of this year because she's in her last year of the PhD. I think it's really interesting. because my study was only about echocardiogram, but her study will have actually myocarditis. No, because it is all right. Io acho que eu estar é uma licença de análise de dados
Faz favor. Eu acho que nesse preparatory Pois, se calhar depois mais a fazer uma autonomia. Ele tinha nada de autonomia.
A parte do sistema autonômico, isso é claramente a por exemplo, eu ponho os pontos porque o meu está muito alto e eu tenho que sentar.
Eu tenho que escolher é o cardeal distinto. Se ela estava é exatamente isso. É os atos distintos que está a usar. O que eu tinha alterado era a atuação e a velocidade. Que é toda a não é pela nuance seguinte. Está bom. Não pode minha heart rate nessa noite. Não, eu acho que a neurologia vai melhorar completamente. Eu acho que a neurologia vai melhorar. Super idosos. São menos altos e
Acho que tem que procurar uma central.
acho que aqui pode ser a mesma coisa.
Se houver estou em imunológico, basta que eu possa ter.
Já está um bocadinho.
Acho que eu posso ter quando sim, sim. Mas também, mais uma coisa que eu não sei se é pode ser isto, por favor. Isto é super
Você no chat.
Isso é outra coisa também, ser médico é
Eu já falei, eu tenho mais interessante
olha,
Mas ainda assim não conheço, não vou ser muito sincero. E acho que João era igual a mim. Mas ele traz todos eu contactei a Seção, mandei-me os já cá. Cinco vezes superior ao nome. Assim como isso, já achamos que era o verdade. Mas eu depois começou a falar em coisas, foi da minha área, porque é uma ponte. A reação vai lá bastante. Eu sei, na verdade, eu que achei que era uma autonomia. Eu achei que isto é um sinal que pega as mãos. Se eu não pegar no meu pai, nós fizemos que isto foi um choque assim. Encontrei essa empresa de reação. O senhor trabalha isso? Eu trabalho. É uma pessoa. Depois, para quem já é uma pessoa assim, eu acho que sabe que eu trabalho em estatística médica. Eu tento, se calhar, para fazer um trabalho. Sim, sim. Mas é não. Foi muito sobre isso, parabéns. A direção é espetacular.
Maybe that one? I have no idea.
Depois fui procurar se havia alguma empresa que fizesse isto. Depois mandámos para a ação.
You are Regia.
Yes.
Regia. Regia Pretorius.
That's correct. And this is go forward and backwards.
I guess.
Where's the you go forward and backwards?
I think it should be with those arrows.
They are having this one.
I think that probably I will introduce you and then. There you go.
I see two.
Okay. Okay. Thank you for getting back. There was a misunderstanding with the timing of the earlier session. Now we are at the right time. And it is my pleasure to introduce Regia Pretorius from the Stellenbosch University that will talk to us about the impact of microcirculation and microclots in ME/CFS. Thank you.
Good morning, everyone. Thank you very much for this opportunity to speak to this wonderful group of individuals, researchers and patients, and also to the online participants. Thank you very much for this opportunity to speak to you. I will be taking you through, in this presentation, through a whole process. But first, I want to thank many of my collaborators, most listed here, some of them not listed here, a wonderful team of students that's always been in my lab, collaborators from all over the world, and some of them really working very hard currently also to figure out long COVID specifically. And then I would like to thank the wonderful funders. I cannot do this work without Polybar Research Foundation, Bolvi Research Foundation, and many more. Really a very warm thank you from all of us. So I'd like to take you on a journey which started probably around 2007. And during that time, I was working on coagulation, and we were studying clotting pathologies, platelet hyperactivation, red blood cell structure, and it progressed where we worked on various diseases, various methodologies used. Particularly, we focused on flow cytometry, proteomics, scanning electron microscopy, and all sorts of markers to study coagulation. So coming to 2020, we were well prepared for this new pandemic that hit the world. So our interests are to look at how platelets interact with each other. They are potent signaling entities, how they interact with each other when they become hyperactivated during inflammation and circulating inflammatory molecules that cause them to hyperactivate, and how they also interact with other types of cells, cells of the immune system, red blood cells, and also the endothelial layers, where they might form complexes when they are activated in the presence of inflammatory circulating molecules. Then we were also interested in how the molecule, the clotting molecule, fibrinogen, interacts when they are exposed to any circulating inflammatory molecule. In the case of platelets, the interactions are through various receptors, where the receptor is activated by the inflammatory molecule. In the case of proteins, there's a direct protein-protein interaction, and this protein-protein interaction might cause the actual protein biochemistry of the molecule to change, and this change causes the protein then to form plates instead of single soluble molecules and to turn insoluble. And specifically fibrinogen is very capable of interacting with spike protein, LPS, and other molecules. The protein-protein interactions bind to the structure and the whole protein unfolds. And we discovered probably around about 2014, 2016, in that period, that when this interaction happens, the fibrinogen molecule turns into an amyloid-dogenic type of molecule. So the structure becomes plate-like, and instead of becoming or being a soluble molecule, the molecule turns out now to be insoluble little structures in circulation. Now, our early work in 2016, we first published how this the molecule LPS from bacteria can interact with the fibrinogen, and we used a marker, the green marker that you can see on the screen, called theoflavin T. Now, theoflavin T is a molecule marker, quite an old marker, that was first used to look at the amyloid nature of plaques in brains of Alzheimer's patients. So this well-known old marker together with Congo red. So we decided to look at it for the first time when we exposed fibrinogen, and we used both from plasma in circulation or purified fibrinogen. We exposed that to LPS and then exposed this mixture to our marker, theoflavin T, and it lit up like Christmas trees. So what happens is when the LPS or the inflammatory molecule binds to the fibrinogen, the fibrinogen molecule unfolds and it opens damaged hydrophobic areas on the molecule. And that allows the theoflavin T marker to bind to it. So this process is then called an amyloid binding process. And we then discovered that fibrinogen can become amyloid. It's not the same thing as amyloid beta in the brains or alpha-synuclein. It's not the same thing, but if you do have a brain slice of someone with Alzheimer's with amyloid beta, syn-alpha-synuclein in Parkinson's, you can use theoflavin T, and it will bind into the areas that has amyloid formation. So we also looked at stroke blood way back then, and here you can see the typical little spiky little fibers in blood, which is the amyloid nature, and in A is of a healthy individual without any of these amyloid present. Now, way back then, we were also looking at thromboembolic stroke, and we were specifically interested in red blood cells. We also looked at what happens to hemochromatosis, but we were mostly interested in the red blood cells and the platelets. And the clotting pathology we knew, but we didn't deep dive too much into that at that point in time. And I'll fast forward and I'll show you in a few slides what happened when we went back to our old micrographs and looked at it again in 2024, 2025. So fast forward to the pandemic, we were well prepared. We knew about amyloid, we knew about platelet hyperactivation, we knew about red blood cell damage during infection with LPS, circulating inflammatory molecules. What we weren't prepared was to see the absolute havoc that was happening in the blood of patients in the ICU. We found platelets significantly hyperactivated. Look at the yellow arrows on the slides. It looks as if the platelets just exploded. Red blood cells were interacting with platelets, but we also found that there were huge amounts of structures, of deposits, of aggregates, of plasma protein that even glue together red blood cells. And you can see them in the blue, with the blue arrows. So quite early on in the pandemic, we also tried to see what happens when we added spike protein. There is part of the spike protein. We looked at microfluidics, and we could indeed, in a healthy individual, induce these platelet hyperactivation as well as microclot. We didn't call it microclots formation then, but aggregates of certain of the plasma proteins. We could induce it simply by adding spike protein to whole blood and to plasma from a healthy individual. We also looked at the microfluidic system, compared the controls to the controls with spike protein, and with COVID-19, we saw huge activation of the structures, these aggregates, just due to the spike protein. So that gave us the idea why in the whole blood of the ICU patients, we found significant deposits on our red blood cells, platelets being hyperactivated, and we had a basic idea that in that stage it was mostly due to the spike. So fast forward to long COVID, our first cases in South Africa was probably around about the end of 2020, after speaking to Amy Prohl from Polybio Research Foundation. Myself and Doug Kell, my long-standing collaborator, I had a discussion with her. She said we must look for samples in South Africa. We went out and we did find them. And lo and behold, the white blood cells, red blood cells, platelets significantly damaged. And we also found these deposits, aggregates in the plasma stained with theoflavin T. Here's just an example of a very ill patient that we saw when we traveled to Germany, to a clinic in Germany that treated patients with long COVID with apheresis. So fluorescent microscopy of long COVID showed exactly the same patterns. We found these deposits, the green deposits once again. We have marked the red blood cells here with red blood cell marker for the membrane, and you can also see the platelets hyperactivated in pieces of broken platelets everywhere. And then scanning electron microscopy close-up of red blood cells of long COVID patients we saw these deposits on and around the red blood cells. Now you can imagine if someone's blood looks like that, the red blood cells will not be able to carry oxygen properly. It will not be able to get the oxygen into the cells where it's needed, and you will get little areas of the endothelial layers that might die, especially in the capillary beds, because they don't receive enough oxygen. Now, in 2021, we quickly did a proteomics analysis after we started having our first long COVID samples. To our surprise, we could not break down the plasma of the long COVID and acute COVID samples, but we could break it down with trypsin from controls, plasma from controls, and diabetes that we included in the study. So that gave us a thought that perhaps these deposits, these plasma deposits, the clotting deposits, do not break down as it should. And when we did develop a protocol to be able to break it down, we found various molecules entrapped inside these structures. Now, interestingly, again, Amy Prohl from Polybio, we had a discussion with her, and she said we should not call these deposits what we call them. We called them heterogeneous, dense matted amyloid deposits. So she said just find some different, easy flowing term, and we came up with the term microclots. And from then on, these deposits were now known as microclots. And entrapped inside these microclots after digestion, and we've done proteomics, we found one molecule of interest, alpha-2 antiplasmin. And that is a molecule that blocks the breakdown of pathology's clots, microclots or clots, inside the blood. So it stays there for a little bit longer, and then it can cause havoc that we have been seeing specifically in long COVID. We quickly realized that we cannot only use a macroscopy method for a quick analysis, and also we can't use proteomics as a regular point of care type of test, just too expensive and too time consuming. So together with various of our collaborators, patients, clinicians, parents of patients, family members, we crowdfunded, but with, again, Polybio Research Foundation and kernels. And we could have our imaging flow cytometer in our lab within 8 months after starting the process. And we developed a method and published on it how to find microclots in platelet-poor plasma using an imaging flow cytometer. What that means is typically the flow cytometers are used for cells. It's what they've been developed for. However, we could actually develop a method to track microclots inside the plasma, which is not necessarily cellular of nature, but these aggregates of plasma proteins that is insoluble. So let's look a little bit more deeply into what it means for the patient. We believe that one of the things that can happen if these deposits stay in circulation for quite a time is that ischemia reperfusion injury can happen. So in general terms, what is this ischemia reperfusion injury? It is initiated via bursts of reactive oxygen species produced during the reoxygenation phase following hypoxia. So this is one of the many of the complaints that patients have, that they have this ischemia reperfusion injury. And we believe that central to this is the presence of these microclots in circulation that do not break down as they should, and then actually block the tiny capillaries. Recently, we've also been working with a team from INSERM and Montpellier under the lead of Alain Theory. He's a world expert in NETs, but in cancer. And he contacted us a few years ago, and we just had a paper where we showed that these microclots are actually entrapping nets from neutrophils as well. So it's a little immune complex in circulation. And there's an example of one of the micrographs that we could machine learn also from our micrographs that we took under a fluorescent microscope, where we could see that there are DNA interactions with this, the microclots stained with THT. He also did ELISAs, elastase assays, and myeloperoxidase ELISA ELISA assays. So it's a whole lot of markers pointing to immune net activation and that they are trapped in structurally associated with our microclots. Now, is a microclot, or should we actually be focusing on their content, their activity, and their biochemical characteristics? So over the past year or so, our team has been specifically focusing on that. We, with proteomics, found numerous inflammatory molecules, including fibrinogen, all the fibrinogen different chains in circulation, but we were now also the past months deep diving in what we can see about the inflammatory molecules that are entrapped in the clots. And we used a program called ameliogram because we are interested in amyloid protein. So ameliogram is a molecule that you can put a sequence of your protein into this program, and it can determine what the amyloidogenicity of your molecule is. So how sticky it is, how damaging it is when it's in circulation, and when it interacts with fibrinogen. Here's just one example, and I turn again back to alpha-2 antiplasmin. This is our molecule that prevents clot breakdown. If you look at the amyloidogenicity, and this is the gram, the amelograph that is produced, you can see that the dotted line there, all of those sequences above that shows high amyloidogenicity. So we looked through all of our molecules that we and others have found in proteomics, and we have determined that most of the molecules, the inflammatory molecules, spike protein is another huge amyloidogenic protein. Sophie Nystrom and Per Hammerstedt discovered that in Sweden a few years ago. All of them have got a huge potential to turn molecules that they interact with, but they themselves are amyloidogenic. So if they are amyloidogenic, it means they are sticky. It means they will be in circulation. It means it will cause hyperperfusion injury and damage to the vasculature and drive inflammatory processes. So the next step that we are interested in, that we have been doing, and we've just submitted a preprint on this, is what are the different types of microclot phenotypes? We know they are heterogeneous, and we know they are complex. So we think they are seeding onto debris from damaged blood cells, vessels, cell membranes, immune complexes. We know that they are associated with nets. They can be fibrinogen alone, just interacting and folding on itself because of binding with spike protein. And they can also seed onto blood cells that are still intact, so functioning, but not working as they should. So what do we think what's happening? We think that what is happening is when you have damage by circulating inflammatory molecules, the membranes of white blood cells, red blood cells, endothelial cells become prothrombotic, and they can become debris. So these debris can be in circulation. It happens in healthy individuals as well. However, in a healthy individual, your immune system works well, and your immune cells will get rid of them. In patients with ME/CFS and long COVID, we know that the immune system is muted. So our immune system doesn't get rid of the debris as it should. And these debris parts of breaking down cells just stay in circulation longer than they should, with a muted immune system, a prothrombotic nature, the PS flip or phosphatidylserines flip happening on the membranes, causing them to just become huge little traps for pro-inflammatory molecules. And then the procoagulant and amyloidogenic nature of these molecules cause them to form the seeding areas of these of fibrinogen, as it's prothrombotic, serum amyloid A, which is another hugely amyloidogenic molecule in circulation. And these little areas are then one of the types of phenotypes in circulation that we believe are a huge problem, because the debris of cells breaking down are not removed from our circulation. But then the microclot complexes, as I alluded to in the beginning, can also just seed onto intact cells, although these cells may not be functioning as they should. And here we have seen that they can attach to, this is micrographs from confocal microscopy as well as fluorescent microscopy, they can just attach to all sorts of cells, binding them together, with a blocking capability where the blood doesn't flow as it should, and can actually cause problems for oxygen transport and just functioning and blood flow in general. So, as I mentioned, one of the complexes is just where the fibrinogen molecule interacts with a inflammatory molecule like spike protein. So you have the conventional clotting cascade, but when these inflammatory molecules interact with these soluble fibrinogen molecules, you have a process where the fibrinogen molecule itself becomes insoluble, and it is a little prothrombotic little area without the canonical process of clotting. And obviously they can also be involved with thrombin, but then they form these dense matter deposits that can also be a clot that stays a little bit longer in circulation. So circling back to our work on stroke. So when we're looking back at our red blood cell work on stroke, we also we again saw these dense matter deposits. And in a recent publication with a whole team from University of Liverpool, University of Washington, we looked at actual stroke clots that was taken out or by just getting the little clot out of the brains of the stroke patients. We found that these stroke clots actually do also stain with theoflavin T, showing that a clot, an actual true clot in the stroke clot, a thrombotic clot, also has got a severe amyloid signal. Our latest preprint was at looking at post-viral disease, but also looking at vaccine injury. We did the proteomics, and it was interesting that if you look at fold changes, that the people with post-viral and vaccine injury split out well from those only with long COVID. So it was quite interesting for us to find that there are specific signatures, molecular protein signatures that differ between this group. Then we also looked at exercise-induced changes of microclotting together with cytokine levels with our collaborator, Mark Foy from the University of Derby. So they did 2 CPET interventions, and we looked at the microclot profiles. And what's interesting for us was that it seems after CPET intervention of long COVID patients, we found that it seems as if the bigger microclots break down into smaller microclots afterwards, but they reform again. So we think that microclots are definitely on the pathway of disease. So our paper therefore challenges the rationale of graded exercise therapy, and it underscores that obviously we must be very careful in patients with ME/CFS and long COVID to just force them to do exercise randomly. We are also looking currently at a nanotweezer experiment, and this is a microclot manipulated by a nanotweezer, and we are trying to look how we can manipulate these microclots and bring them together and draw them out and break them up with a nanotweezer. So this is quite interesting work that we will be doing with our physics department. And then our latest findings, and I'm not going to share too much because the paper is coming out, the preprint soon. We have deep dived into the actual what's happening proteomic level, but at sequence level. And the thing that I can say is, together with my team at Stellenbosch and samples from Canada, from POTS and long COVID, we found that we've got post-translational changes on our fibrinogen and other molecules that relates to glycation and glycation end products on certain sequences. And that's a huge thing for us because we think now we might really start to understand the amyloidogenic nature of the molecules. We have also published a paper where we tried to give some sort of methods for clinicians to use, and we discussed how they can search for endothelial damage in this paper. Then, very interesting that we think as a simple test that a clinician can use is nail fold videocapillaroscopy. You look at the nail fold and you can see the rarefication of the vasculature on the nail fold. We think it's a simple way. It's not the be all and end all, but at least you can look if there's some endothelial damage and thrombotic endotheliitis in your patient population. Another very easy method to be used by a clinician in the practice is infrared imaging. So one can see that infrared imaging reveals effect of the impaired vasculature. It's a quite old technique. It's used quite frequently in diabetes, where you can actually see the hot and the cold with infrared areas in the body, suggesting that there are damage and that the blood is not flowing as it should. And then the last thing that I want to do and talk about is the development of a point-of-care microclot detection and characterization device. We call it the MDCD. So this device was built by one of my MEC engineering students, and we know that clinicians definitely not, and many of the researchers do not have access to a microscope. And a Zeiss microscope, the one that we have, costs a lot of money. We built this with a fraction, 1% of the cost. And you can see it's still very much a prototype. But if you look here, this is a microclot, and my student Luanais Palmer spent quite a time on this. She validated with theoflavin T and exposed to microclots or to plasma. She detected she could detect the same microclot on the Zeiss and her MDCD. So her MDCD instrument uses also the various fluorescent type of processes to detect that the Zeiss does. The Zeiss obviously have lots of channels. With our MDCD at this stage, it's just the green channel because we are interested in the theoflavin T. But then I also asked her recently to just look if we could find PAC1 FITC, which is also the green, staining using our MDC, and she did. And look at that. I think the MDCD is actually picking up better than the Zeiss. So what is PAC1 FITC? PAC1 FITC binds, it's the marker, the fluorescent marker that binds to the activated receptor that binds fibrinogen. So it means that if this is, for example, in your circulation, and this is a part of a piece of debris, this part of microclot forms then part of the cellular debris component or complex, and that there is, for sure, FITC, PAC1 receptors for fibrinogen. But what's so interesting as well, as this specific receptor do not only bind fibrinogen, it also binds the hugely amyloidogenic serum amyloid A, the exact same receptor, binds that molecule too. We and others have found that serum amyloid A is significantly increased in patients with long COVID, and also I think in CFS. So it means that the prothrombotic nature is not only driven by damaged fibrinogen and amyloidogenic fibrinogen, it is also most definitely driven by circulating inflammatory molecules like serum amyloid A, which we know is the mother of all amyloid proteins. So we hope with this work, we will be able to take this work further. My student is now completing a master's degree. We are going to go with this into her PhD if she gets funding for it. Tomorrow evening at the Polybio Research Conference, if you would want to pop in at Amy Prohl's conference, Luana is going to go into depth about her MDCD and to explain exactly how she does it and what she did to make this instrument work. So we hope in future we will be able to have a very, very low cost, real proper fluorescent microscope at a fraction of the time that people can use. What is needed in long COVID and post-COVID research? As we all know, we need to stratify phenotypes. We think if we can use fibrinogen, if we can use amyloidogenic nature of microclots, in somewhere in the process, we can at least stratify the patients and group those together that in fact do have a prothrombotic nature and is more prone to clotting abnormalities. We're very excited that we are working with wonderful teams all over the world that is trying out various methodologies to look for microclots. Jeroen Den Dannen's group is doing the same work as Mike van Elzak has worked with PET scans, also where they look for fibrinogen in the body and onto the vasculature. We hope that those research efforts will really tell us. Sorry, can you hear me? I think I'm off. Can you hear me now? So that those type of research will really show us what is happening to the vasculature and how clotting pathologies are impacting patients suffering from long COVID. We have patented our method early in 2021. So the microclot testing method is actually available now in some places overseas where we actually test patient samples at selected pathology labs and we use imaging flow cytometry. And this is some of the places, and we have a new collaborator in the UK, PeploBio, that will also be very soon start using the test in the UK as well. The problem with that obviously is still an imaging flow cytometer method. However, Biocode Technologies, our company, is working very hard to try to optimize the method for a normal flow cytometer. And I must report that we have done it successfully so far. We are co-staining with various markers. So we're not only using theoflavin T anymore, and hopefully those type of methods will be available very soon for patients all over the world. This is my wonderful team. I cannot do my work without them. Some of them sitting there at the back. It's really a team of passion. We like to work very hard and see where our research takes us. And we hope that sometime in the future, these type of tests that we can produce in our lab will be available for every single patient, not only for selected few. Thank you very much.
Thank you. Fantastic talk. So maybe I will ask you to take a seat and for Michael to also join us. And online, I don't know if Nancy is available, and we take the questions in together.
While we get settled, can we just round of applause to Dr. Pistorius' research team?
Some more questions. There's two more online. I'm just transcribing them.
Okay, so first question. Before Nuno asks the question, let's transmit to you one question, since you were the first one to give a talk, that we received from the online audience. Has anyone ever studied the overlap between ADHD and ME? And do both shared acquired neuroinflammation as a starting point or similar risk factors?
Yeah, good question. So the question is ADHD and ME. Yeah, my understanding is that there's a overrepresentation of ADHD in patients that have been diagnosed with ME. And whether or not it's driven by neuroinflammation, I don't think that ADHD is thought to be largely driven by neuroinflammation, but it is at least largely the effects are within that same circuitry that I was describing. So the anterior mid-cingulate and superior parietal cortex circuitry is the exact circuitry that's disrupted in ADHD that gets normalized by Ritalin during development, for example.
Thank you. Nuno.
Hi. No, great talk. My question is to Rezia, and I just wanted to ask you about this alpha-2 antiplasmin. Just connecting with yesterday's Decode ME. I was just wondering if actually this protein could be a candidate for some kind of genetic association that will increase. Have you done something about genetic associations with the protein? Or
That's a very interesting question. We have not ourselves looked at the genetic component, but it will be really interesting, I think, if the decode, if someone working on that samples, if they could actually look at that, because that would give us some indication if there's some genetic reason why alpha-2 antiplasmin is upregulated. Because we haven't come to any conclusion why it's upregulated. Obviously, it's produced also in the liver, and it would be really interesting to. But we also found some other molecules, other proteins that's also blocking the process of breakdown, and we think it's specifically interesting that it is probably associated with spike, but we haven't done the genetics. It would be very interesting.
Let me ask now a question to Dr. Kleimer. That was something that we received also from online participants. Why did some patients do not respond to the antibody therapy, to the CPA, VRT therapy that you mentioned? And why does influenza viruses sometimes do diabetes type syndromes and sometimes ME/CFS?
Well, the first question is easier for me to answer since we're doing the study. Well, no, but we don't think that everybody with long COVID necessarily has a reservoir of antigen. So we just don't have an easy way to measure the entire reservoir since it's hiding in solid tissue. So I think we'll hope to find a subgroup that should have a lot less immunologic antigenic drive if we could remove that much antigen. I also don't know if the dose that we're using is the right dose. We're using the dose that was approved as a repurposed drug. It was the IND requirement. So we're using a single dose. The drug has a 90-day half-life, but so it'll last for a long time, but we don't know if it's enough to mop up sufficient antigen to really start clearing the reservoir. So we'll find out with a study like this where we powered it to pick up a relatively small, 25% or greater subgroup. And the influenza diabetes question, I honestly don't know the answer to that question, so I'll pass.
Thank you. We have a question there.
My name is João Vink. I'm a clinician. I'm basically pulmonologist. And when I come tomorrow to my clinic, I would like to ask Dr. Kleimer about what would you recommend for screening for viral reactivation and for lymphocyte subpopulation. So what would you say to me as a clinician I should order tomorrow for my new patient that comes to my office? So how would I, with all that info, amazing information that you gave us, how can we do that on our day-to-day basis? Thank you.
Yes, I appreciate the question. So in our clinic, we measure the serology. We use the EBV panel, which includes early antigen, BCA, EDNA, IgG, and then IgM to VCA. So that's 4 EBV antibody tests to give you a pattern of old versus reactivated versus new infection. HHV6, I don't know how widely it's available. It is available. The HHV6 titer of 1 to 160 or greater was what predicted response in Dr. Montoya's Valsite study. So I would imagine that's clinically relevant if it's a high titer. You can PCR, but again, like I said, do that more than once. I wouldn't just do it as a single screening test. The other viruses are harder to follow and less likely to be found, like CMV and the Coxsackie B virus. You can look at the serology, but that doesn't tell you if it's reactivated. Coxsackie B is the virus, yeah.
I think there is a follow-up.
Yeah, just about the immune cells. So what would you recommend about lymphocyte subpopulations? What should we ask for?
So I guess my clinic's a little special because it's an immunology clinic and I have a high complexity laboratory that I can refer to. So I get flow cytometry panel that looks at more than CD4, CD8 NK cell number. What's broken here is NK cell function. So the NK cell number could be low, but NK cell function is low. And then in the flow panel, it's not too helpful unless you start adding some activation markers or senescence markers. Now the question is, what would you do with that clinical information, and should you run it if you don't have a intervention that you plan to do that's targeting that? I think with the viruses, you should know if they're there, and there are some antivirals you could try and see if they respond, even the ones that are less active, like acyclovir, famciclovir, valganciclovir, but sometimes they're helpful. With the flow panels, they would direct you towards therapies that try to restore immune function, and those aren't readily available. Those are more research than they are clinically available.
Thank you. Before we go to the next question, just a follow up on this one, Nancy. You are mentioning the dysregulation of the NK cells. There is a paper coming up in Natural Immunology from a German group from Li Yang, a consortium. My former PhD student is the first author, so I'm very proud, that found using single cell transcriptomics that the major defect in long COVID peripheral blood cells is related with mononuclear cells, so monocytes and so on. So do you think that this difference between NK cells do not seem to have a particular phenotype? Do you think that this may be due to the fact that there is a heterogeneity among the patients, or there is a hierarchy of defects among these different circulating blood subsets?
Well, yeah, I think there's considerable abnormalities in the cell types, and that the innate immune system seems to be more impacted than the adaptive. So the monocytes make sense. They also make an awful lot of inflammatory cytokines. So it makes sense that they could be important in the mediation of the illness. So I just think you're going to see more than one cell type being impacted. And for sure, we know that. There's a lot of studies to demonstrate that.
Thank you. Miguel Castelo Branco.
Okay, I will be very brief. So I do brain imaging, so my questions are focused on the talk of Michael. So we use at our center also neuroinflammation marker called PK, and we do some studies on neurodegenerative disorders. My first question is technical. You use the cerebellum, sorry for the rest of the audience, but it's really a technical question. You use as the reference region the cerebellum. My question is that in the cerebellum, you also have microglia. So this makes you would like to have a reference region without activated microglia. Maybe this is not my most important question, but I'm curious. I have another question that I think it's important more for the audience, but I would like, should I say already the second question? The second question is that you identify brain regions with increased inflammation sensitivity as an explanation to brain fog. So I have to be honest, I don't like the term brain fog. For a neuroscientist, it's a very foggy term. I would like to be a bit more objective, but this is just a comment, not to your talk in general. But so you mentioned the activation in the mid-anterior cingulate and in the vagus nerve. So, but I also saw other regions. For instance, imagine that you have activation of the locus coeruleus. The autonomic dysautonomia would be completely different. So, and this would explain why patients have so different symptoms when we talk about cognitive symptoms. So these are basically my questions, with a small third one, which is, what do you mean by inflammation sensitivity of a brain region? Is it just more increased microclot activation? And I'm done. Sorry for all these questions.
So the cerebellum normalized, we used SUVRs. We also did it with using occipital region as the normalization region and found similar. There's no brain region that lacks, these sorts of cells. So it is sort of a standard approach. We have A-line data that we'll also use from a subset of the patients. About a third of the patients with the ME group got arterial lines. So basically the question is, how do you know what to normalize to, basically? And so we have arterial line blood that we can also normalize to, and that'll be the next step. So yeah, brain fog is just sort of a colloquial term that people use, and it's technically cognitive control is what we measured. But the issue is that it's more than just cognitive control that people experience. So, let's see, your other question was about the specific brain regions.
Locus ceruleus.
Locus ceruleus, yeah. So the reason that I showed the figure, which was figure 5 in the paper that we wrote a couple of years ago, the long COVID paper, was to show the overlap of the nucleus of the solitary tract with some of the autonomic regions. And you're right, I mean, it's not just locus ceruleus, but the dorsal raphe would be right there as well. So, ventral tegmental and all that would be a little bit higher. But the issue is that when these regions get activated, the immune cells sort of pump out excitatory modulators that we think is going to just disrupt the sort of delicate signal to noise signaling that ought to be happening there. And so, yeah, there's going to be sort of cascading effects. It's challenging because there's going to be slight anatomical differences, especially in brainstem. So we don't really know that that's locus ceruleus, but yes, there's sort of activation all over there, more or less in patients, and that surely will be part of the reason that they're experiencing symptoms, I would think.
Thank you.
And before going here, I want to transmit another one from the audience online to Dr. Pretorius. 2 questions, 2 parts. Do all long COVID patients display microclots, or are there subtypes of patients with and without microclots? And the second one is, any thoughts on what is driving persistent clotting in long COVID patients who improve on anticoagulant therapy, but then deteriorate after the therapy is stopped?
Thank you. Those are very important questions. The first one, do all long COVID patients have microclots? Yes, they do. There's also microclots in healthy individuals, much lower levels, and they are also in diabetes, rheumatoid arthritis, and other diseases. What we are trying to figure out is the size and the numbers, how different they are, but in our experience, long COVID patients have much more than diabetes and other types of diseases, including ME/CFS. But the bigger question that we are trying to discuss and to unravel is, what are the biochemical nature of these structures? So if you are healthy and you've got a few microclots, your body takes care of it, your immune system is working, you don't have so much cellular debris, so your seeding areas is much less. The problem with long COVID is your immune system is muted in some instances, that doesn't function as it should. Debris is not removed sufficiently. Prothrombotic areas are formed. All of the inflammatory molecules that are entrapped in it, nets are associated with it to stabilize it, to make it structurally stable for breakdown, perhaps not so easy to break down, together with alpha to antiplasmin or similar molecules in circulation. So the question is rather, what is the biochemical nature of these structures compared to the number and the sizes? But in our minds, yes, long COVID's got much more. Now, the question of treatment, so some people have been using anticoagulation therapy, where when they are on the anticoagulation therapy, they become much better because of the fact that the body just reduces the clot formation, so you get much less microclots to form in the first place. Some people have also been using nattokinase, lumbrokinase, serrapeptase, that are enzymes that enzymatically break up these deposits. But there's some individuals who, if they go off these therapies, they relapse and they again form microclots. So my only explanation for that is that somewhere in the body there must be viral persistence, spewing out spike protein, forming new microclots that are structurally difficult to break down by the body itself, or by by breaking up via the normal plasmin process, or then if the immune system is still muted, if there's spike protein in circulation, there will always be a trigger for prothrombotic little deposits to form. So I think that's the main issue. So my hope is in the near future, we will have some medication that will get rid of the viral persistence, get rid of the proteins that is in the first place the triggers of these abnormal clotting, and then together with clot busting medications or clot preventing medications, and obviously there's lots of dangers with anticoagulation, as we all know, so be very careful when we take it, but perhaps there's then a utility for those type to be added after this initial onslaught of viral persistence is removed from the body.
There's a question in the audience over there.
Here, I'm Giada Daros, president of the CFS and Italian Association, and I've been a patient for 35 years. I was severe for some 20 years, and now I'm more or less moderate and improving constantly. So my question is, are you doing or planning to do longitudinal studies, especially with those patients whose severity changes through time, to see the difference that can be there? Thank you.
So maybe I'll ask Nancy Climate to answer this question.
So absolutely, longitudinal. One of the huge advantages of having an illness that started with a very clear and a very clear bug that's so ME/CFS-like, that we're going to learn from long COVID, is that we do have these very large cohorts that are being followed from acute infection all the way through years now of follow-up. The Recovery Initiative at the NIH has 15,000 patients in a longitudinal study. That's no small number. And there are a lot of other studies that are following longitudinally. I will say from my own ME/CFS experience, and it sounds like yours as a patient, it changes over time. And one of the things we need to be aware of with our long COVID patients is that in ME/CFS, the most inflammatory time is the first 3 years. And then it shifts. It doesn't stop being inflammatory. It's slightly less inflammatory, but it gets more autoimmune, more autonomic, more other things going on with duration, which makes sense. So I think that the long COVID people that are clinicians can learn a lot from the ME/CFS clinicians who've been doing it for decades. And I also think that the ME/CFS community is looking forward to the investment of scientific dollars that's going into long COVID that might untangle much of what we really need to know to have effective therapy for ME/CFS.
Thank you. There is another question in the audience over there.
My name is Emily Kate Stevens. I'm a journalist, and I've actually had the privilege of talking to all three of the speakers, and I would just like to thank all three of you for your incredible work over the last, well, particularly for me, over the last 5 years. My question's for Mike. You talked about the increased energy requirement that you saw in the anterior mid-cingulate in your ME/CFS and long COVID patients. And I just wondered, do you think that requirement for additional energy in the brain is one of the things that is a driver in the huge fatigue that these patients are seeing? Is it the driver that way? We were talking yesterday about efferent and afferent. Or do you think it's all the other things, the autoantibodies, the vasculature problems, the muscular problems that are driving the problems with energy use in the brain?
Yeah, so, technically what that measurement is, the fMRI bold response, is just the flow of blood. Hemoglobin has iron in it, and so you can detect the movement of blood with strong magnets. And so all it's showing is that more blood was needed to mobilize to engage in that task. You know, the brain uses a disproportionate amount of energy relative to the rest of the body. So, you know, I don't want to just assert that that's part of why people feel tired. I don't know that for sure, but it is the case that the brain uses a disproportionate amount of energy. I suspect that it's sort of everything else as well. You know, I mean, if there's less perfusion, you know, et cetera, all the other things that people have talked about over the last day and a half is probably adding up. Yeah, that would kind of be my way of thinking about it, yeah.
Thank you. Another question from the audience to Nancy Kleiman. What are your thoughts on giving monoclonal antibodies to long COVID patients with very high antibodies to spike? And are there medicines helping patients with this type of hyperimmune response to early variants?
So Andrew Shaw has some beautiful data on people with high titer antibody and low titer antibody. And he shows that in long COVID, 75% of people with long COVID don't maintain their antibody response and have patchy holes of antibody coverage. But 25% aren't like that. Of that, I think 15% look pretty normal, but 10% are these hyper immune responders that have very high titers. And in that group, there are some people that are still missing, you know, the variant that matters to them, that they might be a hole. But he perceives the hyperimmune people as the people that are getting vaccine injuries and that type of thing, that they have this very brisk immune response. The majority, though, is fitting in this group that haven't been able to maintain their humoral response to the variants they've been exposed to or the vaccines that they've been exposed to. So we will be doing work with his group with our biorepository when we get done with the study and we can unblind everything and all that. So we'll be able to see if we have responders that are predicted by the kind of baseline antibody patterns that they had and whether or not the monoclonal fills those holes. He does have a few patients that he's got longitudinal data where the monoclonal antibody therapies did fill the holes. So just, you know, a handful of patients that he's seen as open label patients. So I think that's probably the right answer to that question. I mean, I will say this is an early study. Mike Palusa did a study with a different monoclonal and a smaller N and did not get a clinical response that was a primary, he didn't meet his primary outcome variable. And that was disappointing last spring. But it was a small pilot, and this is a better powered study, and it is a different product. So perhaps we'll see something different. We'll see.
Okay, and the last question is from the audience here.
Ricia, David Sistrom from Boston. Quick question about your 2-day CPET study. Did the development of either microclot number or size provoked by the first exercise bout influence the second exercise bout, VO2 max, anaerobic threshold, or the development of PEM, post-exertional malaise?
The CPET study was done at Markvar, his laboratory in University of Derby. So I don't think the microclots necessarily, well, we don't know if the microclots necessarily affected the VO max or whether it's the microclots or just how the patient reacted to the CPET. But what I can say about the study, it was also chosen, the participants were chosen not to have severe post-exertional malaise. They were on the, you know, he didn't want to put very sick patients through this process. So I don't think his patients necessarily developed PEM after the CPET. But what we did find was that the bigger microclots broke down after CPET 1, but then they reformed, and and then the process was changed. So we could see the bigger clots becoming less, but the less clots becoming more. So we think it's a reform and form process, and obviously that might influence post-exertional malaise, I'm sure, if you have got a sick enough individual.
So I just want to finish by thanking all the participants of this panel and also all the audience here and online for this lively discussion. Thank you very much.
Good morning. I will start with good news. We are on time. In Portugal, this is not as often as you used to think, by the way. So we are starting block number 3, dedicated to peripheral mechanisms of post-exertional impairment, crashing after, I like the word crashing, by the way, crashing after effort, muscle dysfunction, and exertional physiology in MI, CFS, and Long COVID. And the first speaker, I'm sorry, is Professor Rob Woest. Professor Rob Woest, thank you very much for coming to Porto. Professor Rob Woest is assistant professor at the Department of Human Movement Sciences at VU University, Amsterdam, a fantastic city, by the way. And he is going to talk about microvascular and mitochondrial abnormalities in skeletal muscle in MI, SFC, and Long COVID. Thank you for coming.
Muito obrigado. Eu prometi a minha mulher portuguesa que começa em português. Right? Oh, no, wait, no, espera. Oh, this one. Espera. Vou falar sobre as anomalias microvasculares e mitocôndrias no músculo esquelético, no EM e na COVID longa. Vou falar continua em inglês. This is an image that we made recently that illustrates the problems that people with long COVID and ME going through when they are going through physical exertion. Brain fog, changes in muscle pain and fatigue are worsening, and other symptoms worsen too. So this is going to be the main topic of today's talk. I don't have to talk you through a lot of the symptoms and the hypotheses that underlie long COVID and the NME CFS, but I just want to highlight some of the work that we did in this field, particularly because we're interested as skeletal muscle physiologists in changes, particularly here at the limited exercise capacity and post-exertional malaise in patients. We don't know the reasons for it. We have heard various hypotheses that have been put out in the literature, including autonomous nervous dysfunction in the immune system, of course, that is dysregulated. Blood clotting, as Professor Pretorius already mentioned, may contribute. But also, we are, as skeletal muscle physiologists, we are looking specifically at the skeletal muscle system. So to summarize roughly what post-exertional malaise is, or PEM, it's the worsening of general symptoms, or actually the development of new symptoms, typically within 2 days after physical, cognitive, or mental exertion. The threshold for patients is typically patient-specific and can vary over time. We don't know the threshold, but I'll go we're working a little bit on this. I'll focus on one slide in my presentation on maybe finding the threshold or finding the risk area. We don't know the threshold, but we do know that the post-exertional malaise can last for days, weeks, or even months, or can even set back patients continuously. We do know it's a cardinal symptom of both long COVID and ME/CFS, and likely also other post-acute infectious diseases. So there's a commonality in the pathophysiology that we think is really important to get a better understanding about, because that may give us a better understanding about the disease itself. Important factor to remember is that patients tell us that PEM comes with different flavors. So some people have more problems with physical PEM, others have more with cognitive exertion. And that's really not really a good diagnostic criterion. So we're working with a group in Vienna to see whether we can get better ideas about these different flavors of the PEM and what is the underlying mechanism essentially that drives these changes. So one important thing to remember for clinicians is that if you see patients in your clinic, they may look perfectly fine when they sit in front of you. They may act perfectly okay. They may speak fine. You don't see anything. They don't have any problems. That's often the reason why these people are sent back home with we can't find a problem. We don't know why you're sick. But actually, as a clinician, I really would stress for clinicians to look the day after, because particularly the day after, patients can be really feeling ill, can be more homebound, sitting in rooms with the curtains closed to really get rid of all visual or sensory input. So it's really important to look particularly at the days when people are feeling ill, because that really brings up the disease. But as an exercise physiologist, I'm most interested in what happens in the body. We don't see patients ourselves, but we wanted to understand better the physical changes that happen in the patients with the induction of post-exertional malaise. So my next speaker today is going to talk about a 2D exercise test. We didn't use that particular method. We wanted to opt for a 2D biopsy, skeletal muscle biopsy test. So what we did is we took a skeletal muscle biopsy of 25 patients with long COVID. Now also we have 26 patients with ME/CFS and 30 controls, 7 days before asking them to undergo a cardiopulmonary exercise test. We do that test for two reasons. We do that to induce post-exertional malaise, but also to test their body exercise tolerance and exercise capacity, so that we can see what is limited, what is changing with what is underlying the limited exercise capacity, and what changes with the PEM induction. Because the day after, we asked them patients back into the hospital, and we took another muscle biopsy from the vastus lateralis, and we took blood and also biopsies. So the publication that we published on this has attracted a lot of attention a year and a half ago, including a lot of letters sent to the editor about this particular paper, because we got criticized extensively for some aspects that I'll try to now rebut in the next 10 minutes. I will not talk a lot about this paper because it got so much attention that we want to continue essentially with showing the newest data in the group. But just to get you on the same page, this is the one-page summary of this particular paper, because we found essentially contributions to the reduced exercise capacity in patients with long COVID. That included the fact that the mitochondrial function was reduced. We saw more metabolites that relate to fatigue, more glycolytic fibers, and they don't change when you induce PEM. They are really like structural changes in the skeletal muscle. However, the changes that we think are related to the post-exertional malaise induction are really rapid changes of local and systemic metabolism. But we also spotted that markers for inflammatory inflammation and markers for muscle damage were increased upon the induction of post-exertional malaise. We also spotted this amyloid-like structures into skeletal muscle that Reza Pretorius was talking about earlier, and we're now finding out there's a poster outside that where we think we now know what these amyloid-like structures are. Importantly, it's to realize for patients that this work also has some practical implications. So we got a lot of questions. So I should really stop doing any exercise. Now that's not actually the case. We don't show that any exercise is better. We only show that exercise above this PEM threshold causes these things. So what patients are always advised by the clinicians that know about the disease, that pacing is important. So patients are encouraged to exercise below this particular threshold, and specifically the thresholds that do not lead to PEM. So using your watches, using variables, we think that heart rate variability may be one of those factors that can track your activity over time, where you can see whether you don't go over this particular threshold. And a student, a recent student of me, the paper is currently under review, but there's also at a preprint as well. We studied whether the heart rate variability is a useful marker to help patients with deciding to which intensities are safe. And what we think now is that around the ventilatory threshold 1 or the gas exchange threshold, that's a moment essentially where something in the body changes that induces this post-exertional malaise. We don't exactly know what it is, because also cognitive and mental exertion can induce PEM. So we think there's something happening around that threshold that increases the risk to become where PEM can be implemented or can be started essentially. And what we saw on the image on the right hand side is that in the white circles, the healthy controls, they increased their heart rate variability very rapidly, relatively rapidly upon exercise above this threshold, close to this threshold. With patients that are mild and moderately affected, they had a very longer duration of the recovery period. And some very severe patients did not even increase the heart rate variability to levels similar to the controls. So we think that maybe that's a good way for practical implications of PEM induction and avoiding PEM induction. But let's go back a little bit and talk about the different hypotheses that underlie these changes that we see in the skeletal muscle. This is a recent paper that Braden in the back, and actually all the other people, all the other students are sitting in the back, so well done, guys. They worked on. We summarized the literature and came up with different hypotheses that can underlie the change that we see in the skeletal muscle. Local hypoxia may be one, ischemia perfusion, as I mentioned before, what Professor Pretorius mentioned before. I'll go into this later today as well, is one of them. Deconditioning, people are just lazy, they're not doing anything, so that's been a major accusation of our work. I will try to rebut it in the next slide. And the electrophysiological changes are changes in the calcium, sodium channels in the skeletal muscle. Underline this is work that has been done in particularly in Germany. And we also may think that autoimmunity play a role, but we don't know so much about it. So we really want to work more on this particular aspect too in the future. One aspect that should be not forgotten is that also central fatigue plays a role. And this is not the same as that I just don't want to contract my muscles and I just don't want to exercise. It's something else. It can well be that there are changes happening in the brain that affect the excitability of the neurons to the skeletal muscle, and there's a real physiological reason why you do not or cannot contract your skeletal muscles to the same extent as a healthy control. So what is this deconditioning thing? And that was super good coincidence essentially that Braden and another PhD student in our lab, Moritz, was sitting right next to each other, where Braden did the exercise testing with the long COVID patients, and Moritz did a study on bed rest. So it was super simple to say, look, guys, you just need to collaborate now and work together and solve this problem where people are accusing us that deconditioning causes all the problems that we see in our skeletal muscle. So this is the preprint that was published early this year and is now under review. And we're very grateful that we got some really nice feedback from people. So just to give you a bit of an understanding what is a bed rest study, this is a study that was sponsored by ESA and NASA just before the COVID hit, actually. It's done in Germany in a specific setting where healthy people, healthy normal people voluntarily lay in bed for 60 days. Everything had to be done horizontal. Brushing your teeth, washing, go to the toilet, everything was horizontal. And what we did in those particular participants, we took muscle biopsies before and after 6 days and after 55 days. So that's a completely different project in our lab. But because we knew what happens after 55 days of laying in bed, we could compare the groups. So here in figure A, you see the bed rest study where we did skeletal muscle biopsies before and after 55 days of bed rest. And there was a longitudinal cohort. And we had the 3 cohorts, the controls, the long COVIDs, and the ME/CFS patients as a comparison. If the longitudinal changes that we see with bed rest are similar as what we see in the patients, then we say maybe they can be one-to-one related. If not, then there's something else going on. So what we did is that we looked at the VO2 max, the maximum oxygen uptake consumption of patients before and after bed, and also before and after bed rest. And the figures are very similar in the sense we're in the black and white. On the left-hand side are the before and after bed rest, and then on the right-hand side are the patient populations. And you see that both of them are similar. Both interventions essentially, or both conditions, are similarly reduced. The gas exchange threshold is slightly different. The effects are slightly different, but technically from the outside you can say, well, something the same is happening in both conditions, so it's all to do with the conditioning. Now that's actually not the case, of course, because we looked into more detail and we also knew that this was not the case. Because if you look at markers for mitochondrial function, they were quickly reduced upon bed rest. Bed rest reduced mitochondrial function and mitochondrial density equally. But we saw that particularly in the long COVID patients, the mitochondria were there, but they did not function well. And if we correlated these two together on the bottom line, you see that the SDH activity, which is a marker for mitochondrial density, correlated very nicely in the bed rest participants, and in the healthy controls, but did not correlate at all in the patients with long COVID and ME/CFS. I don't have a pointer here, but you can see in the figure C on the right-hand side, the colored circles do not show any correlation between X and Y. And the same happened if we would use a different marker for mitochondrial respiration, mitochondrial function on the figures that you see in D. Similarly, bed rest, there was a nice correlation between the two markers, but no such correlation in both the patient populations. So really they're differently affected. And if we zoomed in, this is the work that Jelle does in our lab, looking into the electron microscopy. We see really big abnormalities with the cristae, with the functional units essentially of mitochondria, in particular long COVID, but also we see that same thing happening with ME/CFS. So you see on the right-hand side a mitochondrial that's completely devoid of these cristae, which is really important for producing the energy in skeletal muscle. And this, of course, we did not see after bed rest whatsoever. Now we're changing topics a little bit because we had no clue why these changes that we see in the mitochondria are happening. And one of them could be because there is a problem with the microvascular function. And this here comes the FIC principle, and I'm pretty sure that that Professor Sistrom will talk about this too later on today. But we just to go a little bit quicker into this, we expected that there was a problem in the periphery and not so much in the direct heart rate or stroke volume part of the equation. And we of course couldn't measure this atrial venous oxygen differences. That's something that you would have to do an invasive CPAP for. But we could at least identify that maybe something peripherally is happening here. And this is what we did. So these are measurements of the capillary density, capillary markers in long COVID and ME/CFS. And we see that the capillary to fiber ratio, the capillary supply to the skeletal muscle, was only negatively affected in patients with ME/CFS and not so much with long COVID. By the way, these changes do happen extensively with bed rest, but I'll not show you these ones here today. Now, something that Anouk, who's also sitting in the back here, really noticed at some point during her internship. She said, well, there's something strange happening with these stainings that we got back from our pathology department about the collagen stainings, which we initially sort of discarded because they didn't show the things that we sort of were interested in. She said, look, there's something happening in these sections, because in the top right, you see a healthy control. You see for every circle of a red dot, you see a white little point inside, the lumen of every capillary. But if you look at the patients with long COVID and ME/CFS further down, we did not pick up this particular white dot in the middle. The lumen size was really reduced. So she spent a lot of time, and I thank you very much, Anouk, for doing this work, because this has really changed our understanding of the underlying reasons why we see these changes. Is that the basal membrane thickness, or the thickness essentially of the capillary, was significantly and highly significantly different between the patients and the controls. There was no difference, by the way, between long COVID and ME/CFS. But then if you looked at the radius, the lumen size essentially of that white dot in the middle of the capillary, there was a complete separation between the groups. Everything above a value of 1.35 we regarded as a control participant. You're in the middle image. And anything below 1.35 was a patient. There was a complete separation between the groups. And interestingly, particularly in the patients, but not in the controls, the amount of the capillaries versus the lumen size, so the potential essentially for oxygen and delivery or nutrient delivery, correlated relatively perfectly with the peak power output that they attained on the bike. So a non-invasive marker for the exercise capacity, related perfectly with this particular marker for microvascular flow. So we're diving into this more, and we really think that the gas diffusion essentially is really the problem here. Now, because both Anouk and Jelle both worked on the same projects, Jelle started looking into the endothelial cells abnormalities, because we could measure them as well with our electron microscopy. And on the bottom, you see 4 images of healthy capillaries. You see a nice lining with an endothelial layer around there, which is thin, which is relatively round, is not so much problematic. But on the top right, you see an image from a capillary of long COVID patients, and it's really swollen, it's big, it has lots of different things. So let's zoom into this a little bit. So you see that the endothelial cells are really activated, and they're really actually expressing lots of these small vesicles. And we see this throughout different types of patients, and we're currently analyzing all this data. But what you see is that there are vesicles that excrete things into the circulation from these endothelial cells. And there are some other markers that also we think are related to an endotheliopathy. And of course, the thickening of this wall essentially from the endothelials to the outside is really is also important to realize. This basal membrane thickness really reduces the capacity for oxygen flow across the endothelial layer and the basal membrane layer. So we do see changes, similar changes happening in our histology sections, which really cost you maybe 10 cents in the pathology department, and this endothelial markers on the high-end microscopy level. So I think microvascular dysfunction plays a big role in long COVID and ME/CFS. Reduced lumen space, I've just mentioned before, endothelial activation and dysfunction, and then Anouk's poster showed some more additional images, additional information about this project. And we do really think that it reduces the metabolite removal, but also oxygen and nutrient delivery, predisposes patients to more fatigue. And of course, what we really want to do is, because we're thinking that maybe this is a diagnostic marker or a confirmation diagnostic marker, we're looking for independent validation cohorts, maybe not only in skeletal muscle, but also skin biopsies where we could measure something similar. So I really would be interested to talk to you afterwards. One of the last things that I want to mention here is one of the things that worked up, that came out of our work, is a phase 2 trial that will start soon, where we collaborate with a mitochondrial company in the Netherlands called Condrion, where we are going to give patients a particular drug that has been developed for patients with genetic metabolic diseases. And maybe protecting the mitochondria from becoming damaged, we can improve their exercise capacity, reduce their fatigability, and increase eventually the PEM threshold. That's, I think, our final goal, is we want to increase the PEM threshold and shorten the PEM duration, eventually also improving quality of life. So the take-home messages for today are that the patients with long COVID and ME/CFS suffer from post-exertional malaise. Mitochondrial abnormalities have been extensively described with patients. We also see it in the skeletal muscle. We don't know the X factor that causes PEM, but we do see that there can be different from the contributing factors to the reduced exercise capacity. We really are confident that the skeletal muscle alterations that we see are different from those after strict bed rest, and that microvascular adaptations may be valuable, like confirmation diagnostics for the disease, and also in further understanding the pathophysiology. And with that, I would like to thank the collaborators, particularly Braden, Jelle, Anouk and Koen are sitting in the back. Without you, I would not be able to stand here. Patients, participants, and also all our reviewers of grants and publications. Has really been a great work. And I think it's getting time for lunch, but obrigado.
Stay here. No, stay with me. We have 5 minutes to lunch, so I think we can use these 5 minutes to ask some burning questions. I forgot to introduce myself. I'm Philip Frois. I'm Portuguese. I'm a clinician. I'm a pulmonologist and intensive care physician. I don't work in Porto, by the way. I work in Lisbon. And I see one question from the floor.
Hi, Rob. Thank you so much for your lovely presentation. My name is Joanna. I am a colleague, a doctor, but also the partner of a person with long COVID. My question goes to you about the heart rate that you measured, which seems to be lower, if I understand correctly, in long COVID and ME/CFS patients as a response to exercise, which goes a little bit against, if I'm right, and if I understood well.
No, let's explain it first, because I think it's helpful to get the image back up. This one here.
That one.
So it's not a heart rate itself, it's a heart rate variability. So the variability between every heart rate.
Right. Okay.
So that is really lower. What we typically see is the heart rate is either the same or a bit higher in patients with long COVID. This is only done in patients with long COVID that have been referred to a sports physician. So this is an observational retrospective study, essentially. Yeah. So we have no clue essentially what they exactly did, but what we see is that when the heart rate goes over a certain value, we know that they are going into the anaerobic area, or close to the anaerobic area, switch to thresholds. And then we don't see the same recovery essentially over the time of 24 hours.
Okay, that makes more sense, because I think Joanna Squires yesterday, a colleague from Boston, presented,
exactly.
an increased heart rate and IC-PET. So
yeah, but this is completely different. This is wearables.
For the clarification.
Yeah, but there's also a preprint that you can read the whole paper.
We still have 3 minutes. If nobody asks, I'll ask. I'm a clinician. I see patients. You have a question over there? Okay, carry on. I'm a clinician. I see patients. I have a lot of work. Most of the times we don't have time to research. So we listen to the complaints of the patients. How did you stratify the severity of long COVID patients? Did you use, for example, patients with higher infection in beginning, hospital admissions, ICU admissions, more symptoms, more age? How did you stratify?
So I think this is a very important question. So there are two ways to look at this. So for the studies that we did our muscle biopsies on, they're all mild patients that are able to come to the hospital for work. They have none of them have been admitted to the hospital during the acute phase. So they all had a mild infection, and then the long COVID symptoms developed afterwards. Based on questionnaires, there you can do various questionnaires. To the FunCap is a very good one, I think, where you can stratify patients based on severity. However, on the image that you see on the slide here, the patients were classified based on mild, moderate, based on the oxygen consumption at the ventilatory threshold, which is what you can do on daily life activity. So the moderate patients here had an excess capacity, so to say, where it was already limiting daily life activity. That's what we call them, the moderate severe patients in the image on the slide here. Short question, maybe.
A very short question now. 2 minutes.
Short question. For non-doctors, and people that are watching that are also not doctors, if you'd find a way to protect the mitochondria, how long would it take for them to self-replace? What timeline would we be looking at?
Short but difficult question. The trial, I'll answer it in two sides. So the drug has been used in genetic metabolic diseases where they see an improvement in quality of life after a treatment of 15 weeks. We don't know whether that's enough to change the mitochondrial biogenesis and turnover rate, but we know from the exercise physiology field that can be faster. However, with a drug, we would so I wouldn't expect that I think the turnover rate is faster than 15 weeks for sure. 15 weeks. So the drug duration is 15 weeks. Does that answer your question? Maybe, yeah.
It does, but we need to get to why they're getting damaged so they don't self-repeat. Or can the patients be on that drug on a continuous basis to have at least an improvement on the quality of life?
Yeah, so they will. Bad mitochondria will typically always get renewed, and we don't think that specifically affected too much. I'm saying too much now because we have some recent data that may change the idea a little bit. The turnover rates, but it's more the damage that we have tried to avoid with this particular drug.
No, it's lunchtime, but I know some Dutch words. Dank wel.
Thank you.
Thank you.
Obrigado.
Thank you very much for that introduction, and thank you for having me here today. This is the perfect talk for post-lunch. I'm a little post-absorptive. There's not a lot of blood flow going to my brain, so I'm going to do the best I can here. But we will not be talking about molecules for the next 20 minutes, if that helps. I've been doing the 2-day cardiopulmonary exercise test protocol to provide objective evidence of impairment for about 20 plus years. Can you hear me? Okay. For about 20 plus years. I've done it for various research projects. We've also used this protocol probably most frequently to provide objective evidence of impairment for people with fatiguing illnesses who in the United States are seeking disability or Social Security disability through their private insurer. So what I'm going to talk about today is a brief overview or the characteristics of post-exertional malaise, which I know you all know about. I'm just going to remind you because I know there's a strong online presence here, and I continue to be surprised and amazed that I still have to talk to people who come in for testing about post-exertional malaise because it's really not fully understood. We don't fully understand it, but they understand less of it. And I think it's important to just review that again. I'm going to talk about why we started using a cardiopulmonary exercise test for assessing post-exertional malaise. And not exactly, that's a whole different talk, but how you can use information from a cardiopulmonary exercise test protocol to assess impairment. So I just want to thank you again for bringing me here to Portugal. I know it's raining. I've heard over and over this is not typical weather, but what you're looking at here is what I'm going home to. So 8 inches of snow, 45 minutes from my house yesterday. So I'm still glad to be here. In 2015, the Institute of Medicine, now called the National Academy of Medicine, prepared a report which had 4 major objectives to it. And one major objective was to simplify the diagnostic criteria for ME/CFS. And this is what they came up with. And this is the clinical diagnostic criteria. And that's important to remember. I think it was pointed out yesterday that these are not research criteria. The hope and the objective was to help physicians make a diagnosis of ME/CFS, not to make it harder for them to make a diagnosis. And as you can see here, the second required element of this diagnosis is post-exertional malaise, in addition to the 2 optionals down at the bottom, either cognitive impairment or orthostatic intolerance. And a long time ago, Tony Komaroff described post-exertional malaise as the illness within the illness, and I think most people with ME/CFS and probably long COVID now would agree with that. It really defines what you're dealing with. By the way, this IOM report is still available. You can get it online at National Academies and .org. So characteristics of PEM. I think maybe the slide was up yesterday. I don't recall now. But the reason I'm pulling this slide up, this was a product of a study an intramural study that was done at the National Institutes of Health in the United States. And it was a focus group with ME/CFS persons. And what they learned from that was that PEM was really defined and influenced by 3 broad categories of stressors. And this is what I find I have to speak the most about when I'm talking about reducing your risk for provoking PEM. When we do a CPET, we are testing your physical stressor, but we're not testing your cognitive, maybe a little bit because we ask questions during the CPET, and certainly not the emotional stress on development of PEM. But what I remind every person who leaves our little clinic that your PEM load or tolerance is a sum total or a cumulative total of your physical, cognitive, and emotional stressors within a period of time. So you could have a physically inactive day, but a cognitively demanding day. A lot of time on the screen, at books, having conversations, having to talk in the doctor's office or get to the doctor's office. So it's important to realize that it's all of those combined that create the total of exertional stress that's provoking PEM symptoms. And we did see this slide earlier. From the same study, what they found was that the symptoms that people experience on a daily basis are most highly represented by exhaustion and what I know are not supposed to call brain fog, but there it is. Difficulty thinking clearly and mental, physical, cognitive processing rather, and some muscle aches and pains. On the other side here, you're seeing the symptoms that are characteristic after a cardiopulmonary exercise test, and they're not so terribly different. There's probably a little greater representation of cognitive dysfunction after a cardiopulmonary test, but in many cases they're quite similar. You might notice we've got some indicators of immune activation here, sore throat, headaches, and flu-like symptoms that might pop up after a cardiopulmonary test. But all in all, not so different from what you're experiencing on a daily basis. And if you want to ask me about that later on, I have another comment, but I'm going to save that because I got a lot to tell you. So why do we use a cardiopulmonary test to assess for post-exertional malaise? Because that's what we're doing. And just a reminder, because I get this question often, is this a diagnostic for ME/CFS? And it's not. You know, we don't have a biomarker. This is not one either. But we are assessing the impact of post-exertional malaise on one's ability to produce energy to do work after they've had an exertional stressor placed on them. And quite simply, a cardiopulmonary test, when they've been doing them for decades and decades with heart patients and pulmonary patients, et cetera, is to measure the effectiveness of the heart's, the circulatory system, heart, lungs, and the muscles to use oxygen to produce energy to do work. And that's what we're doing, only we do it twice. So information that you can get from one cardiopulmonary test, some of these are the variables that you can get. There are some variables from a cardiopulmonary test. We know how they're supposed to respond or behave when you do incremental exercise. And based on how they respond, you can actually delineate disease states based on the responses of these tests during incremental exercise. But of course, we're here because we're talking about the 2-day test. And so I need to talk about why we torture people for 2 days. It's not torture. You can talk to Joan about that. She's been through it before. But it's important to help provide objective evidence of impairment, how your PEM is affecting you. So in the United States, typically, attorneys are looking for 3 pieces of information to help support a case for disability. And one is typically the tilt table test to assess for orthostatic intolerance. If you are interested, the Nasoline test is a simple in-office test that can be done. We don't do it, and we don't do it because we can't afford to pre-fatigue you before your first cardiopulmonary test, but it's a simple test to administer, can be done in a doctor's office. The second, typically what attorneys are looking for to help support a case of disability is a neurocognitive assessment. And then lastly, the 2-day cardiopulmonary test. Also additional information to have for someone who's dealing with a fatiguing illness is to begin to track their symptoms, come up with some little simple way of discerning whether you're having a good or a bad day. It might just be a number rating of your day or your morning and your afternoon, something simple that shows ultimately over time your pattern for how you're feeling over the course of several days and weeks. And characterizing, write down what you were like, what was your life like before you became ill and after you became ill, because every doctor's office you go to, if they have a clue about what they're trying to understand here with your symptoms, should ask you about that. And then lastly, begin to monitor your hours of either upright activity. I actually ask about, because I think it helps individuals to understand better when I ask about the percentage of their waking hours that they're sitting or lying down. I want to know how much time they're not on their feet. And any idea what most people tell me? what percentage of their waking hours they're sitting or lying down? 80 would be the low end. 80 to 95, 99. I haven't had anybody put 100 up because I'm sure they have to go up, stand up to go to the bathroom or something, but yeah. So we do 2 cardiopulmonary tests. For the same reason we do 1, but we need to add another little bit to the story. So the first test here is to determine your baseline functional capacity. And one thing that's really important if you're doing this protocol is that you provide information to prepare for the test ahead of time so that they know that 7 to 10 days before they come in for your test, they should be really laying low. You want them to come to the test in their baseline level of activity where they're not symptom exacerbated. Okay, and that's a tough thing to do, and I'll tell you why in a second. They come in for the test, we get their baseline exercise capacity, presumably provoke their PEM symptoms, and then they come back on the second day, and we measure their PEM-influenced cardiopulmonary capacity then, and then we also make sure that we're screening for signs and symptoms. That's what SS is. Are they having normal signs and symptoms throughout the exercise test, or is something abnormal coming up? So we're routinely asking about, are they having pain? How hard do they feel they're exerting, which is called rating of perceived exertion? And are they having shortness of breath or dyspnea? And then, of course, we look at each test to determine whether their response was normal or not. So how do we use the data from a cardiopulmonary test to assess for post-exertional malaise? What we're learning from the cardiopulmonary test, one thing from the CPET, is their oxygen consumption at peak effort. We call that VO2 peak or VO2 max. If you're an exercise physiologist in the room, we're not going to have that debate. There's a subtle difference, but we don't care. You can then use that oxygen consumption, or you have to understand that that oxygen consumption is an indirect measure of energy production, your ability to use oxygen to produce energy to do work. Another way of expressing oxygen consumption, or VO2, is to convert it to a unit of measure called a MET. And a MET stands for metabolic equivalent of task. And 1 MET is equivalent to 3.5 milliliters of oxygen consumed per kilogram of body weight per minute. And that's, I know that's a mouthful, but essentially, what you should know about a MET is 1 MET is roughly equivalent to a resting energy expenditure. The amount of energy, oxygen you need to consume to produce energy to stay alive at rest. That's what 1 MET is. All right. There's more to that story too, but that's another lecture. You can then take that oxygen consumption that you've converted to METs, and you can look up in the compendium of physical activity, how many METs are you doing when you're at your peak level of energy expenditure? And what is it equivalent to in terms of everyday tasks? So at the compendium, what you'll find is hundreds of different tasks that represent physical activities, sporting activities, occupational activities, walking at different speeds, so on and so forth, and their corresponding MET levels. So as an example, what you might see is something that looks like this, where you've got an activity here, cleaning, sweeping floors. That's about 3.3 METs. Okay, so that's 3.3 times what your energy requirements are when you're at rest. Does that make sense? All right. Notice here that sitting at rest or lying down at rest is again 1 MET, but if you're a fidgeter, you can burn a few more calories. Just pointing that out. So in order to understand what the 2-day test is telling us, you need to understand what is a normal response to a cardiopulmonary test and what is not normal. This is a very reproducible test. It's reproducible in heart patients, pulmonary patients, patients with cystic fibrosis, untrained patients, Olympic level athletes. They can come back on the second day and reproduce the test. They may not be very happy about it, but they can. So if we see a test where test 2 varies more than 7% from test 1 in terms of their peak oxygen consumption, we know that's not a normal response. For oxygen consumption when they reach anaerobic threshold, that's a more variable measure, but we use about 12%. That's what the literature has shown us. It should vary within 12% from test 1 to test 2 when you look at the oxygen consumption at anaerobic threshold. The other things that you want to look at are, because we do have cases where individuals we test they will repeat within normal limits the VO2 peak and the VO2 at VAT. But curiously, the amount of work they can do when they reach those levels is far less. So you always want to look at the workload that they're at when they reach their peak oxygen consumption and their anaerobic threshold. Autonomic indices are very interesting to me because, and we've had some great talks to understand why that might be the case. We expect, and one of the first things you have to do when you assess a 2-day CPET is you have to show evidence that the person worked very, very hard for each of those tests. And there are criteria for them. And one of the criteria is that they reach at least 85% of their age-predicted maximum heart rate. And there are other criteria, respiratory exchange ratio, which I won't get into, but we have to meet that criteria as well. And also their subjective assessment of how hard they felt they're working. So we use a Borg scale, which is a rating of perceived exertion. It's the only subjective piece of information we get from the person doing the test about how they feel during exercise. And we want that to be high enough. For us, we use what's called the 6 to 20 scale. We want it to be 17 or higher. So you want to be able to look at that to determine whether, if they worked very, very hard by the other criteria of peak effort, but they weren't able to drive their heart rate up, why is that the case? Is it due to what we call chronotropic incompetence, or are there other factors going on? Because you need to know whether they're on beta blockers or something that's suppressing their heart rate. Systolic pressure. I can't tell you the number of tests that I have looked at from other clinics where systolic pressure was reported at rest and reported at peak, and they didn't look at how they got from rest to peak. So we can talk about that later too. Responses related to POTS or orthostatic intolerance are important as well. And then I will tell you across the board, 100% of the time in the long COVIDs and in the ME/CFS, well, 99% of the time, we see abnormally low ventilation volume. So when they're at peak exercise, there are norm values for age and sex, and nobody ever reaches them. Typically, they're about 50% of normal. So I'm going to show you a little data here quickly because I know I'm limited on time. This is an individual we tested some time ago. She's 39 years old. Her age predicted max heart rate's 181. So we would like to see her get to at least a heart rate of 153, which is 85% of her age predicted max heart rate up there. And this is what she did. Well, I should say that she did satisfy the respiratory exchange ratio criteria and her rating of perceived exertion. She felt like she was working really, really hard, but her peak heart rate was 120. She's 39 years old. She couldn't drive it up over 120 on the first test. Her ventilation was 22% of what it would have been predicted for age and sex. And then if you look at test 2, it remained at 22% of age, sex norm. Heart rate didn't change. Peak oxygen consumption didn't change. Oxygen consumption at anaerobic threshold didn't change. Her heart rate, when she got to her anaerobic threshold, which is a guideline for pacing, actually dropped, even though everything else stayed the same. So from test 1, we know that she's got a very low peak heart rate, probably chronotropic incompetence, we could say. Low maximum ventilation on both tests. And if we look at her hemodynamic data, you can see that her systolic pressure here on test 1 was hypotensive, but it incremented in what would be considered a normal fashion. You would expect blood pressure, systolic pressure, to go up about 10 millimeters of mercury for every 30 watts of workload increase. So going from rest to 30 watts, her her blood pressure went from 97 to 110. So that's close. And again, from 30 to 60 watts, it went up almost another 10. But if you look at test 2 here, we see a little different story. Not only was her blood pressure at rest lower, but it didn't change. In fact, you could argue that it even dropped a little bit. But there's measurement error, of course, when we do this. But you have a blood pressure. She went from seated rest, what you're doing right now, to climbing stairs. That's about what that's like. And her blood pressure never went up, ever. So, you know, if you can't drive your blood pressure up to increase blood flow and delivery of oxygen to the muscles, you're not going to be able to do much work. Or to the brain fog. So we have resting hypotension, we have abnormal systolic blood pressure response. And if you take the data that you just got from this individual and you apply it to data from Weber and Janicki, who established well accepted impairment standards based on heart failure patients, here's what you see. Her peak oxygen consumption, which was around 10, puts her in the moderate, right between moderate to severe and severe impairment. I do this all the time. This is how I write their reports up. And if you look at her oxygen consumption at anaerobic threshold, even though she repeated both of those variables from test 1 to test 2, she's still down in a severe category. So this is somebody who reproduced a test, but clearly cannot do any work. I mean, her anaerobic threshold is very low. So test 1 showed that she had hypotension, chronic chronotropic incompetence, low ventilation volume. Test 2 showed that she didn't, you know, she continued to reproduce, but she had all of the indicators of autonomic nervous system dysfunction, heart rate, blood pressure, ventilation. The summary from her data, the corresponding METs to her peak oxygen consumption, so again, that's 10.7 divided by 3.5, converts it to METs, shows that if you go to the compendium of physical activity, you'll see that 3.1 METs is about equivalent to walking slowly downhill. At her peak effort, that's her maximum oxygen consumption. And that at anaerobic threshold, this is what we don't want you working over. She's reaching her anaerobic threshold just going to the bathroom, okay? So we derive lots of variables from doing cardiopulmonary exercise testing, and I'm not going to go through all of these. I just want to show you that there's a lot of information we get related to cardiovascular function, pulmonary, metabolic, so on and so forth. I want to emphasize that this is really important, these signs and symptoms. If you're not collecting them when you do these tests, you're not understanding how the person is feeling, and you're also missing out on, you know, we have patients tremor sometimes after a test. Their extremities get very cold, which tells us a little bit about where the blood is not going. You know, so those are the kinds of things you want to look at. And a few cautionary tales as I finish up here is that it's important that you pick the correct test protocol to match the person you're testing. We always test on a cycle because a cycle is, while there's drawbacks to that, it's easily reproducible. If you test on a treadmill, the minute somebody puts their hand on a handrail, you've now changed the amount of work that they're doing, and you don't have control over that necessarily. Plus, there's balance issues oftentimes, so that's why we use a cycle. If you're doing the test, you don't warm up the patients. Many of these people will reach their anaerobic threshold during a warm-up, so don't do it. And I'll come back to some of these other things, but also note why the test ended. What was it? Ask the person, what was it that they were feeling at the end? What kind of fatigue, so on and so forth. So in order to really understand what the 2-day test is telling you, you have to know what is a normal response and what is not a normal response to incremental exercise. And if you don't know that, then it's really hard to understand what the 2-day test is telling you. And lastly, in my experience of testing 500 plus people using this protocol with fatiguing illnesses, is what we see over and over and over again. I call it the final common pathway of results or responses, is that we say poor blood flow, poor delivery of blood with oxygen to the muscles and the brain, that we're not measuring brain blood flow, but I just want to be clear, we see indicators of this, okay? Impaired ventilation almost across the board, and neuroinflammation. And the last one is based on, because they all do a symptom survey for us before and after the testing. And the selection of symptoms that some of them describe are inflammatory type symptoms. So as I pointed out earlier, the headache, flu-like symptoms, those kinds of things they'll report to us. So thank you again for having me. I just want to remind people we lost almost exactly a year ago. We lost a friend of ME/CFS, Byron Hyde, who was a physician in Canada, who was the first person to approach me about how do we do this and bring this protocol to Canada, and was, a stalwart for his patients for many, many years. And oh yes, I have to put my one Portuguese word in there that I can say, obrigada. Thank you very much. Right here, right?
Yes, thank you, Rob. First of all, thank you very much. I think you are the right therapeutic against the new entity, post-lunch malaise. Post-lunch malaise, because we all were suffering from post-lunch malaise. I open the questions to the floor. Yes.
Hi, so I'm Diana Vieira, psychologist, academic, researcher, and a patient. Betsy, thank you so much for your presentation. It was very clear, very objective, very easy to understand for a psychologist. Thank you.
It's working.
Just let me put my... I was wondering, at what time of the day do these tests are done? And I ask this because I feel myself that I'm different in the morning, in the afternoon, and at night. That is one question. And then the other one is also, do you ask patients how tired they feel before each test or not?
Oh,
Thank you.
Yes, so remember I'm post-absorptive too. I had that big chunk of cheese. And, so the first one is, for many years we tested in the morning, and we still do. The worst time of day for you. So we've people have asked us to please do it in the afternoon, but I was restricted by the time I had clinic availability and also the people who test with me. And so we were locked into that schedule, but we're more flexible now, but we still do it in the morning because we know you're not at your best, but for a lot of reasons, we do it between 9 and 10. Our schedule varies depending on us too, but usually it's between 9 and 10, and you're with us for about an hour and a half. What I didn't mention was if you're doing this test protocol right, the actual time you exercise is should be about 8 to 12 minutes, more likely 5 to 6 minutes, maybe 5 to 8 minutes is the actual exercise time in reality. So it's not a long test. The prep stuff and the information we get is what lengthens the time. And the second question.
Do you ask patients
Oh, yeah.
how tired?
We have a symptom survey that we administer before, I think I mentioned, before they even come to us. And it's the CDC's 8 symptoms that somebody put up there yesterday, but we have a 9th symptom, and we used it for our NIH study. So it's very easy to fill out. There's certainly limitations to it. They fill it out before they ever come to us. They fill it out right before test 1, right before test 2, so after they're PEMmed. And about 4 days later, we email it to them and they fill it out again. And what I will tell you is we published a paper on this in 2023, because during our NIH study, we were collecting that same symptom survey at those same intervals, but also for up to 10 days. Every second day for up to 10 days or longer until they felt they were back to their pretest baseline. And that image I put up there of the 2-day test was showing a little bit of the results of that study, which had the healthy controls, sedentary controls, recovering within less than 2 days on average, and the MEs recovering within 2 weeks on average. The variability for the healthy controls was 1 to 10 days based on their symptom reports, and for the MEs it was 1 to 64 days based on their symptom report. But the average was 13 days. So.
Thank you. I have some questions from the online viewers, but I will start with one question from my own. How do you monitoring blood pressure during these 2 days? Because it is, yes, for you, Betsy.
Yeah, we don't use an automated cuff. We actually take the blood pressure ourselves throughout the test every 2 minutes.
2 minutes?
Every 2 minutes. So yes, at 30 watts, and we have a whole protocol for it. But the important thing that I was trying to bring out in this presentation was that if you only look at the resting blood pressure and the peak blood pressure, and you see that they get to a peak blood pressure that's consistent with their peak workload, and you say that's fine, then what you're missing is something really important that's happening in the middle, because you saw the data with test 2, the systolic pressure never went up with that individual. But what we've been finding, and it's kind of turned into a joke in our clinic, is that the systolic pressure will stay flat for quite some time. And then all of a sudden, when the patient, we ask them the rating of perceived exertion, if you're familiar with that scale, when they tell us it's 14, we could have told them it was 14 because you'll see a jump in systolic pressure. So if I measure blood pressure first at that time point and I see it jump up all of a sudden, I know their RPE is going to be 14 or 15. And we've seen it over and over again.
And now some questions from our online viewers. How to evaluate your test, your 2 days test, if you have already started taking medication, like, for example, pyridoxytigmine and stimulants?
I get that question a lot, actually. And so what I explain to people is if you want a true measure of your baseline ability to use oxygen to produce energy to do work, and how your PEM affects it, then you should be off your meds, which I can't do, I'm not your doctor, but you should be off your meds. If you don't feel like you could complete the test protocol, stay on your meds. And I've had people do both. But you will get a medication influence test if you stay on your meds for the 2-day CPET protocol. And if you're trying to get evidence of impairment, disability, then you would want to consider coming off your meds.
And another question from an online viewer. What does the neurocognitive assessment involve? In few words.
I don't do them, but I've had many patients tell me that the PEM is worse after a neurocognitive battery than after a 2-day test. So it's a test. It's a day-long battery.
It's a whole day of neurocognitive testing around a variety of different dimensions, which also includes the inclusion of malingering scales to make sure that you're not faking the results. And so it looks at IQ function, the ability to multitask, short-term memory, and it starts in the morning. And then essentially as the day progresses, you're able to do less and less, and you eventually can barely
So
function.
complex.
It's like a 2-day CPET in one.
Sorry?
I did the short version, the Portuguese version. I did the short version
For how long
like
does it
2
take?
hours or
2
3.
hours, okay.
Yeah.
So more questions for Professor Betsy Keller.
Hi, I'm part of many ME/CFS groups on Facebook, and I share and I help. And one thing I see is on one of the American groups is that how difficult it is for them to get onto disability. And I will be posting the conference there. If they would come to you, what is the contact details, the website? Is this the website they can reach you for help?
Yes.
Okay, thank you.
Yes. I also want to add too that post-exertional malaise can occur within hours of doing an exertional stressor or days, but we have on occasion had an individual who knows their pattern and said, you know, my worst post-exertional malaise is the third day. So we have them stay over an extra night if they want to, even though we actually pick up abnormalities if we test them 24 hours later. So instead, if they want to stay, then we'll do them 48 hours later. But understanding your own PEM profile is important, I think.
And finally, one last question to Professor Rob Wust. There is another question. I'm sorry. David, I'm sorry.
I just had one quick one for Betsy. Betsy, do any of your ventilatory or pulmonary gas exchange measurements inform mechanisms for breathlessness or dyspnea on exertion, something that a subset of patients with ME and long COVID have without any heart or lung disease?
If we looked at it, it probably would, but we don't have the resources to do that. I mean, you know, we see hypocapnia. And so for disability, when I can report they're at 50 or 48% of age and sex predicted normal, that's about what I do. But I can't tell you anything mechanistic about it, though.
And a final question to Professor Rob Wust. We talk about the inclusion of patients with long COVID, and I ask you about admission in ICU. Aren't you afraid that admission in ICU can make things a little bit different?
Yeah, that's a good question. I think what happens, it's really distinction between diagnosis of long COVID and longer disease after an acute COVID infection. So if you are admitted to a hospital or ICU, we know that that causes also longer term problems independent of long COVID. And all our patients that we include in our study are had a mild disease and never were admitted to hospital. But also we always check for whether they are positive on the PEM. They had to have physical PEM, and we do that with a DSQ PEM questionnaire. So we don't, and I think if you are only admitted to hospital in ICU after COVID infection, and it takes a long time to recover.
And other factors could be involved, probably.
Yeah, the other factors can be involved, but then you probably would be negative on the DSQ PEM questionnaire, essentially, or the cardinal symptom for long COVID.
So we are running 1 minute late, so we'll start block number 4, and I'll ask a big applause to the previous speakers. David, it's your turn now. So we'll start block number 4 with Professor David Systrom from Dyspnea Center and Advanced Cardiopulmonary Exercise Test Program, Brigham and Women's Hospitals, Harvard Medical School, Boston, Massachusetts, USA. And Professor David will talk about neurovascular dysregulation, preload failure, mitochondrial dysfunction. And he used his own mic, of course.
All right, success. Thank you for the kind introduction here. And it's a pleasure to follow Dr. Keller's talk with a different version related, I think, to her version of cardiopulmonary exercise testing. My topic is broad. Some of you may have noticed that we've changed the order here. Drs. Waxman and Oliver are going to discuss their findings using invasive cardiopulmonary exercise testing later on this afternoon. So I'm going to set the stage perhaps for some of that. Here's what I'd like to tell you about over about 30 minutes or so. I'd like to introduce those of you who don't know much about the invasive version of the cardiopulmonary exercise test to it and what we can derive with a couple of catheters. And then I'm going to pit two different avenues of pathophysiology during exercise against each other to a degree. And that's the notion that some of what our patients notice in terms of fatigue and shortness of breath and lightheadedness might be related to decreased oxygen delivery to the exercising skeletal muscle. Then I'm going to turn to a different notion, not mutually exclusive, and that is that the muscle itself during exercise may fail to take up and utilize oxygen normally, different end of the Fick principle, which you heard about earlier this morning from Dr. Boost. And then finally, I'm going to focus a little bit on our recent unpublished findings using skeletal muscle biopsies. So a little bit on the invasive cardiopulmonary exercise test. First, Betsy has told you all about this. This is Dr. Carl Wasserman's favorite gear diagram that graces his textbook and the business. Shown here is the interface with the environment where we have minute ventilation. We collect that, of course, with a pneumotachograph and a mouthpiece, the amount of oxygen uptake from the environment, the amount of CO2 exhaled. And then if everything's working perfectly, all these gears work in sync. And you have, for instance, oxygen flowing with a convective step, a diffusive step into the red blood cell, another convective step with cardiac output, delivering that oxygen. And at peak exercise, about 80% of the cardiac output is being directed normally to the exercising legs in our case with cycle ergometry. And then finally, there's a diffusive step out at the level of the mitochondria, and it falls normal with the mitochondrial machinery and the delivery of the oxygen. It's taken up properly, and off we go, and we feel well. If there's any portion of these gears that is in disarray or out of sync, presumably symptoms ensue, things like fatigue, shortness of breath, lightheadedness. And then the reverse occurs with CO2 and hydrogen ion excretion. So that's the non-invasive portion that can be measured non-invasively. It's scalable. Many folks are doing this. So the invasive variety is shown here, and I'll point out a couple of highlights. This gentleman agreed to be filmed. Here's the pneumotachograph I mentioned. This is the connection to the metabolic cart, so breath by breath pulmonary gas exchange. And then there are two special catheters that really help us inform the interior, what's going on in the interior of the exercising human being. They're put in our cardiac cath lab around the corner from the exercise lab by Dr. Waxman, whom you're going to hear from in a little bit. This is the pulmonary artery catheter placed in the right internal jugular vein. And then in this gentleman's left wrist is a radial artery catheter. And as Johanna Squires told you yesterday, we get pressure measurements, we get biomarkers, we get arterial blood gases, mixed venous blood gases, and a phenomenal amount of physiologic information. So again, here are some of the measurements that we make. These three up here are non-invasive. This is minute ventilation, VO2, all the way up to peak, CO2 output. And then from the arterial catheter, you'll see importantly arterial oxygen content. From the tip of the pulmonary artery catheter, mixed venous oxygen content. And you'll see that that is very important in assessing whether there is dysautonomia and abnormalities of oxygen delivery or its subsequent uptake and utilization. And then we have a variety of pressure measurements. Joanna alluded to some of these yesterday. We've got the mean pulmonary artery pressure, that's the input pressure into the lungs, and then we've got a surrogate for the left atrial pressure, pulmonary capillary wedge pressure shown here. So pressures in and out of the lungs, and then pressures feeding the right heart. And this is going to be a super important entity, as you'll see in both ME and long COVID. These are the filling pressures in the upright position that reflect normal autonomic function, sympathetic squeeze on the big veins, the capacitance veins, and whether or not they squeeze properly, and physically push blood up to the right heart. You're going to be hearing more about that from me and later today. And here's the Fick principle Rob Voos mentioned. This says that the O2 uptake is related to the cardiac output and the difference between the arterial and mixed venous oxygen content. So this is true at any point in time. I'm going to emphasize today maximum exercise. And what you can view, and I think Betsy said this a little bit ago, the VO2 tells us how much metabolism the patient is doing out in the real world. And with an incremental test, we can say, okay, at 600 ml, you're walking down the hallway, and at 800 or 900, maybe you're running up the stairs. And then there's maximum exercise when presumably all of our physiologic compensation is maxed out. But it is related to cardiac output and then the difference between these two things. This normally goes up about 5-fold above resting values if you're normal, and this normally falls about 3-fold, and this stays the same. If we rearrange the Fick principle, we get cardiac output, and we measure that at the Brigham with the invasive test every minute during exercise. This is continuous, and this is measured simultaneously with this every minute. I want to remind you, though, that this cardiac output that we are measuring is pulmonary blood flow. If there's no shunting going on of blood, that's going to be equal to systemic blood flow. But what we have found in first ME and then more recently long COVID is a different story that I'll talk to you about. Here's an algorithm for what we deduce from the invasive exercise testing program. I'll run through it briefly. We're going to emphasize really 2 buckets here in the end. So here's the VO2 peak that Dr. Keller alluded to, and here's a crude cutoff for normal. Many of our patients with ME and long COVID actually are better than this, and we can find abnormalities if we dig deeply, and I'll go over those. This is a so-called pulmonary mechanical limit. This is really not germane to the type of patient I'm going to be talking to you about today. This is a patient with parenchymal lung disease, perhaps in long COVID, an occasional patient with interstitial lung disease following ARDS. I will not be talking about that type of patient today. This is a central cardiac limit where the VO2 peak is decreased, and there's a similar or symmetric reduction of cardiac output, which we can express as a percent predicted. And if we find that, we can determine whether the left heart dysfunction is at play, the right heart and pulmonary hypertension, or something we call preload failure. And this is where we're going to end up with a majority of patients with ME and long COVID. An occasional patient with long COVID may have a cardiomyopathy. An occasional patient with long COVID may have persistent pulmonary embolism that we diagnose with this, but I won't be talking about those rare cases. The vast majority of patients with long COVID and ME end up here. That's low. Here, to a degree, that's low, and preload failure. Now, at the other end of the universe is the arterial side, and this is reflected largely by the ability to extract, take up, and use oxygen that's been delivered to the exercising muscle. And as I said, this mixed venous oxygen content should normally fall about 3-fold, but we have found in a subset of individuals an abnormality here, whose differential, and this is a spoiler alert, includes these 2 entities: intrinsic mitochondrial dysfunction that you heard about from Dr. Boost, and a peripheral left to right shunt or associated abnormalities that I will come back to. So these are on the arterial side. This is on the venous side. I'm going to begin with the venous side. Just pay a little attention to this. So we first got into this business about a decade ago when we discovered something we call preload insufficiency. And it is a form of decreased oxygen delivery. Oxygen delivery is defined by that cardiac output times the oxygen content in arterial blood, that product. That's what's going out the aorta during exercise. We don't know what happens to it with this type of testing after it goes out the aorta, but there's a subset of individuals who have predominantly preload insufficiency and normal oxygen extraction. We call that a low flow group. And this we began to put on the map with the help of Philip Joseph, now at Yale 4 years ago, published here. So this is what it looks like. This is a low flow group of ME patients, but we have found the same thing in long COVID, where the predominant abnormality by the Fick principle is a depressed peak exercise cardiac output. that decreases the VO2 peak and presumably causes symptoms. So they have a low cardiac output. We are expressing it here against the VO2 slope, and their extraction of oxygen, shown here corrected for the hemoglobin, is normal. This is the low flow group. It's kind of pure preload failure. It tends to be more common in males, and this is where they end up here in our bucket. The next entity I want to talk about and spend most of my time on, though, is what got our attention with that same Philip Joseph paper, and it's a bit of a different entity. So it's impaired systemic oxygen extraction, defined by the inability to depress the normal mixed venous oxygen content, shown here. This is where they ended up in that particular paper. They have high flow compared to normal, shown over here in gray, and the intermediate group, and certainly the low flow group. This is a lot of pulmonary blood flow and poor systemic oxygen extraction. And by the Fick principle, the reason for their decreased VO2 is predominantly a depression of its inability to depress the mixed venous oxygen content, impaired oxygen extraction with a lot of pulmonary blood flow. Here's a more recent look at our data, and Johanna Squires presented some of this yesterday. She did all this heavy lifting. This is our most recent experience with the invasive CPET in ME/CFS. Over the past 5 years, we have 450 patients. We have now actually 93, but I'm showing you 89 long COVID patients and a cadre of normals. And as Johanna told you yesterday, we've got symmetric decreases of the VO2 peak. Preload failure is the right atrial pressure over here. We've got cardiac outputs that on average are down when compared to normals. And we've got depressed oxygen extraction on average down compared to normals, and no differences between long COVID and ME/CFS. Now, I want to focus on these two groups. So this is kind of the newer thinking about at least a subset of patients with both ME and long COVID. And that's that high flow shown here. So this subset of patients with cardiac outputs that are way north of 100%, 120, 140%. VO2 peaks that are up a little bit, but depressed compared to the cardiac output. And then whose abnormality of the Fick principle is abnormal O2 extraction here. This is really the high flow group, predominantly women. And we're looking for reasons for that. So all the things I just told you about, a lot of pulmonary blood flow and poor oxygen extraction, are hallmarks of something the cardiologists call left to right shunting. And we've known forever in congenital heart disease, more common in adults, is an atrial septal defect where you push oxygenated blood across the atrial septum onto the venous side, and the pulmonary circuit is on overdrive, lots of blood flow through it, but it's ineffectual. It's not getting out to the periphery during exercise. We know none of our patients has an intracardiac defect in left to right shunting because Dr. Waxman does a very special step-up measurement of oxygen from the superior vena cava through the right atrium into the right ventricle and out the pulmonary artery. There's no step up there. So we think this is peripheral left to right shunting. And we have an example of this from one of our collaborators, former professor to Dr. Waxman, skin biopsy of the hypothenar pad, which captures the epidermis shown here and the dermis with the blood vessel supply. And what Frank Rice in Albany showed us with these elegant studies is very interesting. We've got an artery coming into the skin, and this can happen in other organ systems, but the skin is accessible by biopsy. We've got a vein draining the skin, and we've got a potential shunt between the two, the artery and the vein. And that shunt is enveloped with something called small fiber nerves. Those small fiber nerves, amongst other things, secrete vasodilators. They can be dynamic and open up. And I ask patients in the clinic, when you get in the hot shower, do you get dizzy and your feet turn purple? And the answer is a phenomenal prevalence of yes. So we think some of this may be going on in exercise, but it doesn't have to all happen in the skin, which is capable of receiving at least half of the cardiac output. But some of it may be in the skin. But it's peripheral left to right shunting. Now, this link to small fiber neuropathy is prompted by some of that Frank Rice data, and I want to tell you about that. This is a form of dysautonomia diagnosed by a skin biopsy. So the small fiber neurites have been known forever to mediate nociception, pain, and that's fibromyalgia in our business. So it's defined by a lack of dendrites, of neurites in the epidermis classically. But we now know that these same small fiber neurites not only mediate pain, but they provide an autonomic function as well. They envelop blood vessels, as I just showed you, in the skin, and they are responsible for blood vessel tone and therefore blood flow. When they're missing in action, of course, they're not able to do their thing, but the ones that remain are often overactive and dysfunctional. So here's our most recent look, again, with the help of Johanna Squires, who presented this in Amsterdam just a month ago. We have a phenomenally high prevalence in both long COVID and ME of either definite or probable small fiber neuropathy, approaching 2/3 to 3/4. So a very high association with this autonomic nerve problem that goes with some of the vascular abnormalities I've just described during exercise. So we're inclined to link the two, although the exact link is not well known. So this is where those patients with high flow end up. They have a depressed VO2 peak and symptoms. Most of them additionally have some element of preload insufficiency, but here's the extraction of oxygen problem, which I would like to focus on a little bit more here for a minute. Now, a nod to some of our prior speakers this morning, and some of this has been alluded to. I would ask the question, if I'm proposing to you a hypothesis that dysautonomia is responsible for some of the systemic oxygen extraction problem, am I sure that that's the only mechanism? And the answer is a definitive no. So there are lots of other potential reasons, none of them mutually exclusive, to impair oxygen extraction during exercise. One is abnormalities of the hemoglobin itself or red blood cell abnormalities. You heard Dr. Pretorius talk to you about. The microclots, of course, that she told you about can physically gum up the microcirculation and create a mismatch between perfusion of the mitochondrion and the muscle and metabolism. Endotheliitis and structural changes of the capillary and the muscle can give you these very same changes. And then finally, there's the notion of intrinsic mitochondrial dysfunction, which I'd like to supplement Rob Booth's work on with the following. So here's this entity. We have preload failure on the venous side. We have potential dysautonomia on the arterial side, but additionally an intrinsic mitochondrial defect is possible. So I want to address mitochondrial dysfunction in two different ways. One is number or better biomass of mitochondria, and we can measure that with something called citrate synthase activity with a fresh muscle biopsy. It's a ubiquitous enzyme at the entry into the Krebs cycle, and it reflects the number of mitochondria and the biomass of the mitochondrion. Additionally, one can look for biomass of mitochondria by looking at mitochondrial DNA copies, and these two correlate. We've done that correlation. I won't show it to you today, but they correlate very nicely. And then finally, with biomass, there's a notion of fission and fusion. Healthy mitochondria get together, and the defective ones are supposed to be tossed out at the edge of the herd. So that's biomass. That's the number of mitochondria effectively that we find in the muscle in this case. But then there's function as well. So the classic way of looking at function, you heard from Rob Boost, is oxidative phosphorylation and looking at the individual electron transport chain intermediates. So I'm going to tell you a little bit about that. We utilize, as I think Rob does for the most part, a frozen muscle biopsy to interrogate function. And we get complexes 1 through 4. 5 is missing in action. With a frozen, you can get it with a fresh biopsy, which is harder to do and analyze. And then finally, EM morphology, which the Boost group is looking at. So here's what's known about genetic forms of mitochondrial myopathy. This is not ME CFS. This is UT Southwestern 20 years ago with genetic forms where they quantify the mutation load in the skeletal muscle itself as a percent here. So worse mitochondrial genetic myopathy shown left to right here. And what they found with a similar approach to our invasive CPET is impaired oxygen extraction as a function of mutation load. So read mitochondrial dysfunction in the limb skeletal muscle results in impaired oxygen extraction. Now, what about biomass? What about the number? So with the help of Bob Navio, who's a mitochondrial maven at UCSD, we have looked at his group of well-defined OXPHOS disease. These are some pediatrics, some adults, but a large number of them he's published in the past at the biomass, measured by citrate synthase compared to normal at Baylor. And you can see that it's actually increased. And one can envision a system where you have a primary defect in electron transport chain and a compensatory increase in the number of mitochondria. So that's genetic forms. But what about ME and long COVID? So we find something different. Our mitochondrial biomass by citrate synthase is decreased. We have fewer mitochondria in the muscle of ME and long COVID. So this is a hypothesis that there is failure to generate the biogenesis of mitochondria is defective in some fashion in ME, and it's different from the genetic forms. All right, what about ETC function, and how does any of this relate to the oxygen extraction problem that I've just described to you from the invasive CPET? So first, our mitochondrial biomass by citrate synthase activity here, and the answer is the worse the systemic oxygen extraction, the greater the number of mitochondria. The fewer mitochondria over here actually have better extraction. So maybe one could envision a reciprocal relationship between mitochondrial number and the extraction. So what does give us poor oxygen extraction? I gave you some of the vascular abnormalities that are at play here, but is it possible that intrinsic mitochondrial dysfunction, presumably acquired, not genetic, in ME and long COVID is related to it? And our preliminary answer, unpublished, but we've submitted this for ATS in Orlando next May, is as follows, that the poor oxygen extraction during an invasive CPET is at least associated with the impaired ETC chain function. So that part is similar to genetic disease. So here's our cartoon of a hypothesis. The genetic forms of mitochondrial myopathy, we think the primary defect is a defect of energy metabolism. The function is down, and in a compensatory fashion, they have regulatory pathways that upregulate the biomass of the mitochondrion. Conversely, in ME and long COVID, we have a primary defect of mitochondria. There are a few of them, and function can go either way. If you have poor oxygen extraction, that's explained by poor function in addition to the decreased biomass, and one could envision a double hit in those patients. They have both fewer mitochondria in the skeletal muscle and their function is decreased, presumably resulting in more symptoms. So I'm going to end with that and thank our team who's in the back here and shown in this picture, and many others, Dr. Waxman, whom you're going to hear from, and too many others to count here. And thank you for your attention. You're welcome.
And the next speaker is Professor João Carlos Vinck from Pulmonology Unit, CUF Porto Institute and Faculty of Medicine, University of Porto, Portugal. And Professor Vinck will address the topic subclassifying long COVID through exercise testing. Thank you, João.
Thank you, Philippe. First of all, I have some disclosure and some acknowledgements to make. So first of all, I'm probably the less expert person here in the room because I've been in the field for like 3 years now. And so I feel like I'm in the shoulders of these giants that preceded me. So my talk will be much easier because of Dr. Keller and Dr. Systrom's talk. So, the less knowledge that I have is because of your papers and also from the experience of the patients that I've been seeing for these last couple of years. So again, the example of Joan is impressive, and she's one of the drivers of a guy like me, a pulmonologist that takes care of COPD or lung fibrosis, has come to this area that is probably a little bit far away from the respirologists of my country. So probably I will skip some of these items because of the previous talks, and I'm really grateful for their explanations. But briefly on my introduction, I would like to clarify a little bit, because I think that, at least in my view, there are some misunderstanding about the group that we are talking about, ME, CFS, long COVID, and we are a little bit influenced by the experience that all we had, especially Professor Freud, which was on the front line of the COVID pandemic. And we are talking about back on those pre-vaccination times. So really the chronic lung injury coming from the COVID-19 pneumonia. But what I'm talking about is not really this part. But anyway, we all seen patients after 1 year of having COVID pneumonia with a lot of lung problems that came from the same kind of mechanisms that you've seen today. So we've seen fibrosis in the lung, we've seen microclotting producing some thromboembolic diseases. And also we had, curiously, some small airway disease that I come back to you. So these signs of chronic lung also produce some of the symptoms that some of these patients have, but it's not really the topic of today. But anyway, just to some case vignettes for you to focus a little bit on this. This is a good example of what I'm mentioning about the pre-vaccination consequences of the COVID-19, which is these patients that were admitted in some ICUs with, severe ARDS that then, when we see them 6 months later, there are still some kind of signs of some fibrotic lung disease, but really after 12 months, well, the CT scans are almost normal. But one thing that I would like also to stress, and coming from the lung function lab, I'm a little bit biased of that, is that some of the lung function recovers really after these 12 months, but there are some markers like lung diffusion that still keeps on the lower end. So sometimes these small derangements of lung function can also explain some of the symptoms that not so severe patients like the one that I mentioned here have. Another example of consequences of COVID-19 and even not severe COVID-19 with a severe pneumonia is these findings that we have, especially if we do expiratory lung CT scans, that if you look at these scans over here in the inspiratory phase, you probably say, okay, your lungs are pretty okay, are pretty normal. But then if you do some expiratory non-contrast CT, you can see some of these air trapping that can occur, especially because of the involvement of the small airways. So that's why when we see a patient on our clinic complaining of the typical dyspnea, fatigue, and maybe some of them are also coughing a lot, we should think about some kind of an algorithm like this. That is what we typically have done in the pre-vaccination or post-ARDS phase of COVID-19, which is to perform a CT scan, to perform lung function test, and then if the tests are normal, maybe we should go more deep into the lung function. And I would say that apart from CPET, which is my topic of today that I will cover a little bit further, we should also think of other imaging techniques that are emerging and seems to be quite interesting. And this is xenon MRI pulmonary in CT, which is quite interesting, showing some interesting changes either in the ventilation and also in the circulatory side. And this is some interesting publication also mentioning some interesting phenotypes that you can pick from these different types of defects that you can have on the xenon MRI. Of course, I'm not an expert on this. I think we have only one of these machines available in Portugal, so unfortunately, we will not be able to do some of this scanning to do. This is something that is quite non-invasive and can be very interesting because it can, depict different kinds of subsets of patients. So coming back for the ME topic, I like very much this paper that's just showing a little bit about the figures of how frequent is these ME, chronic fatigue syndrome, after COVID. And what is interesting is that the percentage of people that have ME phenotype is not so different from the ones that didn't have COVID. So this is something that it's not, so COVID-19, also the virus, is not able to produce more ME than the previous triggers that we know about. The other thing is another study, and this is a systematic review showing, and this is, I think, something we all know from our clinics. So when we see long COVID patient, a big slice of them is ME CFS profile. So being, fatigue, poor sleep, and also dyspnea and some pain important. This is another slide just to show me and to show some of our colleagues of the respirology world the impact of long COVID in terms of quality of life. And I picked this paper because it compares COPD, which is some kind of disease that we all know about, emphysema, so tobacco-induced lung airways disease. And as you can see that in the red bars, which is long COVID, and this is SF36, so a generic quality of life questionnaire, as you can see in all domains, so long COVID just score much worse than, rheumatoid arthritis and COPD, to mention a few of the chronic diseases. This is one interesting paper that I read recently from Carmen Scheibenbogen group in the Charité, where she studied different groups of patients with post-COVID, and all of these patients made lung function tests, and that is again what I think is very useful to include the lung function studies on this patient population. What this paper tell us about is that, again, diffusion seems to be one of the parameters that stand lower in other compared to the non-severe, non-fatigue patients. So she included here some kind of normal, so the normal patients, and so the ones with chronic respiratory sequelae, the PCR, but then these post-fatigue kind of a ME-like, I would say. Something that is very interesting is the PI max, which is the force of the diaphragm. This is something that we measure on the regular lung function tests, and this is something that I would recommend everybody to measure, because you're going to find out some of these patients with the ME phenotype that have also some decrease in the PI max, and this is also some sign of the neuromuscular impairment that some of these patients have, not only the peripheral muscle, but also the diaphragm can also be involved. So now, coming back to the CPET, I don't go again into this. I would like also to show you just this meta-analysis that just brings together all these papers, 38 studies. So it was published 3 years ago, so maybe there are more studies that should be included. But anyway, so on all these patients that were studied, so there were a lot of different kind of phenotypes that were found, like the ones that Professor Systrom and Dr. Betsy Keller was mentioning. So some peripheral limitations, some dysfunctional breathing that will come back to you, and of course some also dysautonomia and incompetence. Again, coming to this integration of CPET with lung function, I like very much this study. I think it comes from the UK, published last year. Again, comparing or integrating CPET of a group of community treated, so these kind of a mild long COVID together with the hospital treated, so more severe cases. This was, of course, in terms of, there was a decline on VO2 max as expected. And also the lung function was worse in these patients. Of course, the LCO was also worse in this patient. And so this integration, this correlation, I think makes a lot of sense when we are seeing patients with ME, but also with long COVID. So the phenotypes were very well described in the paper that Professor Systrom was referring to, and also with Rudolfo Oliveira as one of the authors. And again, peak VO2 is the majority of the cases will show that, an early anaerobic thresholds, of course, inefficient ventilation and some kind of hyperventilation that will come back is also some kind of phenotype that we'll see in these patients. And in this paper, I think that Mancini clearly separates this kind of phenotypes that you can see when you're doing CPET, and we are only mentioning a small part of CPET, which is non-invasive CPET, and again, showing us these different kind of dysfunctions that can help us out on deciding which kind of intervention, be it pharmacological, but also non-pharmacological. So an example of two series of patients with long COVID that found out more or less the same kind of patterns. And this is something that you probably also see, Dr. Systrom and Dr. Keller, which is this kind of dysfunctional breathing, which was in this series from France, like 30%. In these other series from the US, it was a little bit low. But anyway, you could see really this erratic kind of ventilatory pattern that we can see in this Wassermann course. Well, Dr. Keller has mentioned a lot about a 2-day CPET, but I would like also to address a little some other points. And she has done this amazing study, which I think is quite interesting because it's also showing us that what we see in the 2-day CPET also translate into the severity of ME. So the patients with are more severe are the ones that have worsen parameters on the second day of CPET and also on the baseline. Of course, we discussed a lot about the drawbacks of 2-day CPET, and some patients complain of some kind of a relapse. And this is something that she has also done very elegantly. She has not shown the slides, so I can show it for you. which is this kind of a monitoring with some kind of a diary of how the regular healthy people behave or feel after 2 days CPAT. So quite, after 1 or 2 days, they are okay. So like Dr. Keller was saying, so in terms of symptoms, it seems like some of them took some weeks, but in general, which is quite safe, is that the majority in 2 days are reaching more or less 50% of the stage that they were before. So again, it's a challenging test. It's a kind of a provocation test, but it's sufficiently safe for us to go ahead. This was a meta-analysis of the 2-day CPAT for ME that didn't include the last paper from Dr. Kelly's group. But anyway, this is always pointing into the same direction. So the parameters that you were telling us are the ones that are really happening on these studies. So this is our last study with 84 ME patients. So I won't go through this. Just to mention briefly on this last slide about what is our experience of 2-day CPAT on long COVID. So there are only, as far as I know, 2 papers right now in the literature. And curiously enough, so the study from the US, the first author is Gattoni. It was a small study with 15 long COVID, also more or less 50% of females, and 80% with PAM measured by the DIPOL questionnaire. The same here with a bigger cohort in the UK from Derby. And as you can see, there was a negative, so there was no difference in the VO2 max and work rate in these 2 maximal CPAT. But in the study from the UK, there was a significant reduction in the oxygen uptake, the oxygen pulse in the second, although it was a submaximal CPAT. So quite interesting. So just to finish, I think I would like to draw a couple of conclusions. I think, like you've heard before, CPAT is a good way of measuring the individual capacity to work and is the gold standard for measuring disability. All have seen that exercise capacity is reduced. We all know of that in ME and long COVID. We have different profiles. Functional breathing, so autonomic and chronotropic incompetence, so preload failure, like you've seen from the CPAT studies from Professor Systrom. And of course, although invasive CPAT is more accurate in identifying these different distinct phenotypes and going more into deep to investigate the pathophysiology, I think non-invasive CPAT, like Professor Dr. Keller has said, can be like a screening tool and also, in my view, a phenotyping tool that can help us to decide what kind of exercise we can safely recommend for patients, or not only exercise, but also other, pharmacological interventions. And like you've heard before, so it's a good way of confirming PAM, which is something that some people don't believe exists. So this is a good way for patients to show that what they feel is really objective. And I think that in the absence of a biomarker, and I think that today was quite exciting, we've seen the point of care coming from South Africa, from Professor Pretorius, some biopsies that we can do for the muscle that can be maybe diagnostic of ME, I don't know. But while we don't have that, maybe CPAT can be also useful. So thank you again for your attention. And this is the view of Porto that you're always missing, because the River Douro is really an inspiring for all of us. Thank you so much.
Thank you, João Carlos. And the next speaker is Professor Rudolf Oliveira. Professor Rudolf Oliveira is professor of the Department of Medicine at the Federal University of São Paulo, Brazil. And Professor Rudolf Oliveira will address the topic Evaluation of the Effect of Pyridostigmina on Long COVID, results of a Brazilian randomized double-blind controlled clinical study. Thank you for coming.
Oh, good. Sorry. Good afternoon, everybody. So I'm confused. Should I speak in Portuguese or in English? Yeah, because my slides are bilingual, so everyone, I will do it in English, but some slides will be in Portuguese, okay? I was invited to talk about our clinical trial. It's a phase 2 clinical trial, 2A, so very preliminary, that we have performed at the Federal University of São Paulo. But I decided to start a little bit different, because usually we start such talks with the science, and at the very end we say thanks to people. So like one slide, 10 seconds, thank you, all this bunch of people, and then it's over. So I decided to start telling the story, so the backstage of the research, because this could not have been done without all the team that is behind the study. And I think this can also inspire our Portuguese colleagues to see that it is possible to do such type of studies and diagnostic methods even without the high-end technology that is available elsewhere. So the backstage of the research actually starts with me, but it was in 2017 when I left Dr. Systrom's ICPAT lab and returned to Brazil. And I like very much this picture because only 3 people are looking to the photographer. Dr. Systrom is on the phone, and Aaron is asking, what is happening here? And this is a photo from 2017 while I was at the lab, and where I had all my background in invasive exercise physiology and invasive CPAT, and where for the first time I heard the word preload failure, and could not understand, could not believe on what the hemodynamic monitor was seeing, until I went back to Brazil and started to see the same thing. And then I double-checked all the cables, thought everything was wrong, but it repeatedly happened in our patients. So I established the pulmonary hemodynamic program in São Paulo in 2018, 1 year after I was back. And in 2020, the pandemic, COVID-19 pandemic hit us hard, and Brazil was the 3rd country in the world most affected by COVID-19. A lot of related to bad politics, but we are not going to that. And in 2020, Professor Eloara, who is key to all these studies, who is a colleague, a friend, and an excellent exercise physiologist, she started the post-COVID-19 outpatient clinic at Unifest because this was a clinical need. We had so many patients, inpatients, ICU patients, severe. There was no clinic that would keep looking at them after they were outpatients. So she started the post-COVID-19 outpatient clinic and started to systematically collect data. In 2021, almost, I was she actually started to analyze the systematic collection of the data with Professor Mariana Lafetá, and did the first study of cardiopulmonary exercise testing of Brazil, evaluating early post-COVID. So this is the first wave of COVID. These are the patients that were more severe during their inpatient period, more ICU, mechanical ventilation, more fibrosis. And this was published later on the ERJ Open Research. In 2021, we were invited to write an editorial to the Brazilian Journal of Pulmonary Medicine to give our perspective on what we should expect of the post-COVID pandemic, let's call like this, like the post-COVID patients, where we wrote an editorial to the Brazilian scientific community saying that we were going to face basically a tsunami of patients with post-viral syndrome. This was what we were envisioning. At the same time, I was approached by a colleague that was with me at Dr. Systrom's lab, Com, from Imperial College. He sent me a message telling me, how are things in Brazil about COVID? I said, catastrophic. It's horrible. It's horrific. He said, oh, good, because here we don't have any more, and I have an idea, I have funding. Do you want to do the research? I said, yeah. And then we did a research about GLP-1 inhibitors in the early stages, so early stages of COVID-19, later published on infectious disease reports. And then came a call from the late call, let's say it like that, because it was a last minute call from the Brazilian government in 2020. It was the last term of the current, the prior president, offering money for researchers to do long COVID research. And then another important person appears among us, which is Dr. Bruno. He's a physiologist, he's a brilliant guy, and his field of research is autonomic dysfunction in pulmonary arterial hypertension. He brought the call to us and to me and said, let's do something. And I said, yeah, okay, but I cannot do it alone. It will be a lot of work. And so we made a team, and we really wrote together the grant and performed together the entire clinical study. And at the beginning, we had Dr. Ana Carolina. We sent her to the Brigham because it has passed a couple of years since I left, so I wanted her to see if anything has changed, because at that moment in Unifesp, I was the only one to have ever seen a proper ICPAD done. She went, spent a couple of days, came back. We got Dr. Fernanda as well, another amazing young physician. And this was the team of the clinical study, of the ICPAD studies. And because of them, we are able to talk a little bit about the results of the research. So the research also had a very important contribution of patients, right? We did a public call using social media and all the patient associations from Brazil. All the activists also advertised for it. Recruitment is closed. That's why you don't see any contact information. I know there are a lot of people from Brazil watching this online. The study is not recruiting any more patients. But we proposed in our grant to do a first ICPAT in all patients with persistent symptoms, evaluate autonomic function, do muscle biopsy and neurological testing, identify those patients with preload impairment, and randomize them into a pyridostigmine arm. This is so hard to say, right? A mestinon arm, and the other arm with placebo, and then repeat ICPAT and autonomic function evaluation after a couple of weeks. The background behind this, I know at this point everybody knows, came from the concept brought by Dr. Systrom about the preload impairment, and that there is likely a peripheral dysregulation, either endothelial or muscular or mitochondrial, that would impair systemic oxygen extraction. And that mestinon, by its way, its mechanism of function, would be helpful in increasing cardiac output, but increasing venous return and venous tonus in general. And we used this study published by them in 2022 to actually gain some insights about the potential size effect that could be found. And this study was an acute study using mestinon, that found an increase of approximately 50 ml per minute in the treatment group compared to placebo. Here were 2 ICPATs done in the same day with a couple of hours between them. So we established the ICPAT protocol, and this is part of our paper that is under review. It's basically the same protocol as done at the Brigham with some adjustments for the Brazilian reality. And I think this is the caveat of every center. It's impossible to replicate completely 100% one test in another institution. You have to make adjustments based on your institution. And this is the biggest point. Don't try to replicate identically, because sometimes, for example, you have supply limitations. We don't have in Brazil the type of catheters that are available in the US. So how can I replicate identically? I can't. I have to find the best one that I have that will give the best results. And then we performed the ICPAT. So I was actually, Dr. Systrom, back on the video that you showed. So the video that you showed is from 10 years ago. I was in the lab. And this is the video from our ICPAT lab. So it's basically the same setting. We have to adapt because we have a logistic problem to have the blood gases analyzed quickly. They are not, because you produce close to 20 or 25 blood gas samples per test, and they are crucial to the test interpretation. So we had to make them keep moving because we don't have access to ice in the floor. And if we try first to just leave them on the bench and they started to coagulate, something is related to the syringes themselves, the one that we have available, but this is the solution that we came of. So they keep spinning until someone actually analyzes them. And arterial line, central line, and all the non-invasive parameters that we get from a regular CPAT. With Professor Bruno's help, he is conducting basically a parallel study doing the autonomic function analysis, and we wanted to be this way so he could analyze blind from us, and we are blind to him, so at the end to see if we are seeing the same phenomenon. He's doing autonomic assessment at rest, at hand grip exercise and Valsalva maneuver. He's also doing a fatigability protocol using hand grip exercise and assessment of the lower limb venous capacitance and analyzing capacity and compliance, combining vascular ultrasound and years. And muscle biopsy, we are also performing, but the grant had a cut of 20% because this is how it works in Brazil. They cut it 20%, so we were not able to perform muscle biopsy in the entire sample size because this was the initial plan. You had to reduce significantly because of the costs related to it. The design that we did was actually to 40 patients, 20 in each arm. We chose 7 millimeters of mercury of radiator pressure to define preload because in clinical practice, it's hard to get 6.5. I know 6.5 is a number derived from a cohort. Or it's either you derive either 6 or 7. We decided to be more cautious and get 7 so we could include more patients. And we did something a little bit new that it was actually to propose to the patients to get the maximum tolerated dose of mestinon. We started with 30 milligrams 3 times a day and went up until 120 3 times a day or symptoms. So most of the patients do not tolerate this high dose. Most of them are in the middle dose. But we waited them to have side effects to give a step down. So we were sure they were on the maximum tolerated dose. And at the end, they were treated, the minimal time of treatment was between 4 to 6 weeks. A couple of them went up to 8 weeks. And ICPAT pre and post treatment. The first analysis that we did was actually describing how the characteristics of the population. So this is a preliminary analysis. We started screening 160, and here it's something very important because we had a really, really hard time to getting this study approved by our ethical committee because ICPET was something new for them, muscles biopsies, and we had also proposed the skin biopsy, and unbelievably they denied. They approved everything, but said the skin biopsy was too much. Okay, so we had to take it out from the protocol, and the patients' participation was surprising to us. With the study finished, we have close to 300 patients willing to participate in the study. Obviously, there is a huge screening process, and at the end, the numbers are smaller, but this is an important. Without the patients, we wouldn't be able to do the study. We started having the virtual contact of the patients, in-person screening, those who accepted based on the consent form, those who were in fact eligible to be part of the study, and at this point, we had 20 already analyzed with the ICPET, which is the analysis that I will show to you. Mostly female, 75%. This keeps in the second analysis, which is close to the end of the trial. Age is middle age, predominantly white people, and all of them had confirmed COVID because this was a requirement. And very little, so most of them had no hospitalization. Half of them had no hospitalization. Okay. Pulmonary function testing data showing that was no lung impairment. So we did not recruit patients with severe lung disease like the first COVID wave, for example. And we performed some questionnaires about the ME-CFS questionnaires, this autonomic questionnaire, and hyperventilation. And all of the patients had at least one dysautonomic symptom. Most of them fulfilled the criteria for ME-CFS and for hyperventilation. From the invasive point of view, poor oxygen extraction occurs very frequently, as Dr. Systrom said, so this was replicated in our study with low central cardiac function, low cardiac output, and low stroke volume index as well. So compatible with a central cardiovascular limitation with systemic vascular limitation. And the right atrial pressure really low and do not increase during exercise. So this is all baseline evaluation, no treatment yet. With this analysis, we were able to describe at least 3 phenotypes of the COVID-19. And this is the first description of long COVID with ICPET in Latin America. So by definition, we screen preload patients. Most prevalent phenotype is poor oxygen extraction, was 94% of the sample. Poor oxygen consumption, so 61% of the sample, so it's not mandatory, and this is, I think it's an important message. You can still have a disease with a normal VO2, because we have to understand that VO2 is a byproduct. So there are compensatory mechanisms that might normalize VO2 at the end. And very few had low cardiac output, and actually most of them had a higher than normal cardiac output. They were more on the hyperdynamic field of this phenotype. They had reduced aerobic capacity in general. The VO2 was around 75%. A little bit of hyperventilation and hypocapnia by the non-invasive data. We still have to look into the invasive blood gas analysis to confirm if this is maintained in the entire cohort and with the more accurate data. The second preliminary analysis is more robust. We are close to 300 patients, 32 randomized. The study has closed screening. The last patient will do the second and last ICPET in December. Here I'm showing 18 patients treated with mestinon and 14 patients on placebo. They were, again, the trends are the same, 72% women, age of middle age, a little bit on the overweight side. And there were no differences among the two groups regarding the baseline demographics, resting, or peak exercise hemodynamics. The right atrial pressure, with the peak right atrial pressure, which was a definition of an inclusion criteria for the study, was very similar between the groups. So 3.2 and 3.4, so they have the same. I don't know if this is a measure of intensity of preload dysfunction, but they had the same amount of filling pressure of the right atrium at least. And the VO2 was very similar also with a non-statistically significant p-value and higher than 1 liter in both patients, a little bit higher in the placebo group. And then the most important part of the study, this is the delta of VO2 from the first to the second ICPET. So the second ICPET was done here most of the time with the intermediate dose, 90 milligrams of mestinon 3 times a day, and placebo, and was done around 6 to 8 weeks after the first ICPET. And we saw no change in peak VO2 comparing the two groups, which was striking to us. But at the same time, during the protocol, we had the feeling that we were seeing patients very heterogeneous in terms of exercise intolerance. And this made us come back to the preliminary data and take a closer look at the hemodynamics. And what came to my eyes was this information. So the cohort in general had a very high pulmonary vascular compliance at rest and at peak exercise as well. And what does that mean? So compliance, this is the curve between compliance and resistance. The compliance is, in simple words, is how much the pulmonary vasculature can accommodate flow when flow changes, right? The normal is usually here, the blue. It's close between 6 and 7. It rarely exceeds 8. And we found in the COVID cohort patients here, and we even found patients with 15 of compliance. And so compliance is proportional to pressure. The compliance will decrease the higher pressure you have or the higher flow you have. And then we thought that because we have so bad preload, so the filling pressure of the RV is so decreased that we might not be distending too much the pulmonary vasculature, and we might be causing a higher pulmonary vasculature and therefore decreased autonomic function of the pulmonary vasculature, because we have to remember the pulmonary vasculature has autonomic nodes, let's say like this, that are activated when the vessels are distended by blood flow. This is part of the normal physiology. And once you don't have these mechanisms, you might have some problems. And then we made this entire hypothesis that I just told you, that we might be facing patients not only with peripheral dysautonomia, but central pulmonary vascular dysautonomia secondary to preload failure. We decided to divide our cohort based on what we believe it is a normal pulmonary vascular compliance by old studies, which is normal to be below 8.6. And then we found a treatment signal. So this is not the entire cohort of the study yet, but we found a signal of an increasing VO2 of higher than 100 liters in those patients that do have a lower compliance. That means a normal pulmonary vascular compliance. So we believe that they are having their autonomic system of the pulmonary vasculature properly activated. The ones that had very high compliance, they do not respond to methadone, maybe because their symptoms are not only peripheral, but are also central, and methadone is mainly a peripheral drug agent. So these are actually the results of the clinical trial. We are about to finish and hope to confirm this signal with the bigger sample that we are finishing in December. And this whole conference was already very worth, because we already, Dr. Systrom and I and other colleagues from Yale had a plan to see if we can confirm these findings in a bigger cohort, combining all the data from all our centers. And I would like also to finish giving you a little bit of the Brazilian perspective. I think this is important for the Brazilian audience there is online, because we have done the study. This is research fund in Brazil, and I believe everywhere else in the world. So research fund is something, healthcare fund is something completely different. So this fund to do this came from the research side of the government. It's done, it's done. There is no funding to continue. We are seeking more funding. We are looking into it, have applications ongoing to see if we can get more funding, but that's it. The study, the diagnostic tools, they are not available on the public healthcare system. They do not have codes. They are not even available they are not even covered by health insurances, because there are no codes for them in Brazil. So ICPAT, it's not covered by health insurance. The only way to do it is private, because then they will pay the full price, but health insurance, they don't even pay anything. And this is a problem, because we have established a very high-end, state-of-the-art lab with a lot of money gave from the government, but we are still trying to convince the politicians that they should do it clinically, otherwise there will be a lot of patients without care. So Brazil, it's a very big country, close to America. It's very high, it's very big in territory. It's very disparate. You have very different Brazils inside Brazil. Over 210 million inhabitants. There is money. The problem is that because it's a big economy, the problem are the people that handle the money, not the money. And we have a lot of patients. São Paulo, where my institution is, has 3% of the Brazilian territory, concentrates 22% of the Brazilian population, and is responsible for 30% of Brazilian income. So the state has a lot of money, right? They can invest also. And just the city of São Paulo has over 12 million inhabitants. It's the biggest capital of the entire Latin America. So we have a lot of patients. We had several talks with the Brazilian health minister, several. It's like a dog going around his own, because every time you say the same thing, they pretend to believe, we pretend to believe that they are believing, and in the next meeting, we start all over again. But this is the point. With the amount of inhabitants that we have, we should have at least 20 centers for ME/CFS based on the international literature. Just the state of São Paulo should have at least 4 centers. Just the city of São Paulo should have at least 2 centers. We have 0 centers, officially recognized by the government and officially funded by the government, 0 centers. Our center was funded by research. So we are on the gap currently. We need funding from healthcare so we could provide this to the patients. And we showed them this, but they did not seem to be, they seem to understand, but they don't do nothing with the understanding. So if they invest close to, this is close to 1 million euros, you would reach close to 2,500 patients, and you would be spending less than 3% of the healthcare costs of these patients if you don't provide healthcare to them. So the investments are high, but the cost of the care is higher. This is the whole point, that we are trying to convince the government that they should create the first center, because if they don't create the first, there will never be a second or a third or the 20 centers that we need. So as take-home messages, I think I would like to highlight all my colleagues and the backstage of the research. It took a decade of dedicated investigation, so I left the Brigham in 2017, almost a decade ago. I arrived more than a decade ago. And I think I like a quote that I heard when I was at Harvard, which said that lucky is when opportunity meets preparation. So I think we were ready to start once the opportunity appeared. And then the grant started, and we were able to put all the knowledge in practice. About the study design, we try to do a multi-level mechanistic investigation, which will hopefully give a lot of insights, although from the also colleagues from the muscle biopsies and autonomic function. The preliminary results suggest there are phenotypes, even within preload, there are subphenotypes of preload, and they do have all poor systemic oxygen extraction and reduced aerobic capacity, but methadone seems to work better in those who have normal compliance, pulmonary vascular compliance. And bringing our results into the Brazilian context, we need critical healthcare infrastructure, and because there are a lot of patients, the disease is a burden, the healthcare system is underfunded, and if we do all this nice research but don't receive the next step, which is funding to provide health care, it will be just very nice papers that will not have an impact on the society. And I think nobody wants that. And just the last one, this is just the last one. In Brazil, we have the healthcare system, which is entirely free and public to everyone, underfunded. So there are huge waiting lines to get started. Since we did not convince the Brazilian government that it is worth creating one, we created on ourselves in moving to the private sector. So currently we run two programs, one in the public, which is doing the research and it's seeking for funding, and we open a private one. So for all of those watching online who wants to reach out to us, this is the way, because in the public service, you cannot reach out to us because there is a very strict referral system. You have to go to a referral pattern until you reach the tertiary center. And here, it's more free at a cost. Thank you very much.
And to finish block 4, last but not least, Professor Aaron Waxman. Professor Aaron Waxman is Director of Pulmonary Vascular Disease Group, Brigham and Women's Hospital from Harvard Medical School. Professor Aaron Waxman will address the topic, long COVID and pulmonary hypertension. You use your own computer? Yeah. Okay. So long COVID and pulmonary hypertension and other suspected cardiopulmonary comorbidities. My pleasure and a great pleasure for us to welcome you in Porto, Professor. It's yours.
Oh, thank you so much. And as you can see, I changed the title, mostly because we've been hearing a theme of what is going on in patients with chronic fatigue and ME, as well as long COVID. But I'm going to now show you that this applies to a broad spectrum of patients, and there's a significant overlap. So bear with me. So what I want to cover is first the whole concept of dysautonomia on invasive CPAP, which you've heard a lot about already from both David and Rudolph. We'll talk a bit about the autonomic targeted therapies in clinical practice and how they actually apply well beyond these patient populations. I also want to talk a little bit about pulmonary hypertension, which I recognize that many people in the audience may not know much about, so we'll be very basic, but stress that it overlaps from an autonomic standpoint, and that some of the treatments we use for pulmonary hypertension may actually exacerbate some of the underlying autonomic dysfunction. And then we'll finish up with integrating really a comprehensive autonomic assessment into the patient population who have pulmonary hypertension. So to start, I thought a little introduction to pulmonary hypertension for those who are not aware of this disease. It is a rare disease, although it's not so rare when we think about the broad spectrum of patients who have pulmonary vascular disease. We define this disease hemodynamically. So we define it as a mean pulmonary artery or average pulmonary artery pressure being greater than 20 millimeters of mercury. So normally the pulmonary blood flow is up against a very low resistance, high capacitance system so that it can accommodate big changes in cardiac output without causing problems in the lung. We also define it relative to the pressure on the left side of the heart. A normal left atrial pressure should be 12 millimeters or excuse me, or less. Generally, for the definition of pulmonary hypertension, we allow it to go as high as 15. And fundamentally, it's a disease of abnormal resistance or stiffness in the pulmonary vessels. And there, we want to see a low resistance system, and we define it for, it doesn't really matter the units, but a pulmonary vascular resistance of 2 Wood units or less. So very high flow, low resistance system. What happens in patients with pulmonary hypertension is that there's an abnormal cellular growth, proliferation, and fibrosis that result in stiff, constricted blood vessels. And that over time increases the resistance to flow, causes a backflow into the right heart, and the right heart starts to adapt initially and then maladapt so that it gets dilated, dysfunctional, and eventually fails, and these patients die from right heart failure. Just to stress that this is not simply a vasoconstrictive problem, but what you can see here in the upper right, up in here, is a pulmonary vessel that's well out in the pulmonary vascular tree. This is even further distal, and these are very thickened walls. You can see lots of cells there. Normally, these are very thin, compliant, and then allow for a lot of distensibility. What we've learned is, and this big conglomtion here, is the pathognomonic finding in patients with PAH, where we've got this disorganized cell collection that's reflective of this abnormal growth and fibrosis. And when we look closely, and this is part of the common theme across all of these diseases, is there's an infiltration of inflammatory cells. There's a robust inflammatory milieu or environment that probably drives a lot of this. There's also abnormal proliferation, and depending on where you are in the vascular tree, there's abnormal proliferation and activation of endothelial cells, and more proximal, like what you're seeing here, is there's also proliferation of smooth muscle cells. We've also learned that cells get bigger, probably reflective of both the physiology, but also just abnormal activation, which I think is a theme we've heard about today across the spectrum of endothelial cells in this disease. And then we've also learned that in pulmonary hypertension that there is abnormal differentiation of cells. So we can see connective tissue cells infiltrate into the lung and into the tissues of the lung and then transdifferentiate into fibrotic cells, making the whole process more stiff. Now, how do we treat pulmonary hypertension? This is way outside the topic here today, but right now I can just tell you there are 4 general pathways that we target with pharmacology. 3 of them are vasodilators, and we'll get back to that later. But you can see over here the 3 general vasodilating pathways. Prostacyclin pathway, because we know these patients are deficient in prostacyclin, which is a very potent vasodilator. The nitric oxide pathway, which biologically is our most important vasodilating pathway. And then the endothelin pathway, which we actually block because endothelin is increased in these patients. And endothelin is a potent vasoconstrictor as well as pro-fibrotic. Now, most recently, we've targeted the TGF-beta signaling pathway, and we heard a little bit about that earlier today. Here, this is part of the abnormal proliferation of these patients, and we can take out parts of this pathway so that it rebalances the system into a non-proliferative state, and we can actually now reverse some of the features of this disease. But again, this is outside of today's topic. So what is the paradox I'm talking about? Well, PAH-specific therapies, as I just pointed out, are generally pulmonary vasodilators, so they decrease that resistance in the vessels. The right ventricular function starts to improve as we decrease the pressure and the resistance. Yet, what you're going to see, and I'm going to show you a couple of patient examples, are that patients whose pulmonary hypertension is getting better still have persistent exertional intolerance, and this is where the overlap between this disease and what we've been talking about today settles. And the traditional endpoints then, we always think about hemodynamics in these patients, needs to be adjusted once the hemodynamics are better, because in spite of good hemodynamics, these patients still have clinical limitation. So why might these patients still have exertional intolerance? Well, there are a number of reasons when we start to think about mechanism, especially when we want to start thinking about the autonomic nervous system. Peripheral chemoreceptors may be dysfunctional in spite of normal hemodynamics. The sympathetic nervous system plays an important role in the response to the abnormal physiology of pulmonary hypertension, but if we disrupt that sympathetic nervous system, as I'm going to show you, we can really screw things up. These vessels are abnormally stiff at baseline, and even though we're seeing normalization of their hemodynamics today, they still may have some abnormal responsiveness in those vessels, and there's probably sensation in those vessels that we have yet to discover that probably transmits some of their dyspnea. And then RV dysfunction, even though things have gotten better, there may still be under stress some abnormal RV function. And then skeletal muscle abnormalities, especially when we start to think about mitochondria. So fundamentally, exertional intolerance, no matter what disease state you have, is multifactorial, and hemodynamics is just one part of it. So getting to the autonomic nervous system, which, as I pointed out in the title, is probably fundamental in all of this. PAH is fundamentally an autonomic disease. Yes, it's a proliferative disease in the vasculature, but the response to that abnormal proliferation is activation of the sympathetic nervous system. And indeed, hyperactivation of the sympathetic nervous system can actually be detailed in patients looking at their skeletal muscle response and vasomotor response. And elevated sympathetic or muscle sympathetic nerve activity has been well documented in these patients. So really, autonomic dysfunction is compounding the vascular abnormality. And we can see that on a cellular and molecular level. In PAH, like many heart failure-focused diseases, we can see significant upregulation of the renin-angiotensin-aldosterone system. In fact, it's an important part of what we target pharmacologically. We can see upregulation of angiotensin 1 and 2 levels, which have direct effects both centrally and peripherally as far as activating the sympathetic nervous system. And part of our treatment paradigm for PAH is to actually try to block this system, more to target the kidneys and fluid management, and indirectly the sympathetic nervous system. So as far as if we do disrupt that sympathetic nervous system, as I've already mentioned, overactivation of the sympathetic nervous system really drives a lot of the response to PAH, and in fact, you can see a clear correlation of the activity of the sympathetic nervous system with patients' long-term prognosis. So it's really a form of compensation in these patients, and probably is a response to the remodeling that we see in the vasculature. In fact, what's being proposed in the world of pulmonary hypertension now is to ablate parts of the sympathetic nervous system in the pulmonary artery specifically. The concern many of us have with that is it's kind of ignoring the teleologic reason that the sympathetic nervous system is activated and may actually not do a whole lot of good for these patients. But We'll find out from the clinical trials. So let me share with you a couple of patient examples of what all of this comes together as. So the first patient is a 60-year-old woman who was actually presented to a pulmonary hypertension center in New York, was diagnosed with pulmonary arterial hypertension. She was diagnosed by right heart catheterization, and she was started on treatment, which was 2 of the vasodilators that I mentioned. Now, in spite of treatment, she still had persistent chronic fatigue and exertional intolerance, and we also noted that she was hypoxemic, and her diffusing capacity, even for those who aren't familiar, diffusing capacity is part of a full pulmonary function test, and actually is a way of measuring the surface area of the lung that's involved in gas exchange. And typically we will see a DLCO or diffusing capacity reduce in patients with pulmonary hypertension because of the vascular disease. And if we think about the lung, the critical function there is to match ventilation with perfusion as best as the lung can. So here you have a disease that's involving the pulmonary blood vessels, and we typically do see some reduction in diffusing capacity. In her case, though, there was a severe reduction in diffusing capacity that was out of proportion to her pulmonary vascular disease. Well, we took her to the exercise lab. We did an invasive CPET to try to figure out what is the reason she's still symptomatic in spite of a good response to treatment for PAH. And we found out, and I'll show you her data because I think it illustrates, especially the 3 patients, that she had features that were consistent with dysautonomia. We took her to skin biopsy, and she had a small fiber neuropathy and was started on pyridostigmine. She got some improvement with pyridostigmine, and because of the skin biopsy findings, we also treated her with IV immunoglobulin. And she had a marginal improvement with that. But because the DLCO remained low, we took her to the OR and we did a lung biopsy. And her lung biopsy actually showed that there was deposition of C5b9 complement, which is an important part of the immune response. It was actually causing damage to her pulmonary capillary bed, and also, which gets to some of what we've heard from our colleagues in Stellenbosch, some abnormal clotting issues. So let me show you her data, because her response to treatment has been quite interesting and supports a lot of what we've been hearing about. So what you can see on this slide is the baseline is her right heart cath when we met her. So she's already been treated for pulmonary hypertension with 2 medications. They're down here. Ambrisentan is an endothelin antagonist, and tadalafil is a nitric oxide pathway stimulator or a phosphodiesterase 5 inhibitor, so upregulates the available nitric oxide. And what you can see here is that she still has pulmonary hypertension. Remember that mean pulmonary artery pressure should be less than 20, and her resistance is 2.5, so just really mildly increased. So I suggested at that time, double your drug, because this is half dose of both, and she went up to full dose, and 6 months later, this is her right heart cath. So it's normalized, and I'll show you the exercise data. Yet she's still symptomatic, still has exertional intolerance and chronic fatigue. And then 6 months or 12 months after that, you can see still has a pretty good looking right heart cath. So I'll show you what we saw. So that first right heart cath we did, you can see here, this is her exercise test. At peak exercise, she got up to 72% of her predicted maximal VO2. But what I want you to see here is what happens in her right atrium. These pressures, as you've already heard, should be over 6.5. They don't even come close to 6. Here's her mean pulmonary or her pulmonary artery pressure here, and this is the mean. It does get a little bit high, so she still does have some vascular stiffness, but really not impressive to account for the limitation that she had. So 24 months later, what we did was, because of that lung biopsy, we put her on a JAK inhibitor to try to block her complement activation that was causing the damage to her capillary bed. You can see here, though, she still has right atrial pressure that's low. And remember, she's on pyridostigmine and getting IVIG. The other important thing I didn't point out here is the mixed venous oxygen saturation. Remember, this should be down around 28%, so she's got a very significant abnormal oxygen extraction and probably is also generating a left to right shunt, as you heard from Dr. Systrom earlier. This is what happened before we started the JAK inhibitor. So this is all just really findings of dysautonomia at the same time she has pulmonary hypertension. And this is what happened after the JAK inhibitor. Really continued improvement in her pulmonary pressures. She still has significant preload failure and still has, but somewhat improved oxygen extraction. Once we started her on the JAK inhibitor, she actually started to improve significantly. So she's now able to walk significant distances and is actually now exercising regularly. And this is what happened with her diffusing capacity. We started the JAK inhibitor here, and we've been measuring her DLCO along with doing those CPETs, and you can see it's now, after several months, started to improve. So this is just an example of a patient who has an inflammatory disease state that is also generating the same physiology that we see in our patients with dysautonomia and ME and long COVID. Now, this is our next patient. This is a 25-year-old woman who came to us with a diagnosis of idiopathic pulmonary hypertension. When we met her, she was on 2 medications, both the same drugs you just heard about, but still significantly symptomatic because of PAH. Now, PAH we've always thought of as an inflammatory disease state. And this patient did not tolerate prostacyclin therapy, and she elected to go into one of our open-label clinical trials with a new medication, sotatercept, that targets that TGF-beta signaling pathway. As part of that study, she went through 3 series of invasive exercise tests. So these are her right heart caths, and you can see here that she had pretty significant pulmonary hypertension. Remember that PA pressure should be less than 20, and the resistance should be less than 2. 6 months after starting sotatercept, she's normalized her pressures, and yet still symptomatic. She's still complaining of fatigue and shortness of breath, but clearly not because of PH. This is 12 months later. This is a patient that we then did as part of the trial. This is her CPET data. And you can see again here, her right atrial pressure is profoundly reduced. And this is her baseline before we started sotatercept. And you can see here she's got a very significant oxygen extraction abnormality. So this is 6 months after sotatercept. She still has the same picture of preload failure. You can see that she still has significant oxygen extraction abnormality, but it's improved. And we've started her now on pyridostigmine after we saw this improvement. So now we're trying to target her dysautonomia. And here's her follow-up, and this is after 12 months of sotatercept, and she's been on pyridostigmine about 6 months. And you can see the right atrial pressure really doesn't change much. She has no evidence of pulmonary hypertension, but her oxygen extraction is starting to improve, and subjectively she feels markedly better. So targeting the sympathetic nervous system. And the last patient I forgot to mention though, her VO2 max also started to improve. This is our last patient that I wanted to share with you. This is a 66-year-old male who also came to us to go into that sotatercept study. He came in initially on some medications that we changed. He remained symptomatic, and by symptomatic, he remained a functional class 3, and then went into our clinical trial. I'll show you the data, but importantly, after about 7-8 months into the clinical trial, he actually contracted COVID. So what this is an example is a patient with long COVID. So these are his right heart cath data. This is his baseline before he went into the clinical trial. You can see he has very significant pulmonary hypertension. This kind of number would put him into what we would call the severe range. This is after 6 months of sotatercept and significant improvement. And then this is 12 months later, even more improvement. And it was in between these 2 studies that he contracted COVID. Now, this is his invasive CPET. This is at baseline. You can see here he does not have preload failure. This is fairly typical of what we see in a PAH patient, in that he has this big jump in right atrial pressure at peak exercise, which probably reflects an uncoupling of the right ventricular pulmonary artery blood flow. You can see here too that his pressure is still on the high side, and his extraction is excellent. Remember, I said this should be under 28%, and this is fairly typical of what we see in a patient with heart failure, and that they're just sucking the oxygen out of the blood. This is now 6 months later on sotatercept. His right atrial pressure is lower, but probably more reflective of our treatment of pulmonary hypertension. And you can see that at peak exercise, he does get up above 6. He still has significant pulmonary artery hypertension, and you can see his extraction is fine. So after this is when he contracts COVID. And this is what happens now 6 months later. You can see here his right atrial pressures have now fallen. And you can see he's still extracting nicely. He's got improved pulmonary hypertension, but he's really developed significant preload, and he was more symptomatic. We actually treated him with midodrine, which is an alpha agonist, so a vasoconstrictor, and it's been actually quite helpful to him symptomatically. So what's happened with all of these patients, because they all have a very similar physiology, and they all actually have positive skin biopsies for small fiber. So what we believe is happening, and why we think of this as an autonomic dysfunction, especially in those patients who have positive skin biopsies, if we think about the blood volume in the body, we can break it up into 2 big compartments. We have the arterial compartment, which holds anywhere from 25 to 30% of our total blood volume. The vast majority of our blood volume is sitting in the venous compartment, which we can then break down into 3 compartments: the muscular compartment, the cutaneous, and then the splanchnic. Now, importantly, with muscles, we obviously have muscles that contract and can act as pumps, as well as veins that have valves and a sure one-way flow. But obviously in the cutaneous and splanchnic beds, we don't have valves, and we certainly don't have muscles. So there's a propensity for blood to pool. If we look at these patients with positive skin biopsies, what we see is a dropout of the sympathetic neurites using sweat glands as a surrogate for vessels, and just a dropout of the density of these neurites, and essentially a loss of the signal to maintain venous tone. So this, we believe, is what's driving a lot of this. So we end up with splanchnic and cutaneous venous pooling, and the peripheral, which left to right shunting, which you've already heard about, is loss of regulation of these bridging vessels between arterioles and venules close to the capillary bed. And I think all 3 of these patients show various pieces of evidence for this. But why is this such an important issue with pulmonary hypertension? Well, in pulmonary hypertension, because of this increased resistance, we start to see the right heart dilate and try to compensate for this resistance, which means they become very preload dependent. And here we've got a bunch of patients with preload failure. So this is a normal conformation between the right ventricle and the left ventricle. Patients with pulmonary hypertension, we start to see this dilation of the right ventricle, and even imposition and almost squishing of the left ventricle as the pressures really get significant. But even in patients with low pressure, we tend to see this kind of arrangement. It tends to affect diastole, so the filling of the heart becomes compromised, and they become very dependent on just the right amount of fluid. So there's really an optimal range of preload in these patients. And this just shows you the relationship of preload to really flow. And patients with too much preload, we start to actually push even more into cardiac distension, and it reduces function even more. Patients with too little preload, essentially the tank is not filled enough, and their pulmonary blood flow becomes much more dependent on heart rate rather than volume. And then really the optimal preload is somewhere between 8 to 10, 8 to 12 millimeters of mercury. So not too much, not too little, and it maintains enough forward flow that these patients actually feel better. So as far as pharmacotherapy here, I think you've already heard me mention pyridostigmine. There's actually been some small studies looking at pyridostigmine in PH patients, and the reason for using it in the patients I showed you is because they also had evidence of dysautonomia, and this being an acetylcholinesterase inhibitor should amplify that signal that is decreased because of the loss of the neurites. There's also some evidence that using beta blockers, something that's used frequently in POTS, may also have some benefit. So as far as patient management, I think the whole point to all of this is that patients with PAH or pulmonary hypertension in general, for whatever reason, are suffering from an inflammatory disease. The commonality across the whole spectrum is inflammation that probably affects endothelial cell activation. And that if we're really going to think about these PH patients, especially those who are persistently symptomatic, in spite of treating their PH, we have to think about autonomic function and how we can target that, how we can measure it, and even screen for pieces of autonomic disease. So to finish up, again, PAH certainly has features of autonomic dysfunction that we can't ignore. It's not just a vascular disease. Sympathetic dysfunction is really a critical determinant of their symptoms as well as their long-term prognosis. I think effective therapy in PAH certainly reduces pulmonary vascular resistance and improves heart function, but does not restore autonomic function itself. And that persistent symptoms, in spite of good treatment of their PAH, should be considered to reflect underlying autonomic dysfunction, and ideally that future PAH therapy will include that in the long term. So to conclude then, treating the pulmonary vascular bed without considering the autonomic nervous system is probably not a full management of these patients. And even though they improve hemodynamically, many of them will have limited function because of their ability to adapt to stress is governed by those autonomic mechanisms, and that too remains severely impaired. And so that the next frontier of managing these patients needs to include restoration of autonomic function. So thank you. I can sit.
Yes. We are a little bit ahead of time, so I ask the other speakers to join us, and we make the Q&A and discussion before the coffee break. So we have time. So I open, first of all, thank you very much for your excellent talks. It was an amazing opportunity for all of us. And I open the questions to anyone in the audience who wants to ask this excellent. Betsy.
Dr. Waxman, I was curious, do you see ECG manifestations in these pulmonary artery or pulmonary hypertensive patients? Do you typically see the ECG abnormalities that you would expect?
So we do see alterations in heart rate variability and recovery. But when you say ECG abnormalities,
right axis deviation.
Oh, yeah.
All of that stuff usually, I mean, because that's all I have to look at when we're testing these people. So
depending on the degree of pulmonary hypertension, we'll see right axis, we may see right atrial enlargement, and in some patients we'll even see conduction abnormalities, especially a right bundle branch block.
Right, okay. I have another question for Dr. Systrom, if I might. So could the reduced right atrial pressure be explained in part by endothelial dysfunction, decreasing preload? And I mean, is that as opposed to issues at the mitochondrial level?
Yeah, I think, Betsy, the short answer is yes. We can't exclude endothelial abnormalities across the whole systemic circulation. We don't find much in the pulmonary circulation or much evidence of it, but that could include the venous capacitance vessels as well. I'm inclined to think, without much in the way of, well, we've got some data, that the microcirculation is probably more susceptible at the muscle capillary level to endotheliitis or endothelial structural change just because of the size. And what we're talking about, of course, with the venous capacitance system is big veins. But we can't preclude an endothelial abnormality there.
Okay, I have one more, but I'll come back after.
No, another one, and you
Quick
finish.
one. Okay, if you were to clamp or put a tourniquet on the leg, for example, what do you think you would see in terms of the mitochondria? Now, I'm not suggesting you do this, but I mean, you could cuff it. But what do you think would happen in terms of your ABO2 difference, your mitochondrial patients for mitochondrial dysfunction?
So, great question. There are circuits for what you are suggesting here. So it depends how firm that clamp is, how many millimeters of mercury you blow it up to. So just very quickly, if you blow bilateral big blood pressure cuffs, and this has been done, up to impede venous return alone to about 40 millimeters of mercury, there's some really interesting things that happen. Patients, normal individuals, and patients hyperventilate, and their preload falls, and if in the upright position, their physiologic dead space to tidal volume ratio is excessive, they're probably de-recruiting apical capillaries. But on the arterial side, which is effectively ischemia, it's a great question. I think Rob Boost and I have been discussing some of that, maybe using peripheral arterial disease with claudication as kind of a disease model that might mimic some of what's going on in ME and long COVID. So if you took a normal individual and did ischemia, you would induce HIF-1 alpha, you would have the Pasteur effect. Immediately glycolysis would ensue, especially if you're doing exercise, but if you leave it long enough at rest, it would happen as well. But it's reversible, at least for a while, unlike some of what we think we see in patients.
Thank you, David. Thank you, Betsy. Rob?
So I have a very much of a
Rob over there.
Yeah. I have a very much holistic question for maybe all four of you, but actually also maybe to Betsy. So what about the use of either invasive or non-invasive CPAT test for diagnostics of patients? Do we need that? Do we need diagnostics for patients that they have to undergo an exercise test? In research settings, of course, this is important, but do we need to let patients undergo a maximal exercise test?
So why don't I share?
Yes.
The simple answer would be yes, because because there are a lot of patients that do not have any changes in other type of tests, and the only abnormality appears during an ICPAT.
Yes, so there would be a 2-day CPAT test. You would have to do.
Or a 2-day CPAT or an ICPAT. So I don't have clinical experience with the 2-day ICPAT.
Do you want to say something, Aaron?
Only on the ICPAT.
Yeah, Aaron, maybe you could help.
Yeah, I would say we absolutely need invasive CPAT to make a diagnosis. You can certainly track a physiologic abnormality with non-invasive, but just as an example, when David and I set up the dyspnea program at the Brigham, the first year, and the idea of the program was to diagnose or to define the physiologic basis of patients' unexplained exertional intolerance. So the vast majority of clinicians out there, they're going to get an echocardiogram, they're going to get a pulmonary function test, some form of imaging, and it's all at rest, and they're not going to be able to know why these patients are short of breath. You do a non-invasive test, and pretty much every readout from there is non-specific. With an invasive test, we can define all of the contributors to shortness of breath, which you can otherwise be shooting in the dark for months and years. And what we learned was that if we do an invasive test, it's an expensive test and not always available through healthcare systems, but it will tell you what's wrong. The non-invasive testing, it costs upwards in the US, $100,000 to $250,000 over years of testing in the average patient, and they still don't know what's wrong.
But can I be just an advocate of the devil here? Because technically, if you are, for instance, an elite athlete that also gets long COVID, probably your tests are very much in the normal range again, because they started off with values that were way higher than the normal population.
Well, from an athletic heart standpoint, there are clear features of the athlete, but there are also abnormalities if you're going to invoke COVID that a typical athlete would not have.
Can I add some, from my experience, I mean, being a guy working in rehab, pulmonary rehab for some time, and taking care of some patients that do CPATs just to guide rehabilitation. I think that a non-invasive CPAT can be helpful in guiding rehab. First, just to rule out PEM, because if the patient has a pattern, like Dr. Keller was saying, of PEM, this is really contraindicating, aerobic graded exercise. And also could, if the patient has kind of a dysfunctional breathing pattern, which is something that I don't see a lot, but there are described in the literature, you could suggest like some breathing retraining. That's something that is simple. There are apps already available, and some patients just feel better. And also in the muscle training, I think it's important, but even very severe patients that can do inspiratory muscle training, especially when they have weak inspiratory muscles. So like I mentioned, PI max that is low. You can also do some complementary, strength tests for that.
And David, yes,
just
very invasive, this test, isn't it?
Yeah, so we have a running joke, Rob, in our lab. It's not really a joke, and that is we're always looking to put ourselves out of the invasive business. And we would love, the holy grail is less invasive biomarkers that are reliable, that really tell us about subsets of patients with ME and long COVID, and then we can treat with precision medicine. We're not quite there yet. So in the meantime, the invasive CPAT, it's not for everyone, and we don't suggest it is. We think it's helpful in defining some of the subtypes, and then hopefully biomarkers, bloodborne or otherwise, will serve us well, whether it's proteomics, metabolomics, transcriptomics.
The reason that I'm asking, so just a final question, final comment on this, because I think a lot of patients are afraid to do these exercise tests to max because of the extent that they will go into PEM afterwards. So there is this real sort of problem, but I think we all know about this. But
When we established the program at the Brigham, we did some surveys of patients, formal surveys of their satisfaction with the test. And this is a running joke. We asked them whether the dentist is worse than we are. 99% says the dentist is worse. But I talked to Betsy earlier about this, partially perhaps because we're seeing somewhat less severely ill with patients with ME and long COVID, because they have to walk in and volunteer and hop on and get their catheters. We don't have a lot of PEM related to a 5 or 6 minute test where only the last minute or two is intense. We also give them IV fluids often afterwards, but it has not been a recurring theme.
So, yes, Aaron, of course.
One thing that has, from a patient satisfaction standpoint, the ability to give them answers has been hugely important. And I think that also motivates the patients,
of course,
to come, and some to come back, as you've seen, for multiple tests.
We have more questions from the floor. Betsy again?
I just want to add to your concern, which is very valid. And I usually start every talk with, I would like to never have to do this again to a patient with fatiguing illness, but I'm going to talk about it from the need for it from the perspective of a person who's trying to get disability insurance coverage. And you have to be able to write a report that explains to
Precisely.
an attorney and to the insurance company in a compelling way why this is necessary. So if we were to do a submaximal test and I just talked about, well, they exceeded their ventilatory anaerobic threshold, and if they do, if they walk up a flight of stairs, that's going to provoke their PEM symptoms. They won't care. They'll just disregard it. So you've got to show, here's what they are at the beginning, and here's what PEM does to them. And then they start to pay attention sometimes. So
Thanks for your comment. Now we have another question over there.
Can I make a compliment?
You have?
Yeah, just we are on the
yes.
same theme. I think the patient satisfaction is very important. So we very frequently hear from the patients that perform the test, at the end, did you find something? Say, yeah, we found something. Oh, it's not everything from my head. No, you have something. And just this, even though we don't know how to treat yet or the best treatment approach, for them it's very relieving already.
Another question?
I'll try and keep it very short. There's been recent evidence of training status basically shifting limitations in VO2 max from something more mitochondrial focused to something more perfusion limited. So those being less trained, being more perfusion limited, and then shifting towards mitochondrial with training. Can any of you comment on how that might be affecting the ICPET with varying disease levels and varying other comorbidities, and how previous training status might then be implicated in something like the preload failures or the extractions that you see?
So, Brandon, I think there were two questions there. One was, could a diffusion abnormality contribute to some of the findings? And the second was, if you're a prior athlete, how does it influence you?
Not even like prior athlete, but just like we'll call it previous training status, but just previous activity levels prior to disease.
Yeah, so Anouk and I have had a vigorous discussion about left to right shunning peripherally and the possibility of a diffusion defect given what your group has shown with muscle capillary basement membrane thickening, a diffusion barrier, and perhaps endotheliitis and microclots as well. So absolutely, they're not mutually exclusive, but they may cry out for different treatments in the end. I think we addressed a little bit the prior well-conditioned individual, including athletes who then suffer long COVID, for instance. Beware of the VO2 peak there that's 90 or 100% because they may have been 150% prior, and one has to dig a little deeper to find the abnormalities.
Another question? Well, if you don't have any questions, I have questions from the virtual listeners. Professor Aaron, may septical dyskinesia and left bundle branch block explain the low cardiac output?
What was the left bundle?
The septal dyskinesia and left bundle branch block, the conduction system, electric conduction system.
Yeah. Does it explain that person's?
Yes, explain low cardiac output in these persons, yes.
I don't know. I mean, it really depends. There are a number of things. Cardiac output, I think sometimes it's not the cardiac output that's the issue, it's the stroke volume. So it depends on why they have a left bundle branch block, what other abnormalities there are. Is it purely left heart, or is there also right heart disease? So I think that's...
Which tests do you recommend to characterize better that situation?
Well, certainly, if it's a low cardiac output and they haven't had an invasive CPET, that means it's probably on a resting right heart cath, and that may not explain why they're dyspneic. It just simply says they have a low cardiac output. I think you need a dynamic test to actually explain it, and it may be other testing like cardiac MR, echo, things that can actually look at function.
Thank you. Professor Vink, just another question for you. You talk a lot about phenotypes. In clinical grounds, how CPT CPET phenotypes can help program rehab, by the way.
Well, I spoke about that a little before, and I think they are quite useful, especially just to exclude PEM. So there is a nice proposal from, I think, the German group, just separating patients with ME in three groups: the ones that don't have PEM, just based on the questionnaires, but also on 2-day CPAT, that they can be included in more intense kind of a training program, like strength training and aerobic training. Whereas the patients that have kind of a mild PEM, that probably they will need just more careful, more graded exercise, and they are the ones that have PEM and severe PEM that should not be doing aerobic exercise at all and should be, on pacing. So that's basically what I would take from these different phenotypes.
And a question for Professor Rodolfo Oliveira. Do you think your results with periodic mean could be related with, for example, the severity of the COVID infections previously or different strains of SARS-CoV-2?
Yeah, we don't know. It could, but we don't have the answer yet.
Okay. And finally, David, from the virtual attendees, are there any commercially available mitochondrial function tests which would help to direct treatment at present? Do you know any commercial available mitochondrial tests?
Oh boy, most of them are really indirect measures in ruling out O2 supply issues. For instance, there's the endopath with ischemia reperfusion that informs whether the resistance arterioles are behaving normally or not. It's mostly ruling other things out that could cause anaerobic muscle metabolism. The real diagnosis has to be made with a fresh or frozen muscle biopsy presently.
So we have time for one last question. So I'll ask Aaron, what about endothelial activation? Do you think this is a common pathway that in the future could help us identify these patients, identify a biomarker, things like that?
And when you say arterial...
Endothelial activation.
Well, I think what I've been hearing today is a common theme of really endothelial activation. We saw the capillary pictures that look occluded. We have lots of inflammatory evidence in our patients with both ME and long COVID and pulmonary hypertension, all of which have vascular dysfunction. So I do think the common theme is endothelial activation, probably through various different pathways of activation, but that's maybe the common theme. There are things that we're looking at in the pulmonary vascular realm that we know do result in that, like the bone morphogenetic proteins, which dysfunction of that system is what we're targeting with the TGF-beta signaling pathway. But if we reduce certain bone morphogenetic proteins too much, we then see chronic endothelial activation. And that may be some of the overlap between a lot of these disease states.
Thank you very much. I think this was a fantastic end. And now it's coffee break, and we have 15 minutes coffee break. Thank you very much. Thank you. Thank you, Dave. Fantastic presentation.
It's great. Lovely job herding cats.
Aaron, great pleasure to meet you. You too. Thank you.
especial ao comitê executivo desta conferência, ao professor Jaime Branco, ao professor António Vaz Carneiro, ao professor Germano Souza e à doutora Johanne Serra Hoffmann. A vossa visão, a vossa determinação e a vossa capacidade de mobilizar a ciência, a clínica e a cidadania tornaram verdadeiramente possível a concretização deste evento. O vosso trabalho é em si mesmo uma afirmação ética, porque dá visibilidade a uma condição que durante demasiado tempo permaneceu escondida. É realmente um gesto de grande responsabilidade, mas também de coragem. Eu queria deixar uma mensagem clara, em meu nome e em nome da Ordem dos Médicos. Esta conferência é mais do que um programa científico. É um ato de verdade. A encefalomielite mialgica e a long COVID são realidades, nós sabemos, muito complexas, exigentes, profundamente limitadoras para muitas pessoas, mas continuam, infelizmente, a enfrentar o desconhecimento e a incompreensão. E são precisamente eventos como estes que rompem esse silêncio, transformam o que era invisível em conhecimento, em reflexão crítica e também, porque é importante, em caminhos de esperança. E tudo isto, e muito mais que tem feito, merece o nosso reconhecimento. Quero, por isso, reafirmar o total apoio da Ordem dos Médicos e de mim próprio. Um apoio institucional, científico e humano. Estamos presentes para escutar, para aprender, para acompanhar também. Podem sempre contar com a Ordem dos Médicos para divulgar este conhecimento rigoroso, para promover formação atualizada e para criar pontes entre a investigação e a prática clínica. Para trabalharmos em conjunto, todos, com as autoridades de saúde, com as associações de doentes, na construção de vias de cuidado que possam dignificar as pessoas, mas também apoiarem os médicos que estão no dia a dia, no terreno. Durante demasiado tempo, acho eu, estas doenças estiveram no território do invisível. Por isso, reconhecer o sofrimento de quem vive com estas patologias é um dever ético. Dar respostas organizadas é uma responsabilidade do sistema e tratar cada pessoa com respeito, com cuidado, com prudência clínica e empatia é isso também verdadeiramente a essência da medicina. A intolerância ao esforço, a fragilidade funcional, o impacto multissistémico, tudo isto exige uma atenção, uma escuta atenta, um olhar clínico mais informado e uma abordagem que possa não causar dano, mas que esteja orientada para o tratamento. Exige também que apoiemos os médicos e todos os profissionais de saúde que acompanham estes casos, oferecendo-lhes mais conhecimento, mais instrumentos, mais segurança para poderem decidir e decidir adequadamente. A medicina, muitas vezes, melhor dizendo, a medicina, de forma permanente, pede-nos coragem. E neste caso em concreto, a coragem de mudar práticas quando a evidência assim o impõe. A coragem também de reconhecer limites. E ainda assim, não desistirmos. A coragem de colocar sempre, sempre, a pessoa no centro de todas as nossas preocupações. Esta coragem está nos médicos, nos investigadores que desafiam os paradigmas, nos médicos que se atualizam permanentemente e que se dedicam nas famílias que, melhor dizendo, para nunca desistirem. E, sobretudo, nas pessoas doentes que enfrentam estas condições com uma força, com uma dedicação absolutamente admirável. É preciso mais informação, mais literacia, maior sensibilização. Por isso, a todos o que organizaram, participaram e partilharam estes conhecimentos neste evento, o meu sincero e profundo agradecimento. Mas, principalmente, aos doentes e às suas famílias, deixo esta mensagem simples, mas firme e determinada. Vocês não estão sozinhos. A vossa causa é também a nossa causa. Podem contar conosco, podem contar com a Ordem dos Médicos. Muito, muito obrigado a todos vós.
So before we go, Joan asked me to make some closing remarks, and I would use the same words as our bastonário, saying that we deserve a lot to Joan and to the Aliança Millions Missing for breaking the silence in this disease and ME and long COVID in Portugal, and being such a magnet to attract so impressive researchers from across the globe, and making possible that we as clinicians learn more from their expertise, and also gathering patients here that is also an inspiration for our practice. So we also are thankful to everybody that were chairing, everybody that were in the back at the multimedia. So also the people that were at home. So wish you a good trip back to your homes. And I hope that you can enjoy still a little bit of the flavor of Porto. Why not having a port wine and take a bottle with you to home? And I hope to see you soon. I'm sure that we will have the sponsorship of Ordem dos Médicos, because our bastonário was very, very positive for supporting this initiative for next year. So I hope to see you again next year. I don't know where. Joan, I don't know if you want to unveil the location. Will it be in Coimbra or Lisbon again? Not yet. Okay, so I'm sure that the next conference will be even better. And I think I have to say that this was one of the greatest conferences that I have been here in Portugal in my whole life. So congratulations. A big round of applause for Joan and all the team.